series. As always, we pride ourselves in offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available. But please use the all-access pass if you need to claim CME credits. Thank you so much.
And we're live in 5,
4, 3,
2,
1.
I wanted Gary to do that live. Well, good morning. Am I live? Okay, good morning, everybody. I want to thank you all for watching Seattle Science Foundation and for being here. And I'd like to welcome you to the 10th Annual Innovative Approaches to Brain Tumor Management. We've been running a course here every year for 10 years, and we've had an amazing representation of top neurosurgeons, neuroscientists, neuro-oncologists, cancer researchers, and our goal is to try to tap into some of the up-and-coming clinical and research projects and focuses that are moving the field forward in neuro-oncology. I'm thrilled to represent the Ben and Catherine Ivy Center here, which has a clinical translational lab here at Swedish Neurosciences Institute. I'm thrilled that I have colleagues at Swedish here with a huge amount of expertise, Dr. Zachary Litvak, Dr. Alippi Bonham, Dr. Miri Kim, one of our new members of the Ivy Center and Neurosurgery and Neurosciences here at Swedish. And today we have a great group of people giving talks on various topics. Let me just thank all the people who have allowed us to have this meeting. We have representation from many sponsors, including Integra, Longevity, Medtronic, Merck, Monteris, Stryker, Telix Pharma, and Zap Surgical. We greatly appreciate their ability to help have this conference. This course is being recorded and will be available on ssfyoutube.org. And there are options for getting CME, and there will be a slide about how to get CME. So I'd like to move to our first speaker, Dr. Prakash Ambati, evaluating the safety and efficacy of intra-arterial chemotherapy with osmotic blood-brain barrier disruption in treating brain tumors. Do you want to do an introduction? Thank you.
Good morning, everybody. I'm Alippi Bonham. I'm a neuro-oncologist here at Swedish. It's my pleasure to introduce Dr. Ambati, who I've known for a couple of years now. He did his initial training, got his MD in Pondicherry University, and then a residency in neurology at Drexel, and then did a fellowship, I think it's a several-year fellowship at NCI and Johns Hopkins, where he became quite interested in management of CNS lymphoma and also novel imaging modalities. And then went to OHSU, where he was for, I think, 5 or 6 years, and led a really robust research program there focused, again, on CNS lymphoma, including an independent investigator-initiated trial that he's leading and that we are now participating in on the role of maintenance of obinutuzumab after any first-line therapy. He's also had a very active research program in blood-brain barrier disruption and treatment protocols, and is going to talk with us about that today. So thank you for joining us.
Thank you so much for the kind introduction, and thank you for this invitation. Um, as LP mentioned, my talk is going to focus on the safety and efficacy of um, osmotic blood-brain barrier disruption after intraarterial delivery of chemotherapy. I don't have any relevant financial disclosures. This is kind of the layout of my talk today. So what exactly is the blood-brain barrier? So we have known about the blood-brain barrier for a very long time, and now the term blood-brain barrier is specifically used for the tight junctions and the unique tight junctions in the brain. And these are tight junctions between the endovascular cells and the small blood vessels. And in conjunction with the end plates and uh, the pericytes and the small basement membrane, we now call it the neurovascular unit. So the tight junction is actually made primarily by the claudin and occludin, which is pretty tight. And as you can see here in this electron microscopy image, there's this lanthanum dye, and the lanthanum can come in till the end of that tight junction, and then nothing passes through that. So we have known this for a very long time, and it's been a great challenge to get drugs into the brain. Now, specifically in terms of the blood tumor barrier, this is a very robust study from the Lockman lab, where they looked at brain metastasis, which is very leaky. And our typical thought is, well, brain tumors are enhancing, especially the brain mets and the high-grade gliomas. So most likely the chemotherapy drug should get in. But in fact, what Dr. Lockman and his team showed was that even in very leaky brain mets in their breast cancer models, the average permeability of radioisotopes was only 2 to 5% of the peripheral breast tumors. And even in the most leaky tumors, in their model, they injected tumors into the ventricle, and then they had like a spurt of tumors within both hemispheres, and they picked up the leakiest tumors and the non-enhancing tumors as well. And even in the leakiest tumors, the permeability was about 12% that of the peripheral breast tumors from the same origin. And in a follow-up to that same study, they did another experiment where they looked at paclitaxel concentration in the brain metastasis, and this was also noted to be 3% lower compared to systemic tumors. So even in leaky tumors, very leaky tumors, we don't get good drug concentration. Now, there are a lot of clinical challenges that we face as well. And like I mentioned, drug delivery remains a big challenge. And if you look at all the drugs that are available to us, especially the small molecule inhibitors that have worked really well in some of the other cancers, 98% of these small molecule inhibitors do not cross the blood-brain barrier. Even those that do eventually cross the blood-brain barrier, they are actively pumped out by P-glycoprotein pumps. And then, of course, the blood-brain barrier is there for a reason, and that is to prevent things that the brain doesn't like not getting into the brain. So by enhancing delivery, we may actually cause more toxicities to the brain. Now, in the era of immunotherapy, there's a lot of interest in looking at immunotherapy approaches for brain tumors. And we now know that there is a brain immune barrier that prevents a lot of immune cells from migrating in and out of the tumor cells in the brain. And there's also this paucity of the traditional lymphatic system, but now we are learning about the lymphatics that may have some implications and may give us some opportunities to explore. An additional problem with the blood-brain barriers is that because of the unique microenvironment, there's no really good antigen-presenting cells. So, and it's also, like we all know, brain tumors are composed predominantly of strong, especially the glioblastomas, very strong immunosuppressive myeloid-derived cells. Now, in addition to delivery and the unique tumor microenvironment, we run into another big challenge, and that is response assessment. Right now, our gold standard for response assessment is gadolinium-enhanced MRI scans. It is a great test, but it's a great test, a very sensitive test for blood-brain barrier disruption, but not very specific for the etiology of the blood-brain barrier disruption. So, for example, after radiation, we know there's a phenomenon called pseudoprogression, where the blood-brain barrier is disrupted, the contrast leaks out more, and in the traditional sense, we would be leaning towards this being tumor progression, whereas in fact, this is an inflammatory process, or we believe is an inflammatory process that eventually subsides and patients then do well. Similarly, drugs that target the blood-brain barrier, especially the VEGF inhibitors like bevacizumab, can make the contrast leak go away or reconstitutes the blood-brain barrier, and hence may make the tumor look smaller, which was the classical study with bevacizumab. Just to give you an example, we have frequently seen low-grade tumors or non-enhancing tumors that we all thought, oh, well, this is a low-grade tumor. But once we biopsy it, we see that it is a grade 3 tumor. Similarly, with the CDKN2A deletion, we see a lot of non-enhancing tumors that eventually are classified as high-grade tumors, and they progress really fast. Even in high-grade tumors, the enhancement is actually quite small compared to the extent of the T2 signal abnormality. So the contrast enhancement is a reflection of the blood-brain barrier disruption and not reflecting the true extent of the tumor. Now, how can we put in intraarterial chemotherapy and osmotic blood-brain barrier disruption into perspective, and how can we justify the use for this in our patients with brain tumors? So this procedure itself was described first by Stanley Rappaport at the NCI as early as 1971. So in the clinical practice, this was kind of developed quite extensively by Professor Newelt at OHSU, who I had the pleasure to work with for a long time. Technically, this procedure involves catheterization through a peripheral artery and then leaving the tip of the catheter at the C2 level, followed by delivery of hypertonic 25% mannitol intraarterially, and then we give the drug, which in this case is a chemotherapy agent. And, this is a very simplistic model of how the blood-brain barrier disruption works. So these are the endothelial cells, and these are the tight junctions. And when we give the hypertonic mannitol, there's an osmotic shrinkage of these tumor cells, resulting in almost tearing apart of the tight junctions, resulting in passage of the contrast agent or chemotherapy in this case across the blood-brain barrier or the tight junctions of the endothelial cells. Now, in the clinical practice, just to give you an overview of how we did this in our patients, patients were brought into the angio suite. They were given general anesthesia, usually propofol is preferred. And I'm not going to the detail. Multiple anesthetic agents were evaluated, and we found propofol to be the most effective in patients receiving osmotic blood-brain barrier. The catheter was passed femorally, and we've switched. Usually, the patients receive 2 consecutive days of osmotic blood-brain barrier disruption intraarterially, and one femoral artery was picked on one day, and then the other one was used the second day. And then, like I mentioned, hypertonic mannitol was used, and it was delivered between 3 to 12 ml per second for about 30 seconds to achieve disruption. After disruption, chemotherapy was delivered over the next 10 minutes as an infusion using a pump. And in some cases, IV chemotherapy was used, and in those cases, IV chemotherapy was given right after induction of anesthesia so that the drug is actually present in the systemic circulation when the barrier is disrupted. And then immediately after disruption, the patient is still intubated when we actually get a CT with contrast to kind of assess the amount of disruption and quantify the amount of disruption. So this is kind of the animal models below on the left side, and then the osmotic blood-brain barrier CT and radionuclide imaging guidelines we use for quantifying disruption after the procedure. So as you can see, the disruption is peak in small animals. Within a few hours, it kind of starts getting better, and by 96 hours, the blood-brain barrier is almost back to normal. In the grading scale, we use no disruption, moderate, good, or excellent disruption based on this validation paper that was presented about 10 years ago. In the clinical setting, we do not see contrast leak after the procedure more than 1 hour after we disrupt the barrier. So now we know what the procedure looks like in general. So how do we justify it by looking at our preclinical models? So most of this work was done in the Newell's lab, and Leslie Muldoon has been kind of the pioneer in looking at the preclinical models. So figure A is intraarterial administration of methotrexate in patients in rat models. So the blue describes the gray matter, and the red or orange describes the blue describes the intravenous administration, and the other one describes the intraarterial delivery. So as you can see, there's a significant increase in both the gray matter as well as the white matter when compared to IV alone. And as we know, the vascularity in the gray matter is significantly higher than the gray matter, and that's why there's this differential between the gray matter and white matter disruption. Now, in the tumor, also we see IV versus IA, there's a significant increase. But what's also interesting is the non-enhancing tumor, or the brain around the tumor, also had a significant increase in delivery of these drugs. And just with intraarterial delivery, we can get up to 5 times more delivery compared to just IV administration of the same drug, methotrexate. Now, on top of the intraarterial delivery, if we use hypertonic mannitol, it increases delivery about 100-folds as seen in these pictures. So the blue again is IV, the red is the IA, and then we have IV with blood-brain barrier disruption, and then IA with blood-brain barrier disruption, which is our goal to kind of do. So in this study, again, we can see that there's a significant increase in drug delivery, in this case methotrexate, after blood-brain barrier disruption compared to just IV, IA, or IV delivery after blood-brain barrier disruption. And again, there was a discrepancy between the gray matter versus white matter in terms of disruption. It is the proportionality that we are looking at here. Now, if you look at the time course, you can see that immediately after disruption, there's a big increase in drug delivery, and then it kind of drops within 45 minutes. It comes to about half, and then 120 minutes, it comes to like 1/4 or less in this animal model. Histological studies did not show any demyelination or signs of injury or strokes in these animal models. So this suggests that osmotic blood-brain barrier delivery does increase drug delivery quite significantly. And in the previous couple of slides ahead, I had shown that even in non-enhancing tumors and enhancing tumors, there's a paucity of drug delivery compared to systemic tumors, and this could overcome some of that. Now, obviously, the biggest concern we have with this procedure is that it is an invasive procedure, and what is the safety data? So the first safety data was published by the Newell group they looked at patients who received osmotic blood-brain barrier disruption between 1994 and 1997 at 5 university hospitals. And at that point, 221 patients had received 2,464 procedures. And these are the pathologies for which these procedures were done. And the number of procedures, each patient got 2 days of disruption back to back, and they got up to 12 cycles of the chemotherapy on these studies. So in those patients, we had very limited number of toxicities. The highest number of toxicities we saw at that time was the deep vein thrombosis, and then we started modifying our protocols for deep vein thrombosis prevention, because a lot of these patients with brain tumors already were at very high risk for deep vein thrombosis, and we were stopping their heparin and Coumadin for the procedure. So that was probably the reason, and then we started resuming the heparin drip immediately so that we didn't have this problem. There were 3 deaths reported in that study. Most of these deaths were related to procedure-related deaths, where one due to one case of sepsis that was eventually attributed to the procedure. But for that patient, he did develop quite significant immunosuppression, most likely from the chemotherapy. And then there were 2 cases of pulmonary embolism that caused death within 30 days. All the other cases were attributed to progressive disease within the first 30 days. And just to note, these were patients who had been previously treated extensively, and they didn't have many options at that point. Now, in the follow-up paper, we looked at the procedures that were done between 1997 and 2018, and a total of 436 patients were included in this study, with a total of about 5,000 procedures, of which about 1,000 were just intraarterial chemotherapy, and about 3,800 were IA with osmotic blood-brain barrier disruption. And again, the median age was as small as 1 year, and the oldest patient that was treated in this cohort was 82 years old with primary CNS lymphoma. And as you can see, these are the number of patients with various pathologies that were treated. Now, again, we looked at the risks of side effects and toxicities within 30 days. The highlight of this was the major complication rate was very, very small. Just with intraarterial chemotherapy, the risk was about 1.09%. With osmotic blood-brain barrier, the risk was actually even slightly lower, it was 0.7. And for minor complication, it was about 3%. With IA, and about 8% with IA with disruption. Now, in the previous paper, there was some concerns about seizures happening, and we had modified our protocol where patients were, because they were kept NPO, we went back into our charts and noticed that patients were not getting the morning dose of the seizure medication before they were being moved to the angio suite. So we put it into the protocol so that patients would get their first dose of intravenous Keppra at the time of procedure, at the time of anesthesia. And the risk of seizures were also within the first 30 days were noted here. And most of these cases happened with methotrexate, which is a very known agent that can be a very epileptic. We did, however, see some cases with the carboplatin. None of them transitioned to status epilepticus. They were all treated with a dose of Ativan, and most of these were focal seizures. Now, yes, it seems to be, and if you, in that paper, we also talked about comparing the risk versus a traditional angiogram, a diagnostic angiogram versus this procedure, and there was no significant difference in the risks with similar numbers of retrospective review of other papers. We did not see any significant increase in risk from the procedure itself. Now, in terms of the clinical efficacy, the first paper that I would like to quote here is from the 2009 paper from Angelov et al., where they looked at primary CNS lymphoma patients who were treated, newly diagnosed primary CNS lymphoma patients who were treated with IA-BBPD. As you can see, 149 patients were enrolled in this cohort. Interestingly, objective responses were seen in about 81% of patients, with a complete response rate nearing 60%. And this is without rituximab. So this is before the era of rituximab. And these patients did not get radiation at that point, which was considered standard of care at that point. Now, if you look at the Overall survival, the median overall survival was about 37 months, which was pretty impressive. Even when you look at the contemporary data that was available prior to the rituximab era. And now, if you look at the low risk groups, which is the Memorial Sloan Kettering risk assessment scale, the median overall survival was up to 14 years, which is quite impressive. And this is without radiation and without transplant. Now, in that cohort, patients were much younger as well, so that could have biased this. Median overall survival in the low risk, because performance status and age are part of that risk group as well. Now, one of the biggest concern at that point was radiation, which was the standard of care up till the 80s and 90s for primary CNS lymphoma. There was a lot of neurocognitive impairment, and we've tracked them over time in patients who got osmotic blood-brain barrier disruption with a series of batteries of tests. In those studies that was published in JCO in 2013, Doolittle et al. Demonstrated that in majority of patients, there was actually an improvement in these battery scores. Most of them remained stable. And of course, there was a small number of patients who had a small decline over time. Now, is there any data comparing IA versus IV using high-dose methotrexate? High-dose methotrexate now being the standard of care for primary CNS lymphoma. So we looked at our data and compared it with the data from the German groups to see if there was any comparative analysis we could do. Now, obviously, IV patients, there was a significantly larger number of patients who received IV therapy compared to IA. And what is obvious in this study is that the CRR rates, or the response rate, was about 35% in patients less than 65 years, which was about 60%, almost double, in the IA group. And this is actually more impressive in patients who who are over 65. And the response rates, whether it was less than 65 or over 65, was very similar in the IA group, whereas it is clear that the IV group, there was a decrease in overall response rates. So there was an ongoing study where we looked at osmotic blood-brain barrier disruption using methotrexate, rituximab, and carboplatin in patients with newly diagnosed primary CNS lymphoma. We presented our initial data at the ASCO 2023. So these are patients who qualified for a diagnosis of primary CNS lymphoma based on the IPCG criteria. Patients received IV rituximab the day prior to the disruption. So rituximab was not given during the disruption. It was given as a 5-hour infusion, traditional infusion IV. And then the next day, we took them to the angio suite, and then we did the procedure, and patients were given methotrexate and carboplatin over 10 minutes on 2 consecutive days. And this was repeated over 12 cycles. So patients received up to 12 months of this therapy. We also used sodium thiosulfate as a chemoprotectant to prevent hearing loss because of the use of carboplatin. This was a study that was developed based on the preclinical data that suggested that high doses of carboplatin into the brain can cause hearing loss, especially in the small kids or young adults. The hearing loss is not complete, but it is a high-frequency hearing loss. Now, based on the follow-up studies that we did based on 2 randomized phase 3 trials, sodium thiosulfate is now FDA approved as a chemoprotectant based on the work that we have done here in Portland. And then, unfortunately, during the COVID pandemic, there was a staff attrition, and we had to eventually stop the study at that point. But at that point, we had enrolled 20 patients, which is quite substantial, even for considering that primary CNS lymphoma is an extremely rare disease. The study was done over 3 sites, and most of the patients were enrolled at OHSU at that point. On the 16 of the 20 had evaluable scans and follow-up. 3 subjects were not evaluable, 2 because of withdrawal of consent, and 1 at an outside site unfortunately died of a completely unrelated cause, not related to the study at all, involving an accident. So in this cohort, an impressive progression-free survival of about 55 months were noted, and the median overall survival was about 82 months or almost 83 months. And the median duration of CR was about 51 months in these patients. And all 16 who are evaluable eventually got into complete response. These data suggest that the osmotic blood-brain barrier disruption in primary CNS lymphoma is quite effective, comparable to the matrix and other established protocols without the need for transplant or radiation. Our data was further validated by our colleagues in Finland. They collaborated with us in kind of optimizing the procedure itself. So this protocol they used was slightly different because they achieved induction with a matrix regimen and then gave osmotic blood-brain barrier disruption. And they found very similar outcomes, although not as good as ours, and could be difference in the technique and the population, but they got about 70% 2-year overall survival rate with a 2-year progression-free survival of about 70.3%, which is significantly better than most other studies that we have. Now, outside primary CNS lymphoma, we have done a couple of studies in recurrent refractory or unresectable pilocytic astrocytomas. In this paper that we published, about 11 patients received intraarterial chemotherapy, and 1 complete response was attained, and 3 partial response and 7 stable disease. 1 patient unfortunately did progress with a median progression-free survival of about 16.5 months and a median overall survival of about 83 months. Now, this is one of the cases I like to present all the time because this patient came in with a large chiasmatic lesion, presumed to be a pilocytic astrocytoma. Could not be biopsied, was losing vision, and then the patient went on to sign the consent. Parents consented, and patient received IA carboplatin, IV etoposide, and IV cyclophosphamide, eventually attaining partial response. The patient is still alive and has recovered all his vision and continues to do well. Now, the advantage of intraarterial chemotherapy, one is because we are using a C2 as our point of delivery, we are able to get a regional disruption rather than very targeted disruption as we would get with the selective arterial disruption as done in some other centers. In this picture below, we can see that this is a patient with primary CNS lymphoma before disruption, and then adjacent to it is a CT scan where we got it after disruption within an hour, and you can see that the disruption involves the whole hemisphere and actually crosses into the other side through the circle of Willis as well. So in diffuse tumors like CNS lymphoma and glioblastoma, where we know the tumor extends far beyond the enhancing component, this is an ideal way to get drugs in, even into the brain around the tumor. Our data suggests that we can safely do this over multiple doses. So that means, unlike certain other procedures where we can do it like 1 or 2 times, intraarterial delivery can be repeated every 3 to 4 weeks and can be done up to 12 months consecutively. The other major advantage that we see, especially with drugs like methotrexate, is that this first pass advantage that we get with intraarterial delivery. When we give drugs intravenously, most of it is actually delivered to the liver first, and then eventually gets into the arterial system and then goes to the brain. So when we give it intraarterially, we get the first pass into the tumor. This is really important for small, short half-life drugs where, if you can get a very high concentration in the first pass, that is significantly better than a second pass or a third pass. Now, we also have some very strong, compelling data that when we give T cells, especially CAR T cells or tumor-infiltrating lymphocytes, these are sequestered primarily in the lung for up to 70 hours before it eventually migrates. We could actually change this by giving it intraarterially. And then, of course, off-target effects, because now we are able to get high concentration in the tumor. We are able to use significantly lower doses of the similar chemotherapies, so myelotoxicities and other organ damage can be prevented. Now, another major advantage, this is a paper that was published in 2021, where it looked at animal models and looked at the immune response to osmotic blood-brain barrier disruption and compared it with focused ultrasound in a separate paper as well. And as you can see, and the red marks are the inflammatory cytokines, and there was an increase in local pro-inflammatory cytokines and chemokines, as well as neurotrophic and neurogenic factors, with a peak about 6 to 24 hours, and almost returned to baseline by 4 days after osmotic blood-brain barrier disruption. This data was very strongly suggestive that there is a transient activation of the local innate immune response based on the cytokine analysis, and this is where we're going in the future, where we could then augment or potentially augment immunotherapy approaches using this drug delivery intraarterially with osmotic blood-brain barrier disruption. Now, how do you translate this to the general population? Of course, there's, when a new procedure comes in, there's always people who are skeptical. I think we have demonstrated safety and preliminary efficacy, and then I think our next step is to develop it into other tumor types and different chemotherapy agents. Perception and fear is probably the biggest factor in translation of this procedure, which I think can be overcome. And then, of course, expertise and cost. So smaller centers may not be able to do the intraarterial procedures. And of course, insurance coverage can be a challenge, but in the proper settings, insurance do cover these procedures. And then the other issue is multi-DTs. Teams are necessary, and buy-in from medical oncology teams and all those things is necessary. And of course, angio and anesthesia time. Now, the flow dynamics is another consideration, especially when we are using the vertebral artery as our route of delivery, because sometimes drugs can actually go into the anterior spinal artery and can cause myelitis. And then with certain agents, we have to be very cautious about toxicities. For example, platinum-based agents, especially cisplatin, causes a lot of ototoxicity. It's well known, but that is augmented when we give it intraarterially. But this can be prevented quite effectively, as we had shown in the recent FDA approval of sodium thiosulfate when we used carboplatin. And then when we try new drugs, there's always this question about preclinical models and drug delivery, validating those things are really important. Now, future directions for us, now, especially with the advent of immunotherapy and cellular therapies, we are working towards capitalizing on the change in the local innate immune response after osmotic blood-brain barrier disruption. And we are also working towards delivering novel agents like synthetic mRNA and cellular therapies, CAR T cells and lymphocytes. And we had previously used oncolytic virus delivery as well. So you could actually do repeated delivery of oncolytic viruses using this approach rather than direct intratumoral injection or delivery during surgery, like has been shown in some other studies. There are also non-oncological applications that are being evaluated by various other groups, including for dementia and delivery of gene therapies. And then other areas that we're looking into is flow diversion and slowing down the rate of using balloons. Selective intraarterial therapies, certainly something that we have to look into. And then the venous system in the brain is also an interesting target where we can actually pool some of the blood drugs there for a longer period of time. And then, of course, we have been focusing on the femoral artery approach, but radial artery approach can make things quite significant, and this can be done on a day procedure basis, depending on what drug is being used. So thank you again for inviting me here. This is the team that I work very closely with. I continue to work with the team at OHSU, and then, of course, the interventional neuroradiologist and the team at Providence Brain and Spine Institute that allow me to continue the work that I've been doing. Special thanks to Dr. Ulip Kudle for putting together all the data that was shown in the safety paper, and Nancy Doolittle for all the efficacy work, and of course, all the staff that work with me today. Thank you.
Thank you, Dr. Ambati, for that wonderful talk. In the interest of time, I just want to give Dr. Litvak a chance to ask one question.
Yeah, Dr. Ambari, thank you for a tremendous overview of over 30 years of work. And I had the privilege of working with Dr. Newell when I was in training down at OHSU. I'm curious, you mentioned some of the challenges. What do you think the biggest hurdle is that's holding people back from adopting this as something closer to standard of care for CNS lymphoma?
So, as I pointed out, I think the buy-in from our medical oncology has been the biggest challenge. And that's my biggest concern. Now, insurance authorization can be a challenge, but we have not had that being a big issue here. Obviously, a randomized trial would be the next step. And getting it into NCCN guideline would be the next step for us to kind of say this is now the standard of care.
Thank you very much. I'd like to introduce our next speaker. Dr. Nicholas Vitanza is somebody I've known for a number of years now. I knew him during training. He completed his residency at NYU, and I think was actually part of a COG, Children's Oncology Group trial while in residency, and then went to Stanford to complete a pediatric neuro-oncology fellowship. Then did a postdoc in the lab of Dr. Michelle Manji, who's known to us from her prior talks here and is well known in the community, and ultimately joined Seattle Children's in 2016, where he leads his own laboratory within the Bentown Center for Childhood Cancer, and has been leading some very exciting clinical trials of CAR-T for diffuse intramedullary pontine glioma, diffuse midline glioma, and I think that's what we're fortunate to hear from him about today. Welcome, Dr. Vitanza.
Thank you very much for the invitation to speak and for that kind introduction. Hopefully that's showing up for you all okay. Please let me know if it isn't.
You want to switch the presenter view up at the top? You can swap. Perfect.
Okay. Great. Okay. Thank you very much. So yes, I'll be talking about also intracranial delivery, but this will be talking about CAR T cells delivered mostly intraventricularly. And like Alipi mentioned, I've been leading our CAR T cell trials here, which when they started were the first in the world, and now are still the highest enrolling. And excited to share some of our experience. Just as a disclosure, last year Seattle Children's spun out some of these technologies into a company, and I serve as one of their advisors. So I think a lot of you are probably familiar, but CAR T cells are essentially removing a patient's white blood cells, specifically their T cells in this instant, adding an extracellular antibody domain, an intracellular signaling domain, which you can play with a lot, so that you can ultimately recognize a target. This has been most used for attacking tumors, most famously leukemia, but actually now we have a pediatric lupus trial, which I think is getting fast track approval now, another company developing that for adults. So there's a lot of applications for this technology. But a lot of these technologies before 2016, when I got here, were using the paradigm that you do a systemic leukapheresis, you engineer the cells ex vivo, you grow them up into the hundreds of millions, and then you infuse them back into the blood, which at least in the case of children and adults with leukemia is exactly where the tumor is and the easiest compartment to access. So all of that would make sense. As it was alluded to in the previous talk, that doesn't always make sense for the CNS. So when they're thinking about what are ways to get CAR T cells into the brain, obviously viability is an issue, other things. So certain catheter systems, certain length of time, other things don't work very well. But what City of Hope was able to design was a system where with a quick thaw and a delivery, you could do, even as an outpatient, intracranial delivery, either intratumoral through a catheter or intraventricular, most often through Omayas, but not particularly novel technology. And that simple route of delivery would actually allow you to give repeated infusions, some of which were very frequent, and they were seeing radiographic responses and tolerability when targeting IL-13 receptor alpha 2 in adults with glioblastoma. So that really inspired me to move towards immunotherapy, as so many molecular targeting approaches of tumors were failing. And Seattle Children's was a leader in this and had already developed multiple leukemia trials, including the first published pediatric leukemia experience along with CHOP, showing a great response rates targeting CD19. And then Naveen Pinto and Julie Park and Mike Jensen had also moved to a solid tumor trial. And so when I came, I was tasked with writing and directing our CNS program, which at the time Baylor had a program that was dosing IV, but nobody in the world had an intracranial program at that time. Obviously borrowing a lot from our previous experience, but then also relying a lot on City of Hope and Christine Brown's experience. When we were looking at what antigens to target, it wasn't the exact same list as adults. Obviously, pediatric tumors don't have the same antigen expression as adults. They're, less commonly hypermutant, much fewer alterations. And the list of things we had to target was very different. Some things are similar to some other diseases like HER2, obviously on breast cancer, EGFR on some glioblastoma, and B7H3 was coming out through work of Mark Sudain and others, that this, also known as CD276, was a highly relevant target. So based on some CAR T cells Mike Jensen had already developed in a rank order based on expression of tumors, we planned for 3 initial single antigen targeting trials. And these started in 2018 with Brainchild 1 and Brainchild 2 targeting HER2 and EGFR respectively. And essentially the system was children would come to Seattle, they would enroll, they would get apheresis. That whole process takes about 3 days, and then they would return home. We start CAR T cell manufacturing, which takes about 10 days to manufacture, 14 days of quality testing. And at that time, children would go into an arm with either localized delivery with an Ommaya catheter into the tumor or into the ventricular system. And probably outside of the timing available for this talk, because you have a much different immune compartment on the brain, there's nobody that's been shown, and probably from a toxicity perspective would not even want it, to have persistence of cellular immunotherapy in the brain. You do a repeated infusion strategy. There's some adult trials that just do 1 infusion now, mostly looking at safety, but we felt that to really offer children a chance of benefit, you would need repeated infusions. We also felt that children should be able to get their own dose escalation, so we use a intrapatient dose escalation. And essentially Brainchild 1 and Brainchild 2 were the same system, where after cells were manufactured, children would come back to Seattle and then get weekly infusions of intra-Ommaya as an outpatient. I'll show what the procedure looks like in a moment. It's actually, despite at the time, nervously sitting outside all of these kids' room and basically be on call 24 hours a day for 3 years, it ended up being less dramatic to do this delivery system than even IV dosing, and potentially better toxicity profile. So this was the program that we developed targeting HER2 and EGFR. We published some preliminary results. And really the first thing that we noted was our first 3 patients were subject 1 who got an intratumoral delivery for an extremely large GBM, a patient S2 who got intraventricular dosing for metastatic disease, and then S3 was another intratumoral. And so what we learned from these 3 patients is, even though it was the minority of these first 3, which has become very clearly the majority of the now over 150 kids we've enrolled and over 800 doses we've given, is that this is the profile we see most often, which is that with each dose, you get metronomic headaches, sometimes fevers, but otherwise you get very little neurologic toxicity. About 10% of patients have worsening of a baseline symptom that they have, which most often resolves in the same window of the headache, which is starting about 8 to 12 hours after infusion, resolving within 24 to 48 hours. This is what it looks like to give this. In pediatrics, we don't use Omayas very often. So actually, when I enrolled our first patient and gave our first dose, I had never interacted with an Omaya before. but now it's our day-to-day. But essentially, you clean the area. We put in a butterfly needle the same way you would to start an IV anywhere else. We take off about 10 cc's of CSF. We thaw the CAR T cells, which have been, instead of one large product like you do for leukemia, are fractionated into individual doses. That's about 2.5 mLs. We infuse it, takes about 3 minutes. We flush it with 2.5 milliliters of preservative-free normal saline. We pull out the needle. The whole thing takes about 4 minutes. That's the intracranial CAR T cell delivery. We do this as an outpatient, and children don't even have to spend the night in the hospital. What the first two trials didn't include was children with diffuse intrinsic pontine glioma, which Alippi mentioned is what my lab focuses on and what are most of the patients that I take care of and give guidance kind of nationally and internationally on. So we were enthusiastic to start enrolling them, but waited for this initial experience before we did. For people who don't see these tumors, there's about 400 of these patients a year in the United States. It makes up about 8-10% of pediatric CNS tumors. Unfortunately, has a median age of 7 and a median survival of a year. So when you add all this together, it's responsible for about 25,000 years of potential life loss just every year in just the United States. What multiple groups, including Mark Soudane, Robbie Masner at Stanford, Dalia Haidar had showed at St. Jude, B7H3 is highly expressed on a range of CNS tumors and not on normal CNS, and in particular was the most consistently expressed on DIPG, although GD2, which we don't target as a group, but other teams like Stanford do, it can be more highly expressed. B7H3 was the most consistently expressed. When we looked in our own models in our lab, these are 4 patients with DIPG who had biopsies here in Seattle, came across town, some biopsy samples here to be grown in mice and in cell culture, and we're able to develop models that we share nationally and internationally. We also found super high B7H3 expression, as we would expect. And so when we opened Brainchild 3 using this B7H3 targeting CAR, and I won't get into all of the engineering structure, but a couple cool things about this CAR is it was the first CAR that we put into practice that had the methotrexate resistance gene in it. So during manufacturing, we can introduce methotrexate for purity of the project instead of other sorting mechanisms. And when we looked at this preclinically, without going into all this because it's published and multiple groups have B7H3 CAR T cells that are very effective, these are just cell proliferation assays that we do in our lab looking at incucyte. Even at very low effector to tumor ratios, CAR T cells are able to completely wipe out DIPG cells. And for people who work with DIPG or glioblastoma in the lab, basically most of work that you're publishing is 10-day survivals, 15-day survivals, maybe a 20-day survival. CAR T cells are the only thing, granted with lots of limitations in the model system because they're immune incompetent, are the only things that completely eradicate disease. So this is a DIPG model in mice with about 100-day survival. When we give 1 dose of intracranial CAR T cells, we're able to effectively wipe out the tumor in all of the mice and make them long-term survivors out to day 300, their natural life. So while this isn't proof that a single dose, I think, will be curative for anybody, it's a biologic proof of principle of the effectiveness in an in vivo system. And from there, I'll talk specifically about results that were in a Nature Medicine paper that just came out a few weeks ago, because while we have a broader experience across 4 trials now, children with DIPG really sadly have a very specific course. And so it's sometimes easier to draw some conclusions about what their treatment has been like. So when we opened Brainchild 3, which is our B7H3 targeting CAR T cell trial, we had the same localized arm, we had the same recurrent refractory metastatic arm, but we added a new arm, arm C, for children with DIPG. Again, intraventricular dosing, thinking the lateral ventricle is flushing through the third ventricle and around the pons, so we're getting CAR T cells relatively locally. The only way to dose directly into the pons, although plenty of sites do it with CED, requires a heated long-term pump system that just is not compatible with CAR T cell viability. So that's not even a possibility with current technologies, but we were happy with the intraventricular approach and moved forward with that. We had the same enrollment apheresis manufacturing strategy as described before, only instead of dosing weekly with this cohort, out of concerns for some increased toxicity. Before this trial opened, there were actually a few immunotherapy trials for DIPG that had closed early due to deaths. So we dosed every other week. In our first group, we did not do an intrapatient dose escalation starting at 10 million cells. But after that, all the other groups had intrapatient dose escalations getting up to 100 million cells. And this is just looking at the eligibility. A couple things notable. A lot of studies for children with DIPG don't allow metastatic disease, don't allow previous reirradiation. Some don't even allow progression. Some don't allow even extent outside of the ponds. All of those things really frustrate me as somebody who interacts with a lot of these families. So we tried to make it as easy as possible with relatively loose enrollment criteria. This is just a consort diagram of our trial showing the kids that were in dose regimen 1, 2, 3, and 4, with probably just for the scope of time here, I'll say we were able to get up to the highest planned dose of 100 million cells per dose of repeated dosing. And we were also able to show, besides individual dosing, safety over long terms. One of our patients enrolled when he was 2. He just turned 6 a few days ago, and he's now had 87 intracranial doses over 3 years of CAR T-cell treatment. So besides just showing tolerability of individual dosing, we can do long-term repeated dosing intracranially where kids are still going to school, developing normally. The side effect profile I ran through before, but for more details, you can see the recently published paper that came out. But essentially what we see is, as I mentioned, fever, headache, sometimes nausea and vomiting with the headaches the night of the infusions, usually resolving. About 10% of patients having some type of transient neurologic worsening of a baseline symptom, which often improves on its own after a few days. Unfortunately, we did see one patient with intratumoral hemorrhage in the pons, which was the only DLT we've had across any of our 4 studies. But that patient had the lowest planned dose, had a hemorrhage in her pons 8 days after her infusion, which is atypical for the side effects we normally see, and DIPGs can spontaneously hemorrhage. But we're quite conservative, which I think is the appropriate approach with these types of trials. So we reported it as a DLT, but we have not seen it again. This is just a 6-year-old patient with histone mutant disease who enrolled, had multiple progressions, was on high-dose steroids, and as one imaging example, was able to come off steroids, had improvement in her symptoms, had about an 80% reduction in the overall T signal in her pons, and did well for multiple months, but then unfortunately relapsed in the spine. So showing that that's just another example of, while we have some successes, they're not always sustained, and they're certainly not universal. I think phase 1 trials are really complicated, especially in pediatrics, based on how many things people have done before they get to the study. And there's an enormous problem with an immortalization bias that we have, which we've seen with some recently published studies. So I find it most appropriate just to show swimmer's plots where you get to see everything you'd want to know about these patients. But these are children with DIPG stratified by patients who unfortunately enrolled but became too sick to ever receive their CAR T cells. Then a group of patients who had a progression before the start of CAR T cell therapy. And then below are patients who did not have a progression before they enrolled. And what's notable here for people who are familiar with DIPG is we now have 3 patients who are making it close to 4 years from their diagnosis, when the average survival is 12 months. And before this study, I had personally never taken care of anybody who had survived to 4 years. This is our Kaplan-Meiers, which again, to avoid an immortalization bias, are not from diagnosis. These are from your first CAR T-cell infusion. I'm just showing all patients on the left, and then on the right are patients stratified by if they had a progression or not before their first CAR T-cell. And so while we have a few long-term survivors here, which is extremely atypical, obviously these are phase 1 trials, and while we try to be as forgiving and open as possible with our eligibility criteria, certainly the fact that children have to get on a plane, their families are sophisticated enough to find a phase 1 trial, there's some biases baked in on who we're enrolling. So we're planning a phase 2 to better understand these results. I'll also say that, we're obviously trying to do as many correlatives as we can. We live in a world where previously taking care of children with DIPG, you wouldn't get CSF as staging, you wouldn't collect CSF while they were on any studies. And now, because we have OMIAs in place, we have children with literally liters of CSF that we've banked. And so we're learning all types of new things through simple MSD panels, circulating tumor DNA, exosomes, mass spec. And here's just showing some of the published data, showing a couple cool things that our lab is taking to iterate on. But we see after your infusions clear markers of inflammatory changes. Some of these we think might be stratified with response and not. Stanford just published a really nice paper on their GD2 experience, showing that IP10 or CXCL10 might actually be related to going down at the time of progression. We see it going up with a lot of our best responders, and overall, when you look at everyone going up, and that's for people who are not as familiar with immunotherapy, is a T-cell trafficking migration, important chemokine. So A lot of things that are interesting and to build upon from the CSF that we're learning, but the main thing, obviously, we're learning with these phase 1s is tolerability. So across the 3 trials, and a fourth one I'll touch on briefly, where we're using a multi-antigen targeting CAR T cell targeting 4 antigens, we've been able to show tolerability with over 150 kids enrolled, over 800 doses total. We've now helped places like London, Sydney, St. Jude open their programs, and along with other sites that have pediatric programs now, like City of Hope, Stanford, and Baylor, I think we've shown that intracranial CAR T cell delivery is safe, it's feasible, and this is really the foundation of what we can do. And we now have, what I think will probably be decades of work in optimizing their trafficking, optimizing their effector function, optimizing what are the payloads, and then how they combine with other agents. Starting with multi-antigen targeting, just briefly, so we opened a Brainchild 4, which we always wanted to move towards multi-antigen targeting, and we are targeting EGFR, B7-H3, HER2 like we did before. Mike Jensen, who led our program, was previously familiar with IL-13 receptor alpha-2, the CAR he had helped develop at City of Hope, and so we included that, and we have children enrolling that now, which I won't touch on today for time. Combinatorially, there's some oncoceutics drugs, ONC201, ONC206, which in my hands don't have much of a benefit individually, and I think have published some data that suffers from that immortalization bias that I determined before, but are certainly well tolerating and promising for what their combinatorial strategies can be. And so we've seen when we combine ONC206, which is what we use in the lab because we don't find ONC201 to be effective, ONC206 mixed with CAR T cells can have some benefit, but again, this is just in a minority of mice and so has a long way to go. And other things like enhanced CAR T cell migration, as I mentioned, things like CXCL10 or IP10 are elevated, which we published and seen. The receptor via CXCR3, besides building in surface antigen targeting through antibody domains on CAR T cells, you can do lots of other different things. So we overexpress CXCR3, the receptor for CXCL10, and I won't go through all the in vitro data, but we were able to show that these CAR T cells traffic much better when you challenge them through migration transwell assays. They migrate better. So when you overexpress receptors for chemokines, even if those receptors are already expressed on T cells, if you super express them, then you can get better migration. And when we do this in animal models of DIPG, when we give IV non-targeting CAR T cells, IV B7-H3 CAR T cells, IV enhanced migration CAR T cells, they never get into the brain or really have a benefit. When we give non-transduced intracranial CAR T cells, also no benefit. When we do our standard B7-H3 CAR T cells in this hyper-aggressive model, definitely a survival benefit, but only 1 mouse long-term survivor. When we do B7-H3 CAR T cells that also have enhanced migration capacity, we get much better overall in vivo data. So in summary, I would say that we feel that B7-H3 CAR T cells are tolerable, that it can be managed as an outpatient repeatedly dosed intracranial procedure. I mentioned how many children we've enrolled and doses we've given now. We'll be opening a phase 2 later this year, and then a series of other phase 1s, and then also working collaboratively with other pediatric sites across the country and across the world. Actually, we had somebody from the Sydney CAR T cell program out here and are planning to work together. CAR T cells, I think especially B7-H3 mixed with small molecules have a promising future. In my biased hands, much more promising than small molecule plus small molecule. And then there's other modifications you can make like enhanced migration. I already talked about the future steps, just I think for getting us on time, I think I'll skip that and just say our team here is gigantic. Julie Park, who now is running St. Jude's oncology division and doing expert work there, and we miss her a lot, but was my main mentor here in writing and directing these trials. Mike Jensen, who is the architect of the CAR T cell engineering, Sarah Leary, who runs our neuro-oncology program, Rebecca Ronsley, who's taken over as the PI and the study chair of our trials as I've transitioned to more lab work, and then Allison Thompson, our coordinator who interacts with so many of these patients. And then just for lab work that was related to me, these are funding sources and folks that are in our lab. So I think I'll stop there and thank you everybody for your time and your attention and the invitation to speak here today.
Thank you, Dr. Vitanza. What a phenomenal talk and what exciting data. If anybody has questions, you can put them in the chat. I didn't see any as of a second ago. I have one question. We had, in the adult space, we had a New England Journal paper, I think last year, with 3 patients with really striking radiographic data, but very rapid relapse. And so what I was really impressed with your data was, as you pointed out, the durable, the duration of response. So I was just wondering if you could comment on that. Is there any difference between kids? Is it just their immune systems are better, or do the CAR Ts survive longer?
No, I know Stephen Bagley and Brian Cho, who ran the Boston and Penn papers that came out pretty close together. They're both expert groups doing really expert work. I think they still are using a single dose paradigm. We know, I think, irrespective of what you're targeting, T cells are not happy in the brain. Evolution has made sure that you don't get immune insults into the brain. So you also basically don't get immune cells in the brain, except for things like microglia that have other roles like neuronal repair and things. But T cells are just not really present there. And even when they're in the tumor, they're relatively low levels. They're nowhere else. They're not happy. So what I think is the main obstacle to them getting durable responses is just needing to do repeat doses. They do one dose. We know CAR T cells live for, depending on your CAR T cell, 7 to 21 days in the brain. The numbers get pretty low pretty quick. Okay, maybe they're all in the tumor working, but we don't see them in the CSF. So without overestimating what our technologies can do, I think they're not there pretty quickly. So that's why we replenish, basically. Obviously, you don't need to do this in the blood, so it's a different paradigm, but I think that they will benefit once they start doing repeated dosing.
Thank you very much, and thank you for joining us. Okay, I'd like to introduce Dr. Dave Anderson, who is our collaborator. He got his PhD at Harvard in immunology and then worked at UC Davis, then joined the Harvard faculty, and then in 2009 joined VBI Vaccines as their chief scientific officer. I had the pleasure of working with Dave on a clinical trial that was very exciting and also dovetailed off of some of Dr. Cobbs's early work in the presence of CMV antigens and glioblastoma. So I'm thrilled to have him speak today, and he'll be talking to us about therapeutic CMV vaccination for treatment of recurrent GBM.
Great, thanks very much for the invitation to speak. Let me just see if, can you see the presentation okay?
Not yet.
Let's try it again.
Perfect. That looks great.
Okay. Yeah, so I think this group certainly understands just how aggressive and universally fatal glioblastoma is. I think what I wanted to remind everyone is just how little innovation there's been in the frontline setting, and point out that even the standard of care using temozolomide, that really only works for about 30 to 40% of patients, but that's still the standard of care. The Optune helmet, showed an improvement in a phase 3 trial, but if you speak with a lot of neuro-oncologists, there's still quite a bit of skepticism. And then I think, as many are aware, the checkpoint inhibitors that have proven so effective in some peripheral solid tumors like melanoma or lung cancer, they've been evaluated in multiple phase 3 studies and had no impact. So there is a huge need for these patients. Now, cancer vaccines have been around for literally decades. There have been literally dozens of vaccine trials used in both the primary and recurrent GBM settings, and they have universally failed. And, until a few years ago, it really was a dirty word. There was so much negative data that I think, rightly so, the vast majority of people believe that they would never work. But, very recently, using neoantigen approach, combining mRNA encoded neoantigens produced by Moderna with Pembro, this is a trial, and you can see here, this is, sorry, can you see my cursor?
Yes.
Yeah, okay, great. So this is Pembro alone, and this is when you add this personalized neoantigen-specific vaccine, and you can see there was a very clear improvement in efficacy in terms of survival. So the point here is that cancer vaccines can work. It's just that we've spent literally 20 years using, in the vast majority of cases, self-antigens that are very poorly immunogenic. So it's all about the target. So a little over 2 decades ago, Charles Cobbs and colleagues stumbled on this observation that there are viral antigens, specifically from cytomegalovirus or CMV, that look to be uniquely expressed in primary glioblastoma. And you can see it highlighted here. He used a variety of techniques, whether it be immunohistochemical staining against some of the major antigens like PP65 or IE1, and then used in situ hybridization. Critically, it really was specific to the tumors, not in inflamed or normal appearing white matter. Several years later, John Sampson and Dwayne Mitchell and colleagues confirmed this data, and that's highlighted there below. Now, what's shown here on top is just to give you a sense of what the staining looks like. So you can see here control staining, and then here in brown staining against PP65. It's important to emphasize that it wasn't just a sporadic tumor here or there that looked to be positive for the antigens. It really was pretty uniform staining. Now, having said that, if you do a PubMed search, you will find a variety of groups that have not been able to replicate the data. So I think there's 6 or 7 by my last count that could, but certainly some that haven't. And so there has been some skepticism. These are technically challenging assays to run, so that could certainly explain why some have failed to do so. But before we decided to launch a clinical study, we wanted to really try to come at it from another way. And so this is another paper. So instead of using immunohistochemistry or in situ hybridization, you can ask it immunologically. So here are 4 different patients. The study investigators generated CMV PP65 specific T cells. And then what they did is a traditional chromium release assay where, going from left to right, they added increasing numbers of these T cells to a variety of different targets. Now, what's shown in black, these are the patient's autologous dendritic cells loaded with CMV RNA. So they're antigen positive. As you increase the number of T cells, going from left to right, you can see in every case a nice dose-dependent increase in cytotoxicity. What's shown here in the white symbols for each of these patients are their tumor cells. And you can see, again, nice dose-dependent killing, and the controls were all fine. So this is demonstrating from a very different assay, using an immunological assay, that it really does look like the CMV antigens are there. And perhaps even more importantly, it emphasizes that they're there being presented by HLA at levels that the T cells can recognize. Now, at this point, there have been at least 6 different clinical studies, caveat being that they're all small open label studies. But in a variety of different ways, they've all suggested that clinically targeting CMV in primary or recurrent GBM could prove to be efficacious. I won't go through all these studies, but I will emphasize 2 of them. If you look at this one at the top, this was done at UCLA, Tim Clause's group. They, as many have done in the past, took GBM cells, made a tumor cell lysate, pulsed autologous dendritic cells, and vaccinated. And what they discovered is that there was a dramatic 20-fold increase in the frequency of CMV-specific T cells, and, strongly implying that there must have been CMV antigens present in that tumor cell lysate to expand those T cells. And then most recently, the group down at MD Anderson generated autologous CMV PP65 specific T cells. They infused them into patients with recurrent GBM, and you can see there was 1 complete response and a couple partial responses, and then several cases of stable disease. It's difficult to understand how you would have a rapidly growing recurrent GBM completely be eliminated or reduced by greater than 50% if the antigens weren't there. So collectively, aware of all this data, my former company decided to launch a clinical study targeting CMV for recurrent GBM. Now, this just summarizes, 4 different aspects that we thought were shortcomings of past efforts. The first is I've already implied, it was the choice of the antigen. Rather than going after overexpressed self-antigens, we wanted to go after a viral antigen like CMV. You're asking the immune system to do exactly what it wants to do, fight a virus, only in this case, in doing so, potentially fighting a tumor cell. There's also, over the past couple decades, been an almost myopic focus on the importance of CD8 positive T cells, but there is a tremendous amount of both preclinical and clinical data showing that if you want sustained activity and persistence of those CD8 positive T cells, you need to have a CD4 compartment and response as well. So if you look at people naturally infected and that have recovered from CMV, the number one CD8 target is the PP65 antigen. The number one CD4 target is against a protein called GB. So what we did is we decided to incorporate both of those antigens into our vaccine construct. And then another limitation has been that in many studies, investigators have used short peptides, either single peptides or just a couple of them. And there's a real concern given the heterogeneity of the tumor cells and the ability to select for tumors that no longer express the target. We want to have very broad repertoires of both CD4s and CD8s. So we express the full-length proteins, knowing that each individual's HLA would be able to process and present them, and moreover that we would have at least 3 to 4 different epitopes in each one of those antigens. And then finally, these are patients that, as I'm sure you're all aware, are really not very immunologically fit, either through the disease course or through some of the treatment regimens that they've been subjected to. So the immunogenicity of the vaccine delivery has been a real issue in many past efforts. Arguably, the most successful vaccine approach has been the use of dendritic cells because they are the best cell type to stimulate the T cell response, but they can be cumbersome and costly to produce. So cognizant of that and having a technology based on virus-like particles, we decided to deliver these virus-like particles with a little bit of GM-CSF intradermally, where the dendritic cells reside. The GM-CSF stimulates CCL3 production, which recruits more dendritic cells. And preclinical data, we were able to see that within 2 hours of intradermal injection, you could see DCs with the particles present in the draining lymph nodes. So one way to think about it is that this is essentially an off-the-shelf dendritic cell vaccine, very well tolerated throughout the studies that we've run. So this was the initial trial design, a pretty standard design. You can see there, starting from low, intermediate to high doses. I would have highlight the doses that we're using. Often you see people using 100 micrograms or more. These were very low doses, 0.4 micrograms, 2 or 10 micrograms of the PP65 antigen. So we had 6 patients in each study, in each cohort. We wanted to try to identify the optimal dose, and then cognizant that, with just a handful of patients in any cohort, we wouldn't really be able to see any kind of efficacy signals. So the plan was to, in part A, identify the optimal dose and then have an extension phase with an additional 10 patients to see if we could tease out any kind of signals. Now, in terms of the vaccine, it was very difficult for us to try to conceptualize or justify how many doses should be given. Is it 3? Is it 6? And the last thing we wanted was to have an instance where patients were doing well, and then because they had hit their arbitrary last dose, we stopped treating, and then all of a sudden they progressed. So for all the data you're going to see, patients were treated on a monthly basis until clinical disease progression. They received no other treatment during the study. I haven't highlighted the safety, but it was incredibly well tolerated. We didn't have any grade 3 AEs. We didn't have any kind of systemic effects, CNS effects. What you typically saw was a little bit of redness and sometimes some itchiness at the injection site, but otherwise very well tolerated. I won't share the data, but while we were running this trial, the former head of vaccines at GSK saw the data, was really intrigued. They had a very potent adjuvant called AS01, and asked if we wanted to explore their adjuvant with our particles. So we did evaluate it in an additional arm. The data looked quite good, but not better than what we saw with GM-CSF as an adjuvant. Perhaps not surprisingly, the highest dose proved to be the best dose in terms of disease response rate. So here are the data from parts A and B. These are all patients that received the same high dose, so 16 patients total. Now again, this is an open label study, and I think everyone's aware that there have been countless studies that have looked good in open label phase 1 and 2 studies, and then for those that did go on to phase 3, they've universally failed. And that's obviously because this is a heterogeneous disease. The patient populations are different, and so trying to compare against historical controls in terms of PFS or OS is quite challenging. So, you know, when I highlighted this for management and for our investors, our board of directors, I emphasize to them that if we really think that this is working, you should expect to see some impact on the tumor itself. You should either see stable disease for a period of time or ideally see it shrinking. So this is the most objective data that we had. And what you can see here, those highlighted in black are patients that progressed very rapidly. You can see this is change in tumor size over time. This is weeks. And so you can see within a couple months, these tumors are doubling, tripling in size, hence, you know, the very short median overall survival of around 8 months. Nevertheless, a handful of these patients, so 44%, 7 out of the 16, they did have tumor responses, either stable disease, so 2 consecutive stable scans, or partial responses that are in the solid symbols. Interestingly, one of these patients, the tumor actually increased by 50% after about 3 months. Then it stabilized, and then it converted to a partial response. This patient was treated monthly for over 2 years with a 93% reduction. So I think this had us encouraged, but in speaking with the neuro-oncologist, the question is always, okay, it's great to see an impact on the tumor cells, Dave, but what does that translate in terms of OS benefit for the patients? And so here you can see the swimmer plot on the right-hand side. And what I've done is I've color-coded, so those patients that had the tumor responses here on the left, they're highlighted in orange here in the swimmer plot. And what you can see is that there's a very nice correlation between those that had a tumor response and those that had a longer PFS or overall survival. And so you can see here the historical control, you know, around 8 months. Here we're close to 13 months, so about a 5-month benefit. Here's an example of one of the MRIs. You can see here the enhancing tumor here, and then at 6 months you can see very clearly that we started to ameliorate that tumor. Now, as Alipi said, I'm an immunologist by training, and we never expected, unfortunately, that all patients would benefit equally, and wanted to try to identify any biomarkers that could help us guide the clinicians as to which patients would most likely benefit from treatment. So it was a pretty comprehensive panel. We looked at chemokines, we looked at cytokines in plasma, we looked at T cell responses, CD4 and CD8 by ELISpot, antibody responses, the GB protein, and here you can see a kind of primitive heat map. Those that had a tumor response here are in green, and it kind of sounds, no kidding, Dave. That makes complete sense. But you'd be surprised. No one ever thinks about the CD4 to CD8 ratio and how important it might be for an immunotherapeutic approach. In our hands, it really did correlate quite well, not perfectly, but quite well. You can see here, even given a very small n size, it was statistically significant. And just to put this in context, some of these patients had immune systems that looked like they had clinical AIDS in terms of just how few CD4 cells they had. In this assay, a healthy individual would have a ratio of around 3. So based on this data, collectively, we decided we wanted to amend the clinical protocol and have a randomized controlled arm. And we decided we want to give patients the best benefit, best chance to benefit from the vaccine. So we added an additional eligibility criteria for both arms, both standard of care and treatment with the vaccine, such that everyone had to have a normal CD4 count. So these are data from that trial. What you can see here, so I've color-coded it. Those that were treated with the vaccine are in blue. Those treated with standard of care are in orange. The standard of care was either lomustine or carmustine. Not surprisingly, we had quite a high dropout rate. Consent was withdrawn if the patients were randomized to the standard of care arm. Nevertheless, we did enroll, a fairly decent number. And what you can see is, the vast majority of patients in standard of care, they couldn't get past their first MRI, so they came off protocol, at 6 weeks. There were a couple patients that fortunately did benefit, shown here. And then what you can see in the blue is that many instances where the tumor initially increases in size, but they're clinically stable. And so per protocol, they were allowed to continue to get treatment, and then all of a sudden the tumor stops growing. In some cases, there's this nice slow, steady decline, partial response here. Another way to ask the question is, just in addition to looking at the tumor behavior and growth, how long are patients on protocol, as I just mentioned briefly a moment ago. And you can see on the right-hand side, the vast majority of patients on standard of care couldn't get past that one cycle. You had patients on treatment in the 1901 arm much longer. Now, unfortunately, so if you look at the data in totality, I'd said that when you looked at the open phase study parts A and B, the disease control rate, so standard disease plus partial response plus complete response, was 44%. In many clinical trials, vaccine trials in GBM, you have great results in phase 1, phase 2, and then you go to phase 3, and all of a sudden your active arm doesn't behave as well. In this case, it did. So it was 44% in parts A and B of the trial, and then 50% here, and that was higher than what we saw with standard of care of 33%. Now, unfortunately, for financial reasons, the company had to discontinue this trial. So this is kind of what we're stuck with. I think with the help and support of the treating neuro-oncologist, we are going to try to capture the median overall survival data and write this up, because I think this concept has been around, as I said, for over 20 years. There have been a lot of studies, but this is the first one to randomize and ask the question, would targeting viral antigens like CMV offer some benefit to patients with recurrent and primary GBM? So hopefully we will be able to get that data later this year and share it with the community. Now, this was alluded to earlier. This is primary GBM. You can see here in the middle, this is a blood vessel, so these are all red blood cells. You have T cells stained with CD3 in blue, and what you can see is that there are a lot of T cells. This is basically a perivascular cuffing. They leave the blood, but then they're just sitting there. The tumor cells are stained in brown, and you can see here on the right-hand side all these different tumor cells, but none of the T cells infiltrating. And so I think, asking the question, why didn't a greater number of patients benefit from the trial? Because it was clearly a subset. I think this remains a huge issue that needs to be addressed in future trials. We may see some activity with cancer vaccines targeting glioblastoma, but if we want to get the full benefit and have it effective for a greater proportion of patients, I think we're going to need a combination approach that that addresses the tumor microenvironment, because it is so immunosuppressive and it really hinders T cell infiltration. So just to summarize, I think collectively the data, especially now that we have some randomized data, do demonstrate that targeting the right antigen, immunogenic antigens like CMV, could prove effective, at least for a subset of patients with recurrent and primary GBM. As I just said, I think ultimately we're going to need a combination approach, something that addresses that immunosuppressive tumor microenvironment. I think most are familiar, but for those that aren't, the vast majority of the cells in a tumor that you take out are not tumor cells. They are myeloid cells that are incredibly immunosuppressive. And then finally, and this is our experience, and I think this is true for any small biotech that may be trying to develop innovative treatments for GBM, and true for academic designs as well. It's too easy to be fooled in open arm, single arm studies. We need to, keeping safety in mind first, move as quickly as possible into randomized controlled studies to understand what kind of signals we're seeing with new therapies on the horizon. So thanks very, very much for your attention. Happy to answer any questions you may have.
Can you hear me?
Use the big mic.
Thanks for that wonderful talk. And it's very exciting data. I think all of us here were very excited to have the trial and had some excellent responses in patients. You talked about combinatorial approaches that would also simultaneously target the tumor microenvironment. Were you talking about checkpoint inhibitors, or are there other agents that you would think about there?
Yeah, I mean, you might see some benefit if you combined it with checkpoint inhibitor, but I'd rather have a modality that really goes after those myeloid cells that are there within the tumor microenvironment to really try to address that aspect of the immune system. I think that would probably be more effective than just keeping the T cells on, because, as we just demonstrated, and this was emphasized by the previous talk, you can continue to vaccinate or infuse T cells. So even if they get turned off, you can overcome that. What you need to do is get them into that tumor microenvironment, and I think the barrier is really those myeloid cells.
Are there agents that you would think of for that purpose?
Yeah, and just full disclosure, obviously I'm working with Charles and another company, HDT, there in Seattle. They have some compounds that are able to kind of reprogram the myeloid populations from a kind of M2 phenotype, lots of TGF-beta, IL-10, to something that is more pro-inflammatory, induces chemokine production to get more T cell infiltration there. So that's something. There are others that specifically try to deplete the myeloid cells. So I think there are some things out there now that haven't yet been paired with vaccines, and compounds on the horizon that could be very promising.
Thank you.
All right, thank you again, Dr. Anderson. Appreciate the presentation. It is my pleasure to introduce our next speaker, Sean Lawler. I'm Zach Litvak. Good morning, everybody. Executive Director of Neurosurgery here. I do feel some kinship with Sean, even though we've never met. We seem to be in similar orbits, having both spent time at Brown and Brigham and Women's on the East Coast. Sean is the Director of the Brain Cancer Therapy Lab in the Department of Pathology and Lab Medicine at Brown University, and is affiliated with the Brown University Cancer Center at the Alfred School of Medicine, where he co-leads the Cancer Translational Research Group. He's going to be talking to us this morning on leveraging the power of our own immune system to help in treating glioblastoma. Sean, thanks for being here.
Hello. Can you hear me okay?
Yes.
Okay, good. I'm trying to get my thing on full screen, actually. How do I do that? Oh, there we
Down
go. No,
in the
sorry
bottom
about
right.
bottom right. I can't actually, sorry.
That's
Bottom,
okay.
oh, there it is. Yeah, sorry. There's so many things on my screen.
There you go.
Yeah.
That looks great.
Thanks for the introduction. And yeah, we can definitely talk about Brown and Brigham at length, if you like, at some point. Very contrasting institutions, both of which have some great strengths, right? So yeah, today's the title of today's talk is local immunostimulatory therapies for glioblastoma. And what I'm really going to, and I think this kind of dovetails in with Dave's talk a little bit, but not entirely. I think that at least conceptually, one of the focuses of my lab is actually now trying to understand the tumor microenvironment in glioblastoma and identify approaches to maybe overcome some of the immunosuppression. And we're actually looking a little bit more at vasculature and things like that as a potential immunoregulatory hub in the disease. But I'm not going to talk about that today. Actually, I presented last year some of our work on STING agonists, which is published and that continues. And I also presented to this group, maybe it was a couple of years ago now, some of our work on CMV, which is another major focus of our lab, where we have established a mouse model where CMV drives tumor growth. So I'm happy to talk about those on another occasion. Today, what I'm going to really talk about is another study that my lab's been involved in. I want to just keep things fresh and present some data that people don't really know about. And the idea of this is a locally delivered virotherapy, a gene therapy. It's called CAN2409. It's a company that manufactures it and does the trials. It's called Candel Therapeutics, based in the Boston area. And the story really goes from the bench to the bedside, which is kind of nice. So my lab did a bunch of studies on this agent in mouse models a couple of years ago now, at least. And those studies actually led to the development of a phase 1 trial, which is now completed. And so what I'll talk today about is the history of this project through work in my lab. And I'll talk about the phase 1 trial, not in too much detail because we have the trial's completed. However, the analysis of immune correlates is ongoing, but I'll present some of that data to show you what directions this is going in. So the vector we're talking about is an adenovirus. It's a non-replicating adenovirus. It's one of the oldest gene therapy vectors in the book. So it's a non-replicating adenovirus serotype 5 that has been armed with the herpes virus thymidine kinase gene, which renders any infected cell which expresses the thymidine kinase gene sensitive to ganciclovir, because the thymidine kinase will phosphorylate this nucleotide analog and it'll go off and do DNA damage. And the idea behind this approach, at least initially, was as an in situ kind of vaccine. Well, not actually. The idea initially, before people were thinking about immunity, was simply that this would infect tumor cells and kill them. Now, with our wisdom of understanding immunity, we look at it differently. We look at this as an in situ vaccine, where cell lysis will lead to antigen presentation and subsequent anti-tumor immunity if it works properly. And just to really think about local viro and gene therapy, as you know, this is a big area, quite a big area in the field. And what we've sort of to sum up a lot of different ideas. These viruses are generally administered intratumorally in the surgical setting, although that's beginning to change. There's many different kinds of viruses, obviously, and there's many different payloads. Some of the most interesting things that I've seen in the clinic lately have been a herpes virus. It's the oncolytic herpes virus. These are disabled viruses, essentially. They'll replicate slowly, but they won't cause disease. So this is an oncolytic herpes virus called G207. It's been around for many years, deleted, engineered, so it has some deletion of some vital genes to slow it down a little bit. But this virus was in clinical trials in Japan and published in Nature Medicine a couple of years ago by Tomoki Todo's group. And they found that intratumoral administration of this virus in serial injections, so this is This is not during surgery, but through, into a recurrent GBM every several weeks, would slowly lead to tumor regression in some cases. And this actually has been approved by the Japanese FDA, and is ongoing. There's another interesting approach is done by Nino Kioka, my former chairman at Brigham and Women's. And Nino's using a similar type of virus, slightly different genomics, but similar idea. And his approach is to directly inject the virus intratumorally in recurrent GBM. This paper was published in Nature in 2024. And I thought that the interesting thing about this paper, it was in a small number of patients, but they were able to associate responses to the virus with pre-existing anti-HSV1 immunity, which really gives us some clues as to how these things might be working. Anyway, I'll move on to the data now. So the vector I'm going to talk about today, CAN2409, or ADTK as we called it in the lab, is a non-replicating vector. It encodes the thymidine kinase, and it leads to local tumor cell killing when the patients are administered ganciclovir, which does get to the tumor and do its job. So just to sort of summarize the features of this virus that might be useful is that there's a local chemotherapeutic effect. We have definite immunostimulation, so we did some flow cytometry in our lab and showed changes in immune cells. The synergy has been shown with irradiation. I'm going to show you some synergy with an immunotherapy. It's very safe. The vector has been given to many patients. This slide's a couple of years old now, so it's probably twice as many patients by now with different cancer types, with really no major problems, right? So. And also, I should point out that Candel recently reported very positive phase 3 data in prostate cancer with this approach. So they are still developing it. So where I got involved was must have been almost 10 years ago now. Me and the company met and we decided we should run this study. And this study was basically to use mouse models of glioblastoma to test the combination of this ADTK, which then became known as CAN2409, alongside anti-PD-1 therapy. And this was actually one of the first major animal studies that my lab ever ran. It ended up being very, very successful, very informative. I look back on it now and think all the things we could have done in addition. However, this is what we saw. So the Kaplan-Meier curves here illustrate the untreated controls. This is a model called GL261, which, as some of you may know, is a very responsive cell line in terms of immunotherapies. We did see similar results in CT2A, which is another glioblastoma line, which is much more suppressive and has a higher myeloid compartment. So more suppressive M2 type of macrophage compartment. And what we saw in this study was that the vector, when combined with ganciclovir, which we called GMCI at the time, which gene-mediated cytotoxic immunotherapy was the name we coined. This led to long-term survival in a few animals. Anti-PD-1 also long-term survival in a few animals, but the combination clearly worked much better than the individual components. So we showed that in the separate model as well. When we re-challenged those mice with tumor injection in the contralateral hemisphere, we saw no tumor growth. So this represents the memory to the original tumor. And here's some luciferase data showing how the tumors vanished over time in these models. We did quite a bit of flow cytometry, and just to sort of show you the kinds of things we saw upregulated PD-L1 in tumor-associated microglia. We also saw increases in interferon gamma with the GMCI alone, however, none with anti-PD-1 alone, and a little bit with the GMCI. And this actually, I think the mechanism is probably self-evident, but the GMCI is going to be causing inflammation in the tumor microenvironment, and that leads to interferon gamma upregulation. Interferon gamma actually drives PD-L1, is one of the drivers of PD-L1 expression, and that creates this environment where anti-PD-1 can potentially be effective in overcoming that repressive signal. So to move on to the next The next kinds of experiments we did, I'll show you a couple of additional lab experiments that we performed. That initial study went to ABTC as part of the package to start the clinical trial that I'll talk about in a couple of minutes. And so what we looked at a little bit at gene expression and in the intratumorally, we saw some changes in cytokines that you can see here. We saw lots of changes in lots of genes, as you always do. We focused on some of these cytokines, in particular IL-12, which has been employed a lot in combination with oncolytic viruses due to its effects on improving T cell activity. And what we saw in this little in vitro assay here is the addition of IL-12 to our CAN209 cell killing. This is CAN2409 plus ganciclovir in a glioblastoma green spheroid in the presence and absence of IL-12. And we were able to see, as shown graphically here, improved tumor cell killing in this simple in vitro assay. And what this tells us looking forward is there are ways to improve this type of approach, I think. So, when we see the clinical data, we'll see that, that what it's asking us is, do we want to take this this idea further, and how can we improve it to benefit patients? So this is one potential way. Another approach, because as I mentioned earlier, ganciclovir is a DNA damaging agent. Perhaps if we interfere with DNA repair pathways, we could also enhance this therapeutic approach. So we tried a number of DNA repair inhibitors, and ultimately settled on this AZD6738, which is a brain penetrant inhibitor of the kinase ATR, which is involved in the repair of DNA, double-stranded DNA breaks, things like that. And what we were able to show in this initial screen was that the amount of cell death was greatly improved when we added this ATR inhibitor to our in vitro assays. And we could see by histone H2AX puncture in the nucleus that there was basically vastly increased DNA damage when we combined those two drugs. So increased cell killing, things like that. But actually, I've just remembered an interesting feature of this experiment, which I'm going to tell you in a second. We saw some changes in the DNA damage response here, just to kind of illustrate that the mechanism is on target, as it were. And then when we did the Kaplan-Meier curves, in this case, we got a good number of long-term survivors after the GMCI treatment alone, or the ADTK plus ganciclovir. Combination improved the response, at least in the early stages of this experiment. However, when we re-challenged these animals, which I thought was a really interesting thing that I haven't gone back to for a while, unlike in the first experiment that I showed you with the virus plus PD-1, we actually didn't get immune memory. It's something we haven't looked into again, but it indicates there are definite connections between DNA repair and immunity and cytokine secretion that probably we should look into a little bit more here. We also looked at combinations with dexamethasone. So all glioblastoma patients get dexamethasone, and it's become very apparent that dexamethasone impacts therapy, as I'm sure many of you are aware. And so when people run trials these days with immunotherapies, we want to try and limit the dexamethasone, and that's been shown to be useful. Anyway, we did a study in mice to prove this point, and we added dexamethasone to our system. In this case, this particular experimental setup, we didn't get long-term survivors with the ADTK GMCI treatment, but we got still a very significant increase over the controls, and that was completely or near completely obliterated by the addition of dexamethasone. And actually, interestingly, that dexamethasone by itself seemed to make matters a little bit worse. And we did in this experiment, we did a site-off analysis. So this is using heavy metal labeled antibodies, 40 or so antibodies to probe the immune infiltrates. And what we could see, as we might have expected, is in the red bar really is what you're looking at after dexamethasone treatment compared with the green. We see reduced CD8 T cells, reduced CD4 T cells, a trend towards increasing in suppressive macrophages, monocytes, and neutrophils, which all lead to a much more unfavorable immune environment for outcomes. And you can see on these Tisney plots that there's major changes throughout the populations. The Australia down here at the bottom seems to disappear with GMCI. That's actually the sort of neutrophil-like populations, which then recover strongly in the presence of dexamethasone. So there's a warning for the upcoming trial. So I'll for the next part of the talk, I'll just summarize the clinical work, which I was involved in some of the development of this, but obviously being a PhD, did not see any of the patients. But this was done by the old Adult Brain Tumor Consortium, and in collaboration with Bristol Myers Squibb and Candel, which actually it was quite interesting during the process of this work. Candel emerged from a smaller biotech, and as we were trying to publish the dexamethasone data, they really took a long time to review our draft of the manuscript before it went public. Anyway, we don't need to necessarily worry about that. So anyway, the trial, newly diagnosed high-grade glioma. So we about 41 patients were enrolled. I think it ended up with 35 patients that were evaluable. So these patients that go through standard of care. I think this is a great way to do these trials rather than on recurrent GBM. It's a positive. And they had surgery as usual, but the vector was injected during surgery. And the way the injection is done is several injections throughout the tumor bed, a total of about 10 to the 11 viral particles, which had been in a previous trial shown to be a maximum dose and safe. And then patients are given valacyclovir and the usual chemoradiation, with nivolumab starting 6 weeks into the therapy. And these patients are subdivided. Methylated patients get the usual standard of care. Unmethylated patients do not get temozolomide because the benefit of temozolomide in unmethylated GBM is probably not very much. And then the primary endpoints, safety, which I can say that this was overall a safe approach. And secondary endpoints were survival, progression-free survival, and also immunologic biomarkers. And so we're still analyzing a lot of this data, but I'll tell you about some of the things we've seen so far. Okay. So this is our swimmers plot. It's rather complicated. It's really to illustrate the diversity in the responses that we observe. So in the blue arrows here, we see there are some patients that lasted a long time. We see on the left there were a couple of mutant IDH1 patients in the cohort, but they didn't really stand out compared with the others. It's a very low number, of course, and there's also variation according to surgical resection. So patients were subdivided based on subtotal versus gross resection. Also, dexamethasone use was monitored. I can tell you that it was not regulated during this trial, so there was no instructions. This is a multi-center trial. No instructions to limit dexamethasone. So some of the patients got quite a large number of the patients, so over 20 of them, got relatively high doses of dexamethasone, which should be borne in mind when we look at the data in a second. So one of the exciting things in this study, from my point of view, in terms of generating data, was this collaboration we did with the National Cancer Institute group called CMAC, which is a Centre for Immunological Monitoring that was established at NCI a few years ago. And this was as a result. I found out about this as a result of hanging around late at one of the Society for Neuro-Oncology meetings and chatting to people. And a colleague from Pittsburgh said, "You got to talk to CMAC." And so I called them, and they were very, very responsive. So this is a sort of loose organization of centers around the country, Stanford, MD Anderson, and others, who will be supported by the NCI to do immunological monitoring of trials like this. So they were able to do all of the things listed: whole exome sequencing, RNA sequencing, TCR, nanostring for some immune markers, Olink proteomics of circulating markers, and also maybe the sort of high content spatial imaging of brain samples using heavy metal labeled antibodies that you'd use in CyTOF. So we actually have all of those things have been completed. And I'll just show you a couple because they're really there's a lot of data there, as you can imagine, and it probably would take quite a long time to work through it. Anyway, so this just to emphasize what we did during the trial. So at surgery, we took baseline tissue bloods and immunophenotyping. As the trial progressed, there's blood draws, immunophenotyping, cytokines, TCR analysis, and then the patients ultimately are let go on their for the remainder of their journey. And so the survival based on this in this study, I think there's 35 evaluable patients. Whoops, we're slipping back. Is shown here. This is the overall Kaplan-Meier. And when we separated them into subgroups of methylated versus unmethylated, and also with the gross total resection factored in, we were able to see a subgroup that seemed to do a little bit better. And actually, this subgroup would probably do better with or without therapy. Again, we're talking about a phase 1 trial, and as Dave alluded to earlier, some of the things we see are things we see. We can't really make that deep conclusions. However, the methylated patients that were responsive to temozolomide who had gross total resection have a median overall survival of 30.6 months, and some of the patients are still going, to my knowledge. A couple of adverse events just to report at the bottom there, which were unrelated to the therapy most likely, and possibly most likely related to temozolomide side effects, which are known. And so this MIBI analysis was performed and on the patient baseline samples. This is the basically the high content immunostaining, and using analytical tools, it's possible then to subset each of the stains into different categories of cells, and those cells are then associated with increased or decreased survival. And you can see in the red, there's a few cell types, that are associated with decreased survival, as you might expect, macrophages and monocytes, endothelial cells, which I would completely expect to be associated with poorer survival. However, there's some indications of things that might be associated with improved survival, and again, which makes sense from an immunological perspective of B cells and dendritic cells for probably antigen presentation, and memory CD4 T cells as well, which is of interest, as I'll show you in a minute with the circulating biomarkers. And so, in terms of longitudinal circulating cytokine data, analysis, as you can see, this is a really rich data set. This was done with the Olink platform, so many cytokines were analysed, and these are the ones associated with outcomes in this patient group. So, as you can see, the top hazard ratio for a bad outcome was PDCD1, which is actually PD1, which is the target of the antibody we're using in this. And circulating PD1 in other tumours has actually been associated with poorer outcomes, and the reason may be to do with mopping up antibody or something like that, or perhaps reflects some of the tumour biology too, to be honest. And so this pulled out a couple of baseline indicators of poorer outcome, as you can see in the Kaplan-Meiers. There's PD1, so the PD1 high group do substantially worse. And also there's another marker called KLRD1, a gene which I don't know too much about at the moment, but it's an NK cell surface marker. So that was also associated with a poorer outcome. And as you can see, for the whole patient population, so this is the circulating cytokines from comparing baseline with week 3. So you're in the middle of the radiochemotherapy at that point, and you've had the virus and the ganciclovir administered for those 3 weeks as well. There's an upregulation of a number of inflammatory biomarkers, interferon gamma, granzymes come to mind, but plenty of other ones as well, which could be of interest. Between week 3 and week 5, you also see other significantly upregulated circulating cytokines. Again, with PD1 being the top one in this case. So there are some big changes. Again, we can't say that this is specific to the therapy because there's no control group. And after week 11, there were no significant changes between time points, indicating that the response is not durable, or it's maybe stabilized by that point. It might be when you want to do a second injection of a virus, to be honest. So this just shows, this last slide shows you, there's plenty more I can tell you, but anyway, these are just some examples. So we did a further analysis of that MGMT methylated patient group with the gross total resections who did better than the rest, and they're tabulated here. On the left, you can see the different groups and their overall survival, and some of these are still going. And these are some of the cytokine changes. So these are comparing. So in this column with week 3, this compares week 3 with baseline levels of cytokines. So you can see that PD1 upregulation between week 0, between baseline and week 3 is associated with a better outcome, as is MMP12. And at week 5 we see EGF with some other markers which are less well associated, and those Kaplan-Meiers down at the bottom. for what they're worth, small patient population. However, they do illustrate the effects of these cytokines, or at least the association of these cytokines with outcome. On the this data here is this cytoff data of circulating immune cells. It's interesting in that there are significant associations with changes largely in the CD4 population, and these are CD4 memory cells. So, they ask the question of whether this therapy has really, changed the immune microenvironment of the tumors, and that's reflected in the circulation. And I think that's something for further studies. So this is a study that we hope will be published at some point later this year, and there's plenty more, I think, things to analyze over time with it as well. So just to summarize what I've shown you, I've shown that this CAN2409/ADTK is efficacious in murine GBM, and that can be enhanced by the treatment with anti-PD-1. And the phase 1 trial I just showed you, the greatest benefit was observed in MGMT promoter methylated patients who had total resection. And those initial correlative studies reveal that there are potentially relevant alterations in several immune biomarkers, including PD-1 induction in these long-term survivors. And with that, I'd like to thank my new lab at Brown, which is listed on the left, but actually my old lab at Brigham did most of this work, and also the people at Candel Therapeutics who drove the clinical trials, particularly Laura and Brian and Estuardo, who were really involved in the initial planning stages of my work. So thank you very much for listening, and I hope you enjoyed that.
Thank you very much. I'm going to open the floor to questions.
Yeah, Sean, thank you. I'm curious, one of the things that I took away from your talk is we need a new agent other than Decadron that will stabilize the blood-brain barrier, deal with edema, not impair wound healing, and not suppress the local microenvironment. So can your lab whip one up for us?
Yeah, sure. I mean, I've got some ideas on that. I think, there are, I mean, yeah. I think that, so I've seen some work from Dolores Hambadzumian presented a few years ago. IL-1 was a major mediator of some of the leakiness and edema that we see in GBM. I actually don't know what's come of that study and whether it's tractable therapeutically, but I think there are other things. We've done some imaging in animals where we do in vitro dynamic contrast enhanced MRI, right? So we see, and we can see permeability changes. We've seen a couple of drugs which interestingly seem to reduce permeability, although it's all, we probably could revisit that actually, I think. I think it's a great question. Yeah, brilliant question.
All right, well, again, thank you, Sean. Appreciate
All
having
right.
us today.
Yeah, thank you very much.
Thank you. I'm going to introduce our next speaker, who I know very well. Dr. Jerome Graber is a professor of neurology at the University of Washington. He got his MD at the University of Maryland. I think briefly flirted with an MD PhD, but decided not to go that route.
Very brief.
Got a Master's of Public Health at Johns Hopkins. Did his residency in neurology at NYU, and then a neuro-oncology fellowship at Sloan Kettering. He then worked briefly at Montefiore, did I say that right? Yeah. And then came here to Swedish in 2017, from where he came to UW. I knew him in training. He was the director of the fellowship program there where I trained, and it was a pleasure working with him. One of his longtime interests has been tumor predisposition syndromes or genetic syndromes that with increased prevalence of brain tumors, and so he'll be talking to us about that today. Thank you.
Thanks. It's really exciting too. I mean, a lot of us know each other, but it's great. We all take this really long course through like school and training, and we come across mentors, which Dr. Lawler was kind of alluding to, and you find you overlap and stuff with people. So it's really great to see Alippi, Dr. Bonham over here, having done his MD PhD at University of Washington, and then his neurology residency, and then his neuro-oncology fellowship, and then finally like launching into a career. But really, what's nice is this is a community. And I don't know many fields where, you have surgeons and radiation doctors and researchers and pathologists, and it really does feel like a community. So it's great to see him here and joining the community here. And I think we all want the same things, so it's just really, really great. I will add to Dr. Litvak's question that he asked that for a while there was an IL-6 brain penetrant inhibiting agent that was being studied for epilepsy. And I tried to encourage that company to look at it in gliomas because of some of the autocrine IL-6 reactions that occur in the gliotic changes, but I could not get them interested. But other people seem to be better at getting pharmaceutical companies interested in things than me. So I do want to talk about this because it's something that I feel like what we know has changed since I was in training. And then with a lot of the new updates, I feel like there's information that a lot of us were not taught and that I find clinically useful and interesting and potentially relevant. And I'm not really going to talk about NF. We all have heard about that. We know about that. We don't need to talk about that. So I just really want to talk about what I've learned over the last 10 years about germline mutations in brain tumor patients, because when I was trained, it was, this doesn't run in families. That's what I tell all my patients. And then we had a couple global studies, and a lot of us may remember Gliogene, that really seemed to confirm that, like this is not a familial disease with rare exceptions. But I feel like what I've learned and some newer studies kind of question that or give us new light. So, I mean, really, if I was gonna give you just like a one-slide talk, this would basically be it. There's now about 7 large-scale studies where they took every glioma patient, some just GBMs, some every glioma, and they ignored family history because we can do this now. And they took tumor and host or germline samples, and they just sequenced them. Are there any genetic germline genes that increased this person's risk of any tumor or cancer? And all of them are coming up with what to me are kind of alarming results, but the range is really like 2 to 14%. And this is not screening for family history, just patient had a glioma, we're testing their germline. And that's way, way, way above the normal baseline population. In some of the pediatric studies, some of these numbers go up to 20%, which is to me huge and really alarming. And a couple examples, and a couple of them broke it down, like low-grade gliomas, the incidence seemed to be a little lower, but in GBM patients, the incidence was quite a bit higher. And part of why I think this is happening is now you can just run these panels and you can screen hundreds of genes relatively cheaply and very reliably. And it's not any one gene. And I think that's why our prior studies missed it, because you used to only be able to test a couple genes at a time. And over the years, we've learned about more and new genes that predispose people to tumors and cancer. And in most of these studies, the cumulative percent, it's 1% of this gene and 0.5% of that gene, but the cumulative incidence is what really catches my attention. And then there's a couple studies now in medulloblastomas that are showing even higher numbers, which was not on my radar at all. And new genes are being described. So ATRTs are a rare tumor in children and young adults, but it's now, there are a couple studies now saying that the incidence of germline mutations in SMARC genes is not insignificant. And then pineoblastomas and other pineal tumors and pituitary blastomas. I think some of us have heard about the Dicer-1 syndrome, which I think Alippi was the first person to mention to me. I don't think I'd heard of it. But a lot of this stuff is out in the peds literature or the genetics literature, and it may not come to clinicians' attention. So that's really why I like talking about this, because I found it really helpful. And then there's a bunch of references and they're all published, but Gliogene did not really find this. But then if you read it carefully, it kind of did. It was like, oh yeah, we found like 0.5% of these families had ATM, 0.5% had CHEK2. So they alluded to it, but those families that had multiple people with gliomas really might be a different population and a rare one compared to this. They did find some loci associations, but not any specific genes that are clinically available to test for. So the other thing I think that fools us is a lot of us learn like, oh, take a family history. But nowadays families are getting smaller and smaller, and sometimes these second-degree relatives, people say, well, they had cancer, but we don't know what it was because they didn't know back in the day or people didn't talk about it. But in a way, the recent studies free you from that. Like, yes, I take a family history, but I think a lot of these newer studies say, if I get a completely negative family history, I shouldn't just ignore this possibility. Some of the range can also be explained because some of these numbers are just really, really high, like 14%. And if you look carefully at those studies, they include genes that I think a lot of clinical geneticists would not include. So like MUTI-H mutations are very common in the general population, but the biggest studies say if you only have one copy, you really do not have an increased risk of cancer. So some of these higher percentages included things and variants of unknown significance, which are unknowns. So to me, when you kind of remove those, the true incidence reliably from multiple studies in very different populations is coming up like 2 to 7%. And it is, again, this cumulative incidence. And what gets my attention there is that, most of us know, or hopefully know, that if a person in America or any developed countries diagnosed with breast cancer, the current, ASCO, NCCN guidelines basically say anyone diagnosed with breast cancer should probably be referred to the genetic testing. And the incidence of a germline mutation in a person with breast cancer, regardless of family history, is actually about 5 to 10%. So this is touching that range. So it makes me ask, if I'm almost or just as likely to find something as a breast cancer patient, should I maybe be referring all of my patients for testing? So that's kind of my question to you all, because it's what I asked myself. Existing guidelines do not address this whatsoever. So we'll get to that at the end, like, should we be changing guidelines for each other and for our patients? But if you look at all these different guidelines in different places and add them up, like I've done in this table, there's guidelines for when to test and suspect Li-Fraumeni. There's guidelines that most of us know about neurofibromatosis, von Hippel-Lindau, tuberous sclerosis. But the American Society American College of Medical Genetics also has specific guidelines that were recently updated about tumor mutations, which we talk about a lot. And I wasn't aware of this, but when I found it, I was like, are you kidding me? If I use this, I would probably be testing almost all of my patients. So, but I had never heard of this, so I don't think anyone else had either. And apparently my pathologists don't know it. But I look at these genes and I'm like, most of my patients have one of these in their tumor. So if you add all these different guidelines together, it almost comes to the same conclusion. They do have this interesting thing that modifies the tumor mutations for age, that is basically because TP53 mutations are so common in brain tumors. And it says, well, if you're over 30, that's so common, and it's really looking for Li-Fraumeni. But other people have looked at this data and validated this, and I think a lot of us just aren't aware of it. So kind of already said all this. The other thing now is current testing, it's so much cheaper. And in the old days, you had to guess the gene because they'd only pay for 1 or 2 genes, and if you were wrong, oh well. But now you can get this huge panel, dirt cheap. Most of the testing in the US, they literally mail a kit to the patient, they swab their cheek and mail it back. I mean, it's that easy. Insurance typically covers it. As of today, there's a GINA law that protects patients from insurance discrimination based on genetic testing, but if that wasn't the case, I think there'd be a lot of other layers and concerns to testing people. And GINA, it isn't that old, it's still pretty new, so hopefully that remains in place. And then I think there's the question of, well, why? What are we gonna do about this, right? So for me, the holy grail in cancer really is primary detection and prevention, which for breast cancer, maybe ovarian cancer, certainly colorectal cancer, it's led to huge, huge increases, in prevention of cancer deaths in people at risk. And to me, that's what this is about. That's the most obvious benefit. So if my patient is thinking of testing and they have any living relatives, to me, that's an obvious action item. Because once a family is found to have a gene, then everyone related to them qualifies for testing and it should be covered. And we know what to do to protect them from other systemic cancers, not so much this. I think for some people too, they just want to know, why is this happening to me? Because I don't know why it's happening to them. And I think that's a valid reason for testing. If people are still in their childbearing years, like a lot of our low-grade glioma patients are, it can inform fertility testing. And there are options for people with BRCA and other germline mutations to do pre-implantation testing of embryos to screen out, which has some controversies to it, which I won't get into. And I think some of us, it's just too much to think about, well, what was their tumor mutation? What's their family history? What's the chance? The good news is you don't have to. That's why there's genetic counselors. We can't order genetic testing anyways. So if in doubt, I just say, just go talk to a genetic counselor. They're trained to do this. They have the data. I have found, though, that a lot of them are using slightly older guidelines. So some of them I will put in my referral note, P.S., here are my references. But so some of them will say oh, we don't have much data on this. You don't need testing. And I'm like, yes, you do. So I feel a need to direct it, and that may be why we should get together and update guidelines so that all of these patients should at least be offered testing. Because this kind of stratification thing is confusing, some institutions, including Sloan Kettering, are using just a super simple rule of, if a patient has more than one cancer, that's not normal. And if anyone in the family has had cancer under 50, that ain't normal. That's not true for all genes. You know, for BRCA, the age of onset of breast cancer really does stratify the likelihood of finding something. But for things like CHEK2 and ATM and some of the Lynch genes, that's really not true. Like, you're just as likely to find them in people who get cancer in what we think of as normal age ranges, like 60s and 70s, which is a lot of our GBM patients. So age isn't the only part of this story. So I think we were running a teeny bit behind. I have a few cases, but Alippy, don't let me run over and keep things on track. And I'm really informal, so please feel free to like jump in, ask questions, interrupt. I can talk about all sorts of other things. I have a whole nother talk I do for the epi students at UW about like radiation and Agent Orange. And it's, again, this really interesting stuff. And I never learned it, but it's, yeah. Anyways, I like to talk about stuff. So anyways, so this is a patient of mine, 35-year-old guy. He had a prior history of a benign bladder wall tumor in his 20s, whatever. But then we're talking about his family, and he's like, yeah, my mom died of ovarian cancer. 2 of my sisters had ovarian and breast cancer, and they were all kind of on the younger side. So, I mean, that's a family history that should get anyone's attention, independent of him. And when I met him, he had had frontal headaches and a new onset seizure, and we saw this MRI. And I'd love to ask anyone except Alippy, because I know he knows this. Can anyone guess what this tumor is just based on the MRI I'm showing you? And what should we test him and his family for? Anyone want to take a guess? What is this tumor? Because I can tell you, I know what pathologically this is, and it's like 99%. It's the most reliable imaging thing in radiology ever reported. And I'd love all of our surgeons to know this. So here is the T2 flare on the left and the T2 on the right. Does that prompt anyone? So this is something called the T2 flare mismatch sign. This was described over a decade ago now. And the name is a little bit confusing because a lot of tumors can have this bright on T2, not so bright on flare, but the other critical feature is this hyper intense rim that's thin all around the edge. That's not edema, and that's not a cyst, right? Like, that's solid. There's little microcysts within it. So when you see this sign, this disparity between T2 and flare, that it mimics water, but you're like, that's not a cyst, that's not water, and it has that hyper intense rim, that is 99% specific for an IDH mutant astrocytoma. It's not super sensitive, they don't all have it. There are case reports in the literature of like people saying this is wrong. Everyone I've seen, I was like, but that's a true cyst, and it didn't have the rim. But when you have both of those features, it is 99+% specific. It can be any grade, it could be 2, 3, or 4. The 3s and 4s often have a little enhancement, maybe a little area of necrosis, but around that, you can often still see the remnants of this.
Jerome, what is it about an otherwise homogeneous solid tumor that causes this signal disparity at the rim, at the margin?
Yeah, so the reference down there, that's what we wanted to ask, because T2 flare, it's water, right? Like, you're attenuating the water signal, but not fully. So we basically pulled all the path reports from all the IDH mutant astrocytomas, and the ones that had this sign versus the ones that didn't, the pathologist often said that there was an abundance of microcysts. They were also more likely to have visible macrocysts on imaging, which would increase their water content. Makes sense to me. It disappears after radiation, but it does not disappear after a partial resection. Yeah, so just super interesting, because I always complain, like, imaging is not reliable, but like, there's one thing that is actually reliable enough you could make a decision. So with that family history, you'd think like, oh, this is a BRCA history, all this breast and ovarian cancer at young ages. But then he tells me, yeah, everyone said that, but my sisters got tested and they're negative. So what should we do with him now? Like, if we know his sisters tested negative for BRCA with that family history? So I said, who cares? Let's send you for testing anyways. And they'll test everything. And lo and behold, he came back for a RAD51C mutation. So RAD51C is a newer described mutation. RAD51C and D are part of the BRCA2 complex. So they behave like a BRCA2 mutation, lots of ovarian cancer. But when his sisters were tested, we didn't know about that. So of course they were negative. And it's much less common, but it's not super rare. And it's come up in multiple of these glioma studies, all the BRCA family genes. And I think what's interesting about that is we know that breast and ovarian cancer patients with BRCA germline mutations, their tumors are much more sensitive to PARP inhibition, which we've done lots of studies in gliomas and they haven't panned out so far. But I wonder if that holds true for our glioma patients. If they have a BRCA mutation, would it make their tumor more sensitive to PARP inhibition? No one's looked at it. So for some of these genes, I wonder if we might treat our patients differently, because that's certainly true in breast, ovarian, and colorectal cancers, that you have more treatment success if you know the germline mutation that caused it. So take-home point for this case to me was old testing should be repeated because we get better tests, broader tests, new genes. Variants of unknown significance get updated. They get fed into this global database with family histories. And some testing companies now, and probably all in the future, are going to start doing protein modeling. So some of the testing companies, if there's a variant of unknown significance, they'll tell you, protein modeling says that mutation probably does not change function, or that mutation is likely to change protein functions. So you could start even stratifying variant of unknown significance. Is that just a nothing, or is that maybe real? And the ACMG recommends repeat genetic testing every 3 to 5 years for people who qualify for testing and prior testing was negative, or people where a variant of unknown significance was found. And I've had multiple patients now where we got repeat testing and well, now we understand what's going on. So it's been pretty useful. So case 2, this is a 20-year-old woman with rapidly worsening headaches, hiccups and vomiting, strong maternal history of breast cancer in multiple people at young ages. And this is I think this is a T2 flare without contrast on the left, and this is a MPR, so a T1 base sequence on the right. Does anyone know what this tumor is based on this appearance? Lippy can chime in on this one, because
I'm wondering about a sonic hedgehog activated medulla.
Okay. Medullos can look so crazy. I have been wrong about them many times, especially on the left. I'd be like, I wonder if that's a medullo. She's a young person. Any other thoughts? So this is Lermita close, right? And we see medullos more, and I think of them more. But the key is, some people might look at that flare and say it, but to me, it's the T1 pre. It's this bundled, but kind of the cerebellar folia are kind of architecturally preserved because this is within that foliar layer. People have called this like tiger striped, and if you pull up the right picture of a tiger, I guess I can kind of see that. These are people with Cowden syndrome and germline P10 mutations. So Lermita-Close or dysplastic gangliocytomas, it is pathognomonic for this disease. So if someone has that, nothing else matters. You should suspect they have a P10 mutation and send them for testing. I've met one person who didn't come back with a P10 mutation. He did come back with a variant of unknown significance in another gene in the P10 pathway. So this is like a pathognomonic thing. It comes up on tests a lot for neurosurgeons and for neuro-oncs and neurologists too, really. So this is good test prep for anyone listening. They do have a significant increased risk of other cancers and breast cancer, and there's many guidelines. So this patient, based on her family history in this, we sent her for P10 testing. She was positive. Based on that positive result, she got full body screening, and lo and behold, she already had an unknown breast tumor. This to me is the point of finding it in our patients is you start them on screening, and some of these people might be saving their life. But I've heard other people be like, well, what are you going to do with it? They have brain tumors anyways. But Lermita-Close is a benign disease. So take home point, to me, germline testing is useful, even if it finds something that you as a neurologist or a neurosurgeon are like, that's not my job. Ideally, we find these people and can protect them, and that can be really useful, especially for the low-grade gliomas as they're living longer and longer, like decades. Case 3 is a woman in her late 40s who had survived breast cancer in her 30s with aggressive treatment and was doing well, but then presented with left-sided weakness. She had systemic screening, including a PET scan. Her ovarian cancer was in complete remission at this time. There was no family history. She came from a pretty big family, if I remember right. Anyone want to guess what this turned out to be? A bunch of people said Matt, like it's a solitary enhancing lesion, it has edema, like even though her body's clean, she's had ovarian cancer. It's, you know, how often do you cure ovarian cancer? But this was partially resected and it was a GBM. And then I was like, this is weird. You're young for a GBM. You had ovarian cancer at a young age. She had had prior BRCA testing that was negative. So we sent her for testing and she came back with Lynch syndrome. So she had an MSH2 mutation. Lynch syndrome, if you add up all the different genes, is actually pretty common in the general population. And 20% of Lynch genes, it's a new mutation. So you won't get a family history because it was a new mutation in that person only. I think a lot of us think of Lynch syndrome with colorectal cancer, which is true. But we now have big studies from Europe, and each mutation has its own risk profile. And MSH2 patients, their lifetime risk of a brain tumor was 8 to 20%, which to me was like, wow. You know, should we be sending these people for MRIs and screening? Within Lynch syndrome, it's also been shown that even within your mutation, family history modifies risk. So if you have, you know, MLH2 mutation, but you had a first-degree relative with breast cancer, your cumulative risk of breast cancer is higher than other people with the same mutation. And some of these genes, but not all of them, show anticipation. So age of cancer gets younger with subsequent generations who have the same gene. Am I okay for time? I think so. So case 4, this was a guy, an 18-year-old guy who had known NF1 and was being followed for a right neck plexiform neurofibroma, and presented with new onset seizures and left-sided weakness and this big enhancing cystic thing. So this was resected as a GBM. We know NF1 patients are at increased risk. The NF1 guidelines, which have been updated, so if anyone hasn't looked at them in a while, I encourage you to look at them because they've been updated based on big natural history studies, often done at Mass General, but also at CHOP. They do recommend brain plus minus spine every 1 to 2 years. And you know, UBOs, these little non-enhancing flare things, are really annoying. They cause a lot of stress, but they're usually nothing. But we now know their pattern, like this is where they are. So it's easier to me to follow them, but any new enhancing brain lesion in an NF patient is a glioma until proven otherwise, a malignant glioma, not just optic nerve gliomas. Their risk is higher than the general population. Most of them don't get it, but that's really, to me, the take-home point from the NF1 patient guidelines, because sometimes you've been doing this for years and you're like, yes, I know they have the neurofibromas, but you know, so we do primary glioma screening in this one disease. And then maybe the last case I'll show is a 32-year-old woman with a prior history of breast cancer. Her sister died of breast cancer, and that sister's daughter had a sarcoma of the proximal leg. Patient tested positive for a TP53 mutation. So this is a good family history, not good, but this is a family history of Li-Fraumeni. So this was already known. And then she was sent, as some people with Li-Fraumeni are, for whole body MRIs, which is kind of becoming the way to monitor NF and Li-Fraumeni patients. Rather than getting 10 different tests that still don't look at everything, just do the whole body MRI and find it all at once. And lo and behold, on her whole body MRI, there was this little thing in her brain. So she was fine, they decided to watch it, but on her 2-year follow-up, it was bigger. So that's when she got referred to me, and we said, like, you have a significant risk of gliomas, this is growing, you know, and it's in a fortunately very accessible place for the surgeons. So she went ahead and had this resected, and it was an IDH mutant astrocytoma. So we might be, and I've met 3 Li-Fraumeni patients now, where we identified a glioma pre-symptomatically on whole body MRI. So this may become a thing, and in a perfect world, if we think resection really benefits our patients, maybe we should be doing it for other people at risk. Because if it happens to pop up somewhere you can resect it, that theoretically would be the best thing to do. And these are all patients I've met just in the last couple of years. So it's not like I was picking through. Like, I think this is as common as the studies are saying. And the more I've sent people for testing, I feel like I'm getting a similar rate to what's reported in the studies. There's a million other genes, like, I don't want to talk about all of them, but because to me, it's simple as a clinician, I'm just going to send my patient for testing and they're going to find whatever. And then once you know the gene, then we have data. What are you at risk for? How should we protect you? The one thing that I've had recently, I've had 2 people with tuberous sclerosis with malignant gliomas, which is not supposed to happen. These are not SAGAs. And there's only a few case reports in the literature, but I've had 2 this year. So if anyone else has had any tuberous sclerosis patients with a malignant glioma that's not a SAGA, like, let me know, because I think we should report this. Other thoughts? Oh, variants of unknown significance. These are really annoying, but some people do protein modeling, so that's helpful, because you can be like, that does not change protein function, who cares? Or that changes protein function, and I have a patient or family history that kind of makes it seem like this is real. And it's reporting those variants of unknown significance with the patient and family history. That is how these global databases get updated. So if you are adding that through your geneticist to that database, you are helping other people with the same variant be like, this many people in the family had that variant, none of them had cancer, probably benign, or hey, the people in this family with that variant seem to have problems. We're updating the database so everyone can benefit from this information. And the people with a variant are the ones that really should get repeat testing every 3 to 5 years. And sometimes it's not even testing, it's just seeing their genetic counselor, checking the database for new information. So I'm getting to the point where I feel like maybe a group of us should get together and update the guidelines through SNO, ASCO, NCCN, because I think the data has accumulated and crossed a threshold that is comparable to other cancers where we send for testing. I feel like I knew none of this, and in fact, I was trained and told, these don't run in families, you don't send them for testing, so I really feel like I've learned something new and it's helping my patients, but I feel like most neuro-oncs don't know all this new information, so I want to update other people so they can use it as well. And then I think, to me, one of the next steps would be to say, like, for some of these genes, do Lynch patients with gliomas respond better to immunotherapy? Do glioma patients with a BRCA mutation respond better to PARP? It'd be hard to do those studies, but we could also go to prior studies, and if we have the samples, see how many people in that huge PARP inhibitor study actually had a germline BRCA family mutation. Do they seem to be outlier responders or not? So we could even dig through old data and maybe get a hint at the answers to those questions. So I'm only, I think, a teensy bit over, so I'll stop there. Thank you so much. I really appreciate the opportunity to share this because we're always learning new things. We're always hoping we learn something useful or helpful for our patients. So I feel like this has really helped me and some of my families. So thanks for letting me share it. Any questions?
Yeah, I'm just curious. Are you noticing differences in what you're picking up based on where you're sending it? This is a conversation I've been having with Dr.
Yeah, when a variant is found, I like seeing the protein modeling on the report, but again, that's all theoretical and extrapolation. And I have found that some genetic counselors are like, yes, this person should get testing, even though they don't meet my old guidelines. But some genetic counselors are kind of sticking to their guidelines that exist. And then I'm having to be like, well, go see this other genetic counselor.
Well, I meant even in terms of platform, like genetic testing platform.
No. There are some companies that will dual test. So if you're sending a tumor for mutation analysis, some of them will also test germline genes at the same time if you send a paired sample. Is that better, more efficient, more cost effective? I don't know. I have no idea. Thanks so much.
Thank you again, Dr. Graber. Our next speaker this morning is Dr. Jody Stern. Dr. Stern is a practicing neurosurgeon in North Carolina with the Carolina Neurosurgical and Spine Associates. In 2015, Dr. Stern suffered the tragic loss of his sister to leukemia, and in 2021 published the book Grief Connects Us, sharing his experience and insights surviving that experience and his other interactions with patients and other medical providers over the years. And Dr. Stern will be speaking with us today about why it is important for neurosurgeons and probably all physicians to have some component of their education and training with regards to palliative care and comfort care. Dr. Stern, thank you for joining us.
Thank you very much. Can you hear me okay?
We can hear you.
Great.
Yes.
So it's a privilege and an honor to be with you guys. I'm currently teaching at the University of Michigan and am in my office here, and I'm looking at you guys thinking you look warmer than I am. It's pretty cold here. So Miri Kim is the reason I'm here, and she and I have worked together, as I'll talk about in a little bit, and I'm thrilled to be with you. So I trained at the University of Michigan, where I returned as a member of the faculty. I was in practice in neurosurgery for about 30 years in Greensboro, North Carolina, with the largest private practice neurosurgical group in the country, Carolina Neurosurgery and Spine. And as we just heard, I kind of went through a very personally disruptive experience that led me to become a writer and to write about what I have gone through. I've become a teacher now. I joined the UNC faculty teaching medical students and residents, and now I've joined the faculty at University of Michigan. So it is a personal story, so I'm going to take you through why I'm here and what I'm about, and also what we're trying to accomplish. So my younger sister, Victoria, developed leukemia, had an AML, a bad mutation, monosomy 7, and had a bone marrow transplant and died. And that was in 2014, 2015. This led me to write a book called Grief Connects Us, a neurosurgeon's lessons on love, loss, and compassion. For me, it was a very disruptive experience that really reoriented me in the practice of medicine and the way I think about patients, the way I think about compassion and the importance of compassion and the care we provide. My younger sister was always in my life. She was 18 months younger than me. Here you can see, we grew up in DC. She was sitting on our mom's lap, we both were. We spent 4 years living in England in high school or junior high. After we grew up and graduated from high school, we went our separate ways. She went to college, later moved to Los Angeles and became an actress. I went to North Carolina after training in neurosurgery at the University of Michigan. So in the fall of 2014, she developed leukemia. It started as what was a flu-like illness, and here she wrote a journal about her illness, and her goal was to share this as a one-woman play about surviving leukemia, and unfortunately became a testimony to her illness and later her death. And I didn't really imagine myself as a writer, but I wanted her words to continue on past her, and so I incorporated her journal into my book. But here she talked about the isolation that she felt, being yanked out of her life, being yanked away from her family, spending almost 4.5 months in the hospital. Here she was, she had put pictures of her children and her family up around her, and here she was getting her head shaved. I was there visiting with her at the time. She was continually hooked up to IV poles. She used to call it her stalker. She had 12 pumps running all the time, and she was very frustrated because she never lost any weight despite not eating much. So most people in the hospital saw my sister as a patient in a gown, bald, head shaved, and very few people knew the person who just a month or two earlier was a vital mother of 2 sons, wife, and an actress, and producing her own films. And almost no one knew her as the young girl that I had grown up with and loving. And I realized this sort of led to a personal transformation. It was as if I suddenly went from seeing in black and white to seeing in color. Because this is the story of each and every patient that we take care of. And oftentimes we don't really recognize who they are, their stories, that we don't take interest in them, we don't see what's unique about them, and we kind of keep a defensive wall of emotional armor to protect ourselves. But I realized as I went through this experience, I wanted to get rid of that armor. A year and a half later, her husband, Pat, after a year and a half after my sister died, her husband, Pat, ruptured an anterior communicating artery aneurysm in his brain. And he went into a coma and then was taken to UCLA Medical Center, where he was in the hospital for a couple weeks. I was his healthcare power of attorney, and I had to ultimately decide with his family to withdraw treatment. This is a picture of their family. This is Pat, Victoria, Nick, who's the taller child, and Will. And this was in happier times. Nick was the bone marrow donor for his mother, and he did CPR on his father. And really had a devastating change in their childhood. You know, they're both now orphaned and are struggling to kind of become adults in a tough world. So in my book, I advocated for palliative care, for education and training in palliative care. And I realized that if I was going to become an advocate for palliative care, I needed to learn more about it. So I decided I needed to do this to grow as a person, to develop new skills as an advocate for palliative care, and to improve my ability to communicate and care for patients. So I went to Palliative Care Education and Practice, which is a program through Harvard Medical School, which was remote due to COVID. And it was a 2-week, sessions with a project with lectures and small group play acting and working with others. And in this, I studied and learned to develop communication and listening skills and skills maps, explored teamwork, role-played with professional actors, and had a safe space to learn and to grow. So we did new projects. One of the projects I did was with the CEO of our health system, which is Cone Health in Greensboro, North Carolina. And I'll show you a clip of a video of the CEO, Mary Jo Cagle, talking about her own experience. So I attempted to integrate palliative care into the clinical services in the neuro ICU. Here's Mary Jo. She's formerly an OBGYN, now full-time CEO of a health system, talking about her own experience with her mother, who had a subdural hematoma, went into status epilepticus, and later died in Alabama.
That the neurosurgeons, the critical care docs, they were incapable of dealing with this end-of-life issue and allowing us to meet my mom's wishes. And I very much felt like that to meet that, it was in my hands to do it. And it was one of the most frustrating moments that I've ever experienced as a patient family member, as a physician. I was so frustrated and could not believe this is the institution where I trained. And I felt that I was dismissed, and I couldn't even get people to look me in the eye and have a conversation with me over something that was not unreasonable. You know, we talk a lot about making sure patients have advanced directives and living wills. My mother had all of that. It was brought to them early. They said, make certain palliative cares involved. We had palliative care involved prior to her surgery. We had a plan, and yet none of that could be executed. So it's more than that. It is that all of our physicians have to have some training and some sensitivity to what it looks like to be involved with end-of-life care and understanding what patients and family members need.
I wrote an article about why a neurosurgeon should attend palliative care training, and that appeared in the Journal of Palliative Medicine. And since then, I've been working on integrating palliative care into neurosurgical practice. I think this is less a conversation about what advances in palliative care and more that we need to bring the principles and practice of palliative care into our field of neurosurgery. I think that care is often bifurcated. It's technical versus emotional and often split. And yet the emotional support piece is oftentimes what patients and families remember most and is the most important. And sometimes we leave that behind. In an acute care setting, the palliative care integration has unique requirements. I think one of the key parts of this is working as a team. We need earlier involvement, frequent touches, consistent messaging, and training. In brain tumors, I think this is a well-suited paradigm, and it's no accident that a lot of brain tumor programs have palliative care integrated into them. They're chronic conditions with longer-term relationships. At Cone Health, we started our own brain tumor program, which I was one of the co-directors of, and we had a multidisciplinary clinic with an embedded palliative care nurse practitioner, which we were able to address patient needs and quality of life essential to the treatments we were providing. As I tried to develop palliative care integration in neurosurgery, I discovered it really wasn't something that was widely accepted. And we started a collaboration with residents, Miri being one of them, and Adela Wu at Stanford, Stephen Miranda at Penn, and we came up with a game plan of how we would implement palliative care in neurosurgery. I also got involved in Vital Talk, and I've become a trainer in Vital Talk. And I think this is crucial because it improves communications and increases resilience with decreasing ethical distress. And as I'm sure most of you know, they grew out of palliative care and oncology, and is a really good opportunity for us to develop training in serious illness conversations. At Michigan, we call it M-Talk because everything at Michigan gets branded with a block M. There's been over 1,000 people trained at Michigan, but until I started, nobody in neurosurgery and very few people at all in surgical disciplines. So we're talking about goals of care, delivering serious news, shared decision-making, and how to communicate about adverse operative events such as complications. The beauty of this is not only do you improve communication and care with patients and their families, but you decrease the ethical distress and burnout in the practitioners because you give them a path to be able to share what are often wrenching and guilt-ridden and difficult topics that they're not comfortable expressing. This is a paper about doing so in implementing communication didactics in OBGYN to talk about complications. And we have had an effort in neurosurgery to train residents in difficult conversations, but it really hasn't been implemented widely or as thoroughly as it should. And this responds to a call from ACGME to have better communication training for patients and providers. We went to the AANS, which is the American Association of Neurological Surgeons in Chicago in May, and we gave the first presentation ever in neurosurgery on the evolution of palliative care and its relevance to neurosurgical practice. And you can see Miri on the far right, but these are all the residents and also neurosurgeons and palliative care specialists. We all came together to put on this training. We talked about why we need palliative care in neurosurgery, the importance of teamwork, and how this is done outside of the US, including in Australia and other places where they have a greater integration of palliative care than we do in the US. We also provided a model for communication training for neurosurgeons. Palliative care needs to be integrated into surgery. It's part of the continuum of care for patients. And these are some of the slides that we showed at that presentation. And we have to bridge the gap between neurosurgeons and palliative care providers to provide a more seamless scope of care for patients. Teamwork and multidisciplinary collaboration are key for effective communication and compassionate, culturally sensitive, and quality care for neurosurgical patients. I want to share a little bit from Adela, who is one of the co-presenters, and here she is with the young girl on the right with her family. And she had her own personal story with her father, who developed a brain tumor, a atypical meningioma, ended up having 18 surgeries and later died. And what was interesting when I talked to Adela is it's not one size fits all. She wanted to bring palliative care to her family, and she's at Stanford. They're very interested in doing so. But the parents didn't want it. They said that culturally they weren't interested in receiving any palliative care. So it makes a big difference where you meet people and where they're coming from. I think that one of the beautiful things about this of personal loss and grief and going through these experiences is it integrates your artistic side. And here is a beautiful article that she wrote about food and the importance it had in her father's care. Also, she's an artist. And she's worked on integrating, as I have at Michigan, integrating palliative care into the neurosurgical practice. And she's talking a lot in her work about cultural sensitivity across different ethnic groups. So what are some of the challenges of integrating palliative care into neurosurgery? You know, I was amazed. So at the time that we gave this presentation in the plenary session, one of the brain trauma researchers stood up and said that the number one cause of death in patients was the early implementation of palliative care. So nihilistic, therapeutic nihilism and withdrawal of life-sustaining therapies was the number one cause of death in traumatic brain injury. And I think one of the fundamental problems in the ICU is the difficulty we have with neuroprognostication and how we manage uncertainty. But I think we make a mistake. You know, if you look at, and Claire Kreutzfeld is in Seattle, talks about the fourth trajectory. There are a lot of complicating factors. You know, the disability paradox. If you ask someone when they're initially injured, do they want to live with that disability? They would say no, but later on, family and patient adapt and adjust. But we need to decrease suffering. We need to get rid of what is, I think, a very paternalistic attitude. And oftentimes when we say, well, we can't make decisions on whether to withdraw treatment, what effectively we're doing is abandoning patients in one of their greatest moments of need. And there's such a focus in the ICU on throughput and getting patients out of the ICU or, you know, length of stay, that we end up doing a pretty poor job in terms of giving follow-up to patients or keeping with families. We also provide, I think, an inadequate amount of caregiver support. So is there a middle ground? You know, do we need to say and come up with standards to say we're going to refrain from withdrawing life-sustaining therapy for 5 to 21 days to set some standards that we can, guidelines that we can both use from both neurosurgery and palliative care, and look at how, so that we can provide that supportive care at the same time that we're not withdrawing care too early and letting people die when they may improve. The problem is if we don't look at patients in terms of, you know, what they're experiencing in their families rather than, so we don't look at them as people rather than diseases, I think we miss opportunities to connect with people. And some people really have poor quality of life, and continuing just to get to survival with the possibility of ending in a vegetative state doesn't seem that we're doing them any favors at all. So what are the next steps? So I've launched a neurosurgery communication training program. We've written individual cases in neurosurgery and are presenting that at various institutions. We're doing this in Australia. I did this at Duke. We're starting this in Michigan, also at Stanford and Rochester, University of Rochester and UNC. And we're with Martina Stipler and Kate Drummond, who are two neurosurgeons. Martina is at Harvard and Kate is head of neurosurgery in Melbourne, Australia. We're producing the first ever book on palliative care in neurosurgery. So I spoke in Australia. We are working to integrate palliative care in neurosurgery. I was amazed when I came to Michigan. I thought, well, this will be a snap, you know, they'll want this. And I discovered, no, actually people are very resistant to the idea of bringing palliative care into the ICU. We are at least locally much more receptive to communication training for neurosurgeons. I spoke at the International Neuropalliative Care Society, and there are great groups within neurology that are working on palliative care integration into the chronic diseases, including neuro-oncology. And I think we need, as neurosurgeons, to integrate into those efforts rather than try to reproduce them on our own. And I think we also, so we're working on coming up with specific neurosurgical cases and also looking at best case and worst case scenarios for patients, which I think are particularly germane in surgical treatments. And at the University of Michigan, I just want to share briefly how we've launched this at Michigan with 2 3-hour courses with original cases. One was an intraop aneurysm rupture, also a glioblastoma, where the patient comes back for pathology review and discovers that the tumor is more malignant than first perceived or thought of. Goals of care about a recurrent subdural hematoma, where we say, well, should we go back to surgery or should we stop? So we're doing 2 courses. One is delivering serious news and the other is goals of care. I've launched the delivering serious news course with 8 neurosurgical APPs in person, and then we did 9 more remotely. And we're launching at the end of this month with 32 residents and faculty. The goal is to train 100 people in our department. And here's a shot of this in person. I'm working with the palliative care people. They run MTalk. And these are the APPs in that conversation. And here we are with an actor talking about her what was felt to be a low-grade glioma that turns out to be a GBM, and some of the decision-making that we need to make. So the results so far with surveys are 100% endorsement for self and for others, and 100% advocating for additional training. So I think there's a real important need for this in our field. One of the big issues is that when someone comes up with a question to you and it's a cognitive question, we tend to give a cognitive answer rather than recognizing the emotion behind the question. So starting to get smarter about how we address questions, I think, is a part of it, to respond empathetically to a patient or a family. So my goals are that we need to deliver compassionate care and chart our futures. You know, we so often in neurosurgery, we tend to offload things. We become technicians. We're going to do the surgery, you know, someone else takes care of the patient. And I think we lose our opportunity to have a meaningful relationship with patients. So we need to improve our communication skills, our collaboration and teamwork. And through research, we can come up with best practices where we can direct this care and provide the best care we can possibly for patients and their families. And this came out of personal loss and grief, but I feel, and I'm very grateful to my sister, I am grateful to you for listening, and I thank you for your attention.
Thank you, Dr. Stern. I'm curious, you know, there's sort of two groups of patients for whom surgeons would be in a position to have these types of conversations. One is a group of patients where something happens to the patient, a stroke, a traumatic brain injury, some externality. The other is when we're caring for the patient and there's a complication in the course of their treatment, in the course of their surgery. How do we get the surgeons themselves to a point where they are cared for and they are in a mental place where they can be compassionate as opposed to suffering themselves, dealing with the negative emotions associated with hurting somebody unintentionally?
I think I'm really glad you asked that, because I think that's one of the goals of this training is that I think we tend to be avoidant, and I think it's certainly not from a lack of self-criticism. I think actually we beat ourselves up and we don't admit the basic fact, which we all know, and you can see the gray hair. We're not infallible. We are going to make mistakes, and mistakes and failure are an inevitable part of our field. I think that patients, we have this sort of perfectionism that we think we need to do things perfectly, and we berate ourselves when we aren't perfect. And families and patients, they want to know that you care, that you're doing your best. They're actually far more forgiving than we are. So I think you have to become comfortable being in that space. And I think a lot of times when we talk to a patient or a family about a complication, it's all from the standpoint of ourselves. Like, I failed, I made a mistake, or our guilt, or how we react to it, rather than taking a bigger stance and saying, complications can happen, and I feel badly about this, but I need to talk to this person and family about what's going on, where they are, what to expect, and really to be far more compassionate toward that person. So I think one of the problems is that we lack self-compassion, and we're also perfectionists, but we need training. This is a crucial part of our job. We're not all perfect. We're going to make mistakes. How do we communicate those effectively? And that's one of my hopes of the training, is that through training, you will become more comfortable recognizing, admitting to complications, having the skills to deliver that message and the impact of that, rather than avoiding it or keeping armor up or keeping your distance. But we need training in this, because complications are inevitable, and these conversations have to happen, and they have to happen with skill.
Thank you. One question from our online viewers. Dr. Sharma, who's a neuro-oncologist, states that she finds a lot of extremism on the part of neurosurgeons when it comes to brain tumors, in terms of optimism or pessimism with regards to the outcome, and that sometimes that pessimism will cause a break or a rift at the beginning of a patient's journey. What would you propose for education around that, especially breaking news at the beginning of a highly malignant tumor?
I think that one of the big problems is mixed messaging or, inconsistent messaging. So I think that, and one of the other problems that happens is that people pass the buck, right? I'm just going to avoid talking about it altogether. Someone else, the neuro-oncologist will get to it. So I think that, I do think that one of the ways that we can support each other and support patients is by having a unified message. I found the multidisciplinary brain tumor program that we set up to be very powerful, very supportive of the patient, their interests, and also bringing all of the clinicians together so that they speak with a common voice. So I think that very individualized presentations of information or extremes really have no place in this care, and you have to recognize I'm not just doing a technical surgery. I'm not going to say either something horrible like the GBM is incurable or untreatable, and that's that, and sort of wash your hands of it, or make the alternative case and say this is a super easy surgery, we can take this out, and then minimize the downside. I think that's irresponsible of us, and I think ultimately we need to do better, and we need to integrate our voices, hopefully at the outset of care.
Well, thank you again, Dr. Stern. Thanks for making all of us better doctors and capping off quite a morning. We're going to take a brief break, and we'll be back online on stream in about 10 minutes. Thank you.
Thank you so much.
There's snacks and beverages. Encourage you to spend some time with our vendor sponsors, and we'll be back over here at 11:40.
Before everyone goes, I just want to say I'm here from palliative team here at Swedish Health, and we want to work with you guys to help with communication, empower your voices. We do not take people to hospice. We listen to what the neurosurgeon recommends, and we help. So call us.
I can vouch for that. Nice to meet you. Awesome. So let's take care.
And then I just get out. That's exercise. Lauren Abrams, terrible. We had so much show yesterday. Yeah, like this was our main show yesterday. Like I was trapped. It's beautiful. My dogs loved it. It's beautiful, but I was so snowed in. And so I ended up getting here. I was out today. There were a lot going on. So I told her, I was like, I just have to leave by like 3:30 so I can make it. Of course, I'm like on hills, and there's 3 hills to get in out of my neighborhood. So I just need to get home. So if the fruit's over, I'm good. Is your here's your common information to get it? So I saw Stan's note saying that we want to get it, but I got page cut from. Oh, okay. usually we can't get people in Tumor setup, but they actually got her. She's in 550. Yeah. Yeah. How was your drive? Is it not too bad? I am. It's so interesting. There's some things that are like very way above my head, but I'm trying. Ooh, that looks really exciting. It's a lot. Oh, thank goodness. No, Sam. She said that I wouldn't call you. She mentioned all of our attendees. Okay. So I was like, how do you know that I'm late? Oh, that's a good combo. Applause. Some of these things are super.
I finished up scrubbing now, so that's good. And most of it's fine to sit for the weekend. And most of that stuff is fine to sit for the weekend.
Oh, is it? Usually, so you kind of go through and scrub it. Also, so when you do say scrub, that's an extra kilo of patients.
I literally did 14 days ahead. And I just scan over everything and make sure, like, here's an example. There's a patient that's Tuesday.
All right, we are going to keep things rolling today. We have 2 more talks before our lunch break, and hopefully our friends online are still with us. Our next talk is from Dr. Cobbs, who prepared his talk ahead of time because he's not able to be here. And as many of you know who've been attending all day, Dr. Cobbs is a neurosurgeon here with us at Swedish and has been our director of the surgical side of the Ben and Catherine Ivy Center for Advanced Brain Tumor Treatment. Dr. Cobbs has been many years over a Seattle Metropolitan top doctor in the field of neurosurgery. And we're going to be hearing today about some of his innovative and collaborative work looking at slice culture immunotherapy models for GBM.
Okay, well, it's a pleasure to be able to give a talk again for the brain cancer course that we hold every year. Sorry I have to pre-record this because of another place I have to go during the day of the course. But my name is Charles Cobbs. I am a neurosurgeon here at Swedish Neuroscience Institute, and been fortunate enough to be able to run a translational research lab here. And I would like to discuss a model we have in tissue culture that I believe will lend substantial support for the concept of a type of immunotherapy clinical trial that we're trying to develop at Swedish. First slide is to just state that I have conflict of interest with HDT Bio, which is a local biotech company who I'm working with on this project, and I'm a scientific advisor for the company. The essential issue that we're discussing today in this talk is the fact that immunologically, some tumors are cold and some are hot. Hot tumors like melanoma and some lung cancers have a lot of mutations, and that can be leveraged by using checkpoint inhibitor drugs to amplify the attack mode of cytotoxic T cells just non-discriminately. And when you do that, you can attack these tumors because they have so many neoantigens. Glioblastomas and most other solid tumors fall into the category of cold tumors, and glioblastomas in particular are extremely cold tumors. And what I mean by that is not only are they devoid of cytotoxic T cells, but they have molecules that are expressed that promote the immunosuppressive phenotype of the tumor microenvironment. TGF-beta in particular is one that we see a lot. And T cells that are in these glioblastomas often have high levels of checkpoints on them, like CTLA4 and PD-1 ligand. And so one of the critical issues with glioblastomas is how are we going to get an immunotherapy to work when the tumor is essentially a force field that prevents infiltration of cytotoxic T cells. And so we know that checkpoint inhibitor drugs have not really shown great efficacy for glioblastoma because even when you give them, the T cells don't really penetrate into the tumor. And so part of that problem is that the microenvironment is full of macrophages and other cells that are in the so-called M2 phenotype, which means that they are actively promoting anti-inflammatory and anti-tumor immunosuppressive molecules. I like to go back to this slide, and so what I'm going to do is kind of take you through some concepts, general concepts of immunology and cancer immunotherapy. For years, we've known that most tumors that develop from epithelial cells, and glioblastomas are neuroepithelial, are thought to arise from either some type of inflammatory process or, in many cases, an infectious process. And in most events, when you have an inflammation of an epithelial layer, there are infiltrating macrophages and dendritic cells and monocytes, which are innate immune cells. But then you go back to the normal epithelium. However, in cancers, often you have microbes or chronic inflammation, and the infiltrating cells essentially do their job, and then you have a dampening of the subsequent immune system such that over time, if there's chronic inflammation or chronic expression of oncogenic elements from something like HPV, for instance, in cervical cancer, then there becomes a point where the microbes induce enough mutations and the tumor microenvironment immune system gets suppressed to the point where you make a transition from chronic inflammation to tumor, and the immune system is not doing its job. And just to go back to the basics of immunology, but it's very critical for the concepts of this talk, there are two arms of the immune system, the innate immune system and the adaptive immune system. Consider innate immune system function to be that function which has been pre-programmed genetically into you from millions of years of evolution, so that if your cells are exposed to certain molecular things like double-stranded RNA, which is specific for viral infections, or certain molecules that are seen in pathogens like bacteria, like lipopolysaccharide, then they have ingrained, million-year-old mechanisms to activate huge amounts of certain cytokines that will bring in immediately macrophages and dendritic cells and NK cells. That occurs in the first few minutes to hours of this exposure, and then these cells will then pick up little pieces of various parts of the cells that are infected or destroyed, go back to the central processing unit of the immune system, which is the lymph node or the spleen, and they will direct these so-called adaptive cells, B cells and T cells, tell them to expand and focus in on specific molecules, and that's the adaptive response. And it's thought that in cancer, there is probably an initiating event where you have a massive induction of innate immunity, and this is associated with these ingrained molecular pathways, and two of the sort of hallmark pathways are called RIG-I and toll-like receptor pathways. These pathways go up immediately upon exposure to a pathogen or some type of cellular damage. That leads to secondary infiltration within days to a couple of weeks of the adaptive immune system, where you may get massive expansion of specific clones of T cells that are specific to these molecules. These guys come in, and it's thought that during the evolution of cancer, for instance, if a pathogen is involved early on, you get an elimination of that pathogen. However, back to the HPV and cervical cancer analogy, if that pathogen is not completely eradicated or there's multiple rounds of infection over time, then that pathogen can alter the genetics of the cell and maybe make those cells become resistant to the effects of the T cells, and they can actually reprogram those T cells to go from cytotoxic T cells that are active to cytotoxic T cells that are, quote, exhausted T cells that have immunosuppressive functions, and they can even change the function of the infiltrating macrophages, et cetera, to make the environment for the tumor immunosuppressive. And that's called the equilibrium state, which leads to escape, where the immune system in that tumor is actually promoting immunosuppression, and it's allowing these tumor cells to outgrow, and that's when cancer rises. In the last several years, there's been an increased interest in the possibility of leveraging sort of the innate process of your immune function for various tumors, including glioblastoma, and this is from a review article. The concept is, if we don't have specific antigens in glioblastomas that we can target with CAR T cells, whatever, et cetera, can we leverage that process of activation of the innate immune system to reboot the immune system to get it back to functioning? And so, as I mentioned, there are innate factors in the cells in a tumor or anywhere that are specific and responsive to pathogens and to damage. These are so-called pathogen and damage-associated molecular patterns that I briefly mentioned. Would it be possible to take a glioblastoma, which is a cold tumor, and insert something or do something to the tumor that would dramatically induce these pathogen and damage-associated molecular patterns and essentially reboot the immune system, and, you know, if the tumor is in this state, drive it back so that you have a massive innate immune response, call in a whole new squad of infiltrating T cells and immune cells, which would look at the tumor for the first time in a long time as a abnormal environment. And there is evidence in that setting that even if you don't have specific molecules you're targeting, if you can induce that response to the tumor, and especially if you can do it in the setting of a pathogen, then T cells may come in, attack the pathogen, and there is something that is a very interesting phenomenon called epitope spreading, that in that environment, all of a sudden, these infiltrating cells may also say, hey, there's a tumor here, and they may reboot the original anti-tumor response, and so you can get clearing of the tumor. So just to briefly discuss a couple of mechanisms that are used to activate innate immunity, there's a molecule that's been around for a long time called poly-IC, and it's basically a synthetic molecule that looks like double-stranded RNA. And as I mentioned, when you have double-stranded RNA, it can activate both the RIG-I pathway and the toll-like receptor pathways, and these are two evolutionarily conserved pathways in all mammals that dramatically activate interferon activation, which sort of reboots and re-establishes the innate immune activation of the tumor, and that would lead to increased inflammatory cytokines, increased dendritic cell infiltration, and reshifting of that immune suppressive microenvironment to a more anti-tumor microenvironment. And people have been studying viruses that are associated with glioblastoma. One that my lab has been involved in is cytomegalovirus, and they've shown that if you have a person who's been exposed to cytomegalovirus or an animal, then you can actually, by rebooting this innate immune system in the setting of adding viral peptides that would call up a established immune response, you can dramatically increase the effects of this for the effect of the activation of the innate immune system, essentially trying to artificially produce innate immune activation and the setting of a viral infection to really bolster that innate immune function. So it's not just theoretical. There was a paper, there have been a few papers over the last few years that have investigated this concept called peptide alarm therapy. One of the key investigators is at the University of Minnesota, Dr. David Massapust. But this paper came out a couple of years ago that was really striking to me by Dr. Schiller at the NCI, who's a leading cancer immunotherapy researcher at the National Cancer Institute. They decided to study the activation of the innate immune system in the setting of recall for cytomegalovirus using solid tumors of different types in the sub-Q model of mice. And essentially, they gave mice cytomegalovirus infection at birth, waited 6 months, and they implanted tumors into the mice. And they gave various combinations of either nothing, saline, and all the mice died at essentially day 30, or they gave poly-IC, which is the molecule I mentioned a minute ago that makes the cells think that there is a double-stranded RNA and it induces gamma interferon in the innate immune response. When they gave that alone, it did increase the survival of the animals. However, if they gave the poly-IC plus specific peptides that the T cells for that mouse had been trained on for the cytomegalovirus infection, kind of a lot going on, but basically they added peptides to the tumor microenvironment, and it allowed the T cells that had already been established and were memory T cells to see this pathogen and activate those T cells in the setting of activation of the innate immune system. When that happened in combination, there was a profound anti-tumor response that was not just against the pathogen, but it was also able to eradicate the tumors. None of the mice died in any of these situations when they received activation of innate immunity by poly-IC plus recall of a prior infection using peptides against CMV. And it's worth noting that in humans, for whatever reason, about 10% of a lot of people, even up to 30, 40% of some people's complete T cell memory pool is specifically dedicated to cytomegalovirus. And that virus, is common in most adults. About 80% of adults have been exposed to CMV. So my lab, which has already been studying CMV and glioblastoma, we had a slice culture up and going that we were using to do other types of studies. And basically, in this situation, we take out a tumor and we can slice it in 350 micron sections, and these can survive for several days in tissue culture media. And we can study them, and this is just a H&E and a CD8 cytotoxic T cell stain, where you can see there are CD8 cells in the blood vessel here, but hardly any cells exist in the tumor, and that's just classic for glioblastoma, where there is essentially no active immune function going on in the tumor, and that's so-called cold tumor illustration. About this time, and about the time I had read that paper from the lab at the NCI about activation of innate immunity in the setting of CMV, I was lucky enough to be introduced to some colleagues that work at a local biotech company It's one of the leading makers of RNA vaccine technology. They have a proprietary molecule with a lipid core surrounded by RNA that is made to not only go into a cell specifically, but also to amplify the signal on the RNA. And one of these molecules is a molecule that activates the exact same thing that you see with poly-IC. So it is a profound activator of toll-like receptor 3, giving that signal that there's a viral infection to the innate immune system. So essentially, if you inject this molecule, it goes into cells, and then they start expressing high levels of the molecule of interest. And we tested it in glioblastomas by first using a molecule that they have that expresses GFP, EGFP, which is a fluorescent marker that turns green. So we would take out a glioblastoma, and on the chunk of tumor would be injected with this molecule and sit overnight, or else cut into slices, and we would put the molecule in the media, and we could see a day or so later that there was diffuse and high levels of expression of the GFP green fluorescent protein throughout the glioblastoma from a patient. So we had the concept that what if I took out a tumor and we wanted to test the ability to activate the innate immune system and do that in the setting of recall of CMV peptides for a patient. And of course, the patient needs to have been exposed to CMV, which is not hard because, as I mentioned, 80% of adults are positive. So we have done several experiments, and I'll illustrate one of the results that we had based on this study, and I think that this is quite exciting and could lead to a rational basis for a clinical trial. So essentially what occurs is we take out a glioblastoma, we put it in a little thing that looks like a sausage slicer and slice out 350 micron pieces of the tumor, and these go into tissue culture. And then in that setting, we can either treat it with just nothing or with the HDT-401, which is the lipid RNA molecule that gets into the cell and produces high levels of essentially a signal for toll-like receptor 3 to activate innate immune function. We can do that alone, or we can do that with adding in peptides of cytomegalovirus. And this patient that we did it with was CMV seropositive, so they had a prior immune system response to CMV. And then we also did it after doing that, plus adding some of the patients' PBMCs, the white blood cells into the media to see if the tumor cells could express certain things that would be amplified by actual immune cells being in the setting of the tumor. And this is an illustration of some of the cytokines that were studied. This is just one case, but I think it's exciting to show some of the things going on. Some of the critical cytokines that are involved in taking a cold tumor and turning it into a hot tumor are inflammatory cytokines like IL-6, tumor necrosis factor, interferon gamma, IL-12, GM-CSF. This is actually a cytokine that is immunosuppressive, so if this goes up, it'll make the tumor more immunosuppressive, and if it goes down, it'll make the tumor less immunosuppressive. So what did we find? The very interesting thing is that at the baseline, without any treatment, these inflammatory cytokines, IL-12, gamma interferon, at day one is in black and day 3 is in gray. At baseline, At baseline, there's hardly any expression of inflammatory cytokines. If we were to add the HDT-401 activation of toll-like receptor 3, you do get induction of IL-6. You get pretty significant induction of tumor necrosis factor. You get some interferon gamma production, but not so much from IL-12 or GM-CSF. However, if we give HDT-401 plus the viral peptide, we get increased expression of some of these inflammatory cytokines. But what is really exciting and really striking is if we give all three HDT-401, CMV peptide, and PBMCs, you can see that at day 1 and day 3, you start getting a much higher level of expression of these cytokines. For instance, with all three of those constituents, you get a 1,500 fold increase in IL-6. After 1 day, you get a 400-fold increase of TNF, and gamma interferon, essentially several hundred-fold increase in gamma interferon by day 1. So this is consistent with activation of innate immunity in the setting of viral infection and activation of innate signaling pathway toll-like receptor 3. And I'd like to kind of hone in again a little bit on just gamma interferon. As I mentioned, gamma interferon is one of the most critical activators of innate immune function, and it has the ability to really alter the tumor microenvironment to make it much more hospitable to inflammation, infiltration of dendritic cells and macrophages, and alteration of those cells from an immunosuppressive to immune activating phenotype. So just this dramatic increase of gamma interferon by the addition of this RNA molecule plus CMV peptides in the patient's own white blood cells is quite striking. And just to show, this is a schematic of what gamma interferon can do to a tumor microenvironment. Macrophages, which are often seen in in the glioblastoma microenvironment, which are immunosuppressive, can be reprogrammed to become inflammatory. And this also can induce upregulation and maturation of dendritic cells, infiltration of dendritic cells, to really reboot the immune system. And all of that can induce infiltration of T cells to activate more of an antiviral response. And in that setting, we believe it would lead to also this off-target anti-tumor epitope spreading response. So based on these studies and some animal work we're doing now, we are working with HDT Bio to try to come up with a phase 0, phase 1 protocol for clinical trials where we would potentially do a brain tumor biopsy, for instance, in a recurrent glioblastoma setting, and inject in doses, increasing doses, the HDT-401 molecule, and then resect the tumor and see if we can get infiltration of cytotoxic T cells and increased activation of cytokines. Simultaneously, we would do a dose escalation of CMV peptides in seropositive patients, and then consider combining these at some point to see if we can essentially recreate in a patient what we have been able to recreate in a dish and in animal models, which would be a alteration of the cold microenvironment to a hot microenvironment, and hopefully anti-tumor response akin to that seen by the NCI group that is doing these similar studies. So couldn't have been done without a huge amount of great work from the folks in my lab, Dr. Hoti, Yoon, Dr. Lee, and several of my colleagues at HDT Bio and other members who have helped out. And this is supported so far by primarily the Susan McGregor immunotherapy grant that we have, and a recent grant that we just got, as well as the Paul Allen Research Award. So thank you very much.
I must say that's a clever way to get out of having to answer any questions from the audience. Our next speaker, and the last speaker standing between you and lunch, so hopefully you're not too hungry, is our newest addition to the department here, and somebody that I'm very pleased and proud to call a partner. Dr. Mary Kim, who joined us out of fellowship at Yale New Haven and residency in Loyola, will be presenting to us today on molecular updates in the diagnosis and prognostication of meningiomas. Mary?
Great. Good afternoon now. Do my slides just come up on their own, or? This one. Okay. All right, great. So I really enjoyed all the talks today. It's kind of a little union of all things that are very exciting and interesting to me, including the role in palliative care, and then also the molecular studies that are coming out with everything. And to add to that, I wanted to briefly discuss meningiomas, because I feel like this is sort of an underappreciated tumor that in recent years has come to the forefront of a lot of molecular advances. And I also wanted to do a brief review of an update regarding these meningioma classifications. So very briefly, these are tumors that arise from the arachnoid cap cells of the meninges. And because the brain and spinal cord are just surrounded by the meninges, meningiomas can arise anywhere along the central nervous system. These tumors grow outside of the brain. They usually present by whatever symptoms they cause due to compression of the nearby brain tissues. And because of the variability in the location, as well as the eloquent brain areas that might be adjacent to the tumors, the presenting symptoms can be incredibly variable. And of course, as imaging techniques and as patient lifespan has increased, the incidence of identifying these tumors has actually increased. And so a little bit of history. Meningiomas actually weren't always considered a benign pathology. In the 18th and 19th centuries, hyperostotic and outward physical changes were actually what led to the diagnosis of meningiomas. Early attempts at surgical resection of these tumors generally presented with incredibly high mortality. Victor Horsley had endorsed a 46% mortality rate in the early 1900s. And of course, as many advances in medicine back in the day sort of changed the landscape for these tumors. So Harvey Cushing had deeply studied these meningiomas and had put out a case series of about 300 patients between 1902 and 1932 to document his experience of these tumors, and thankfully was able to get the mortality rate down to less than 10%. I think what's really, meaningful is that back then he said there is today nothing in the whole realm of surgery more gratifying than the successful removal of a meningioma with subsequent perfect functional recovery. And I think that still kind of stands true today too. And of course, thankfully in the modern era, we're not faced with the same high mortality, but there are other challenges that come with meningiomas instead. And so these are the most common primary CNS tumors. There's an incidence of about 9 per 100,000 in the population. It's more prevalent in women than it is in men, and noticeably after the 5th decade of life. And so in this red box, you can see that this blue color of the pie chart, it's about 37% of CNS tumors. And there's a small wedge adjacent to that is about 0.4% of all CNS tumors that have been deemed malignant. And so, of course, due to their variability in location, the presentation of these tumors can be very different. And so, historically, these have been graded from 1 to 3. And the WHO grading landscape has mostly been with a histopathologic analysis of these tumors. These are the descriptive findings based on what they see under the microscope. And, this has been sort of the standard way that meningiomas have been assessed. And you can see on the right that The recurrence rate for what was deemed grade 1 is about anywhere from 7 to 25%. Grade 2s are 29 to 52%, and then grade 3s anywhere from 50 to 94%. These are very, very large ranges in terms of recurrence rates. So in 2016, the WHO actually released an update on meningioma classifications, and this still relied heavily on histopathologic characterizations. What was interesting, though, was that in comparison, glial tumors and other primary brain tumor types started to have more molecular classifications that were being integrated into the pathology. And really, it wasn't until 2021 when the WHO classifications were updated, and it included 2 optional molecular criteria for meningiomas, and they were for WHO grade 3 tumors. So here's a whole list of the tumors that were updated. Meningiomas occupy this tiny little wedge here, and it continues to remain a single entity. But even within this entity, there's 15 different subtypes. And this table here shows the molecular subtypes that are including the TERT promoter mutation, as well as the CDKN2A and B homozygous deletions for these WHO grade 3 meningiomas. But, despite these molecular updates, the WHO grading system still has a lot of limitations in terms of predicting recurrence of these tumors. So outlined in this table over here, we can see some general guidelines that we've been using for the treatment of these meningiomas. And so if you look at the top, there's no mass effect on these findings on MRI, then usually patients and physicians will opt for observation. Let's say the tumor does have significant mass effect if their patient is symptomatic. And I would also add if they've had some radiographic growth over time, then after careful discussion with the patient, if they're interested in an intervention, you can see that there are options for therapeutic intervention. Historically, surgery has been the primary means of intervention, and sometimes patients who are not in the best clinical state may not be the best surgical candidates. You can also opt for radiation to be an option as well. And so as we continue along this algorithm, when you do your surgery, there are different grades in terms of the extent of resection, and then sometimes this can also help guide the patient as well as the clinician and surgeon about what the next steps would be. And so, of course, I'm sure many of you guys are familiar with the Simpson grading, which is the extent of the resection of the tumor. That, in addition to the histopathologic grading of the tumor, you can opt for observation, more treatment, or experimental therapy if there is something that is readily available as an option. And so as we've been learning more and more about these meningiomas, we've seen that with the inclusion of the TERT promoter mutations and the CDKN2A genetic changes, we've also seen an increased interest in just general meningioma genomics. So basically, in maybe like the last 10, 15 years, there's been a huge boom in the genetic profiling of meningiomas, and this has also included methylation profiles, which has included identified 6 methylation subtypes. So in this paper that came out in 2013, you can see that there's a variety of driver mutations that are associated with anatomic location of these tumors along the skull base. And then as they continue to study at a more molecular level, a lot of nuanced features of these tumors began to emerge. So when you better understand the molecular subtypes, then you can also have a better prediction in terms of the recurrence rate for these tumors. So in patients that have had hedgehog mutations, NF2 mutations, TRAF7 mutations, and even the PI3K mutations, they have nearly a 27-fold increase in recurrence rates compared to other tumors that have the KLF4, polar, or SMARCB1 mutated meningiomas. And these are studies that have been going on for, over 50 months. So, in addition to these genetic molecular changes, you can also consider copy number variations and again, methylation profilings, as well as looking at somatic mutations within each patient. Additionally, there have been imaging studies that have come out. So patients have been looking at, or radiologists actually, with dotatate PET scans. And so this is a scan that looks at the somatostatin receptor ligands that are generally found on these meningiomas. And this can help with tumor diagnosis, as well as delineating where the tumor margins are. So with the C-Impact Now Update 8, this was a publication that came out pretty recently. It clarifies a lot of the pathology and the histopathology, and then also for tumors that are sort of in between in terms of their molecular classification, it helps put them into a bucket that'll guide what we as surgeons and neuro-oncologists and medical teams can do for our patients. This is the flow sheet that now includes a CDKN2A and N2B homozygous deletion, as well as a TERT promoter oncogenic variant. And then that'll shuttle these tumors to be CNS WHO grade 3 tumors. And then when we look at the next part of this, these tumors that might have borderline findings that are soft calls for either grade 1 or grade 2, molecular testing can really be helpful to further guide the histologic findings that we see. So then if you have a lower grade molecular profile, then you can bucket it into a WHO grade tumor, versus if you have high risk features like a 1p or 22q loss or any other major chromosomal abnormalities, or if they have a higher risk methylation profile, these previously thought to be reasonably benign tumors can now be pushed over to the grade 2 bucket. From a histopathologic standpoint, they've clarified a lot of the findings in terms of defining mitotic activity. So we really need to make sure that the slides are good quality slides. And then the updated features are, instead of being anywhere from 4 to 19 mitoses per high-powered field for grade 2 and over 20 mitoses per high-powered field in grade 3 tumors, they've actually created an area so that you can find a certain number of mitoses. In terms of brain invasion, they clarified that the brain invasion should be truly infiltration of the tumor through the leptomeninges, rather than just kind of coursing along the Virchow-Robin spaces. And then for this study, really the tumor sampling is critical for this assessment, right? If you get a sample from the core of the tumor, you're not really going to be able to see whether or not the brain invasion is truly there. But if you get it from the periphery of the tumor, then of course the likelihood of finding true brain invasion is much easier. And then they've also added this brain invasive meningioma, otherwise benign type of category, which I personally think I need to study on a little bit more as well. So, with all these things that are changing and updates in the molecular features of meningiomas, there's sort of a new evolving landscape of them. And so what was initially, back in the day was thought to be a really terrible and high mortality disease, the landscape has transformed into something that is more treatable. And you see papers that are being published that have these really complicated molecular aspects to them that's integrating like the methylation profile, the proteomics, the genomics, the RNA sequencing, and everything. And then they're looking at survival. So when you take everything into account, all these things can really help to guide what we do in terms of extent of resection, guiding the patient and having the discussions about future treatments for the patient as well. So looking to the future, once we sort of have our current methodologies right now, we look at the histology, the proliferative index, and the brain invasion. And then we started to slowly incorporate some of that genetic data. And then also with our known extent of resection, we can start to look at what's evolving and emerging in terms of the technologies that we're using to better characterize and define these tumors. So by looking at the full whole exome sequencing, looking at chromosomal abnormalities, incorporating methylation profiling, we can start to build for the future, at least, an integrated molecular and methylomic classification. And then hopefully if we find targetable treatment, targetable mutations, then we can actually maybe start to integrate some sort of, chemotherapeutic agent or something that's a little bit more targetable. And ultimately, I think that by integrating everything that we know about meningiomas, we can start to have more prognostic and predictive algorithms that develop from all these different studies. So it's still a tumor that is revealing itself to us. And I think that over the years, as our own sequencing and analytical methods start to advance, then we'll be able to help guide patients a little bit better, because meningiomas, they're the type of tumor that will come back, and even if it's a grade 1, even grade 1 tumors can still be pretty devastating for patients. So being able to understand them better and then understand the patient, I think that we can do a really great job of helping to guide these patients in their treatments. And so with that, thank you.
Thank you for a wonderful talk.
Thanks.
I had a question looking at the CMPEC Now 8 guidelines. One thing that I kind of wish they would be a little bit more clear about is which molecular testing in which moment, especially when we reference methylation profiling, but that's difficult to access. One specific question I have is when do you think FISH should be obtained, which might then trigger NGS?
That's a good question. I feel like with the way that that sequencing platforms are advancing, FISH just might be out of the question, and you can just send it for sequencing anyways. We've been hearing all these talks about different mutations that might come up, and they might be variants of unknown significance and all these different targets. So just by having that whole exome, sort of like global view of the tumor, I think that might be, we might get to a point where that just becomes, a reflex pathology assessment. So yeah, I don't know whether or not FISH really has a strong, home in meningioma pathology just yet.
All right, thank you again, Dr. Kim. And with that, lunch is served. We'll see you back here 5 minutes to 1, please.
Remember that we need to talk. Oh my God. Ooh, fancy lunch. I like it. I don't know if I already long. We all three of us are on call together now. Right. I've been trying to. I don't know if it's a good thing or a bad thing. You may try that. This is like yeah. It's all for you. I don't know, hold on. So. Nope. There's a specific axon. Do you still want to do the yeah, towards the end of Monday, but really close hearing. Oh, we met. Okay. Have you looked at the
No, but now I've heard that from, yeah, a lot of it's based on that. I think the hard thing is like, because that story's already happened. Oh, yeah. Yeah. That's the first time. And then it's like, okay, well, they will get another house. Well, thank you. I felt like that. Did you ever go to that charity conference? Yeah. Yeah. It was really good, don't you think? Right, They didn't talk about this there.
Now's the time.
Oh, they talk about screening guidelines.
And it's only one trade, so I think you could find a card pretty good without it.
Because that's where I got it, because I wouldn't.
I'm gonna go grab a for it, but he's gonna meet you.
Yeah, probably 2019 is when I got it. And the new guidelines were published yet. They talk about these studies, targets, and also very interesting. They're cheap. Cheap and cool. You do have lunch? Yeah. We just said this all.
Yeah, for sure. Having something count. Two CEOs like that. Now the third CEO. It's like we're asking for an asshole. It's like, well, sorry, it's gonna get private and sick. Like, what am I supposed to do about it?
It's like a weird awkward, training in there. And so they asked, hey, can you guys work on that's like a whole gig. They have two, potentially two accounts in there. Oh, yeah.
It's kind of nice. I've heard about him. Oh. Oh, that's not okay.
Yeah.
I've heard of them, but I've never actually met
Yeah.
Everyone's in the case.
Yeah, that's fine. It's nice to do something. Love I've done that.
Wow. Can you imagine? That's a lot of work.
Exactly. I value so there is that. I did that. No, I liked it a lot. It was
That's a good commitment with the OP, it's just like not easy either.
Why am I doing it? Yeah, it's pretty.
It's a lot of time. There's too much time.
Yeah. My work goes on this.
Wow. That's really good. Yeah, and I did yarn implement Mondays and then usually it's like, that's and holding all the snow in my meeting. Oh, I did show the pictures, did I? I'm sure. Yeah, it was terrible. It was like, it's beautiful, but that's a road. Like I can't drive on that. My dog's too old. It was so much snow and then it melted on that Saturday and then froze. So then it was like just ice this morning. It's so dangerous. That's why I was like, I try to wait for the sun to come out so I can be, there's a little bit more melted. Oh, already?
Yeah.
So you just take the information film, how you got it, you don't wanna do it. Next year teaching us, but it's so nerve-wracking. I will feel not good about it.
That looks like an easy.
I mean, you don't have to.
It looks good. I thought I remember that. I was just thinking about that. I think they gave us. Yeah, it's like admin. It's so busy. It's hard to get it. Really? to know a little bit more because Christina was by herself. That's really super crazy. We just kind of Wednesday, they were kind of full. I don't know if they're doing Tuesday. Oh. And you guys leave on Wednesday or Thursday? Yeah, every time I cover other teams. It's just kind of. It's a disaster. I'm with Sarah. The Sarah usually takes most of Oh. Christina's not even on that list too. Don't put her on the call list. She doesn't hear the name.
All the circles.
Oh, I didn't realize that. Brings his teaching just like Sam's car. So that's why it's a little bit of a lot. Brick. The same policy. Oh.
Hey.
Hey. How was the chicken? It's crunchy. Yeah. I was like, yeah. I was hungry though. I ate last night so bad. I went to bed like 3 hours later. I was just like, oh, I ate so much. Yeah.
It's also that amazing fattier than
Yeah.
I used to eating. It was good though.
It was so good. You stumped me with that. I couldn't really see the. Normally I look at the T2 for those because that's what really pops.
The tiger stripes?
Mm-hmm.
I disagree. I think it's always much more obvious on the Tumor.
Really?
Yeah, because it's all distorted. And then when you see the anatomy, you're like, okay, that I can see the foliar like outer cortex, and that this is. But Medjova's always. I feel like Medjova's I think can look really weird.
As long as it's covered, it doesn't matter.
Non-enhancing.
Sometimes people.
And restricting at the same time.
Yeah. I find them challenging.
I have one right now, actually. Leah just, or no,
a patient.
Lisa just, sorry?
A patient.
Yes, yeah, I have a Medjola right now, and I'm in trouble. Yeah. Yeah, he's starting, chemo like in a month.
He finished radiation already.
Mm-hmm. With you guys.
We have like a bevy of great arms. That's crazy.
I know. Lisa, is it I or me?
Oh, I don't even know her yet.
Oh, okay, she's the one I was working with.
Yeah.
I figured she was a CNS person.
I believe she is, but then we also have Shannon Fogg and Sarah Hardy came. So she did neurology training and then did radon, and she came from Rochester.
Yeah.
And her research stuff is really good because a lot of it's about like geriatrics and frailty stuff.
Oh yeah.
You know, and using all that instead of age. And it's great. I mean, she's a oncologist. I really need to see
Great.
That's crazy. We have all those-
Yeah, you guys are growing.
I know, we have two positions open. Have you talked to Janet lately?
No, last I heard, she took the Kaiser job? Okay. Well, she had family down there.
Yeah.
I figured she was gonna
Parents
do
were
that
there,
just because of
the
family.
kid.
Yeah, it's hard to compete.
Yeah. I told her, I was like, that's a really hard decision.
Yeah. But also that job, like, seems really well supported, like surprisingly.
Because what I've been told is the main tumor surgeon there insists on it.
Okay.
So, yeah.
I gotta get Syed.
And then Kaiser uses this as a hub.
Yeah.
You know, so they have people all over Kaiser, California do like televisits with them.
Yeah.
So one patient even like the Kaiser flew her from Hawaii to there.
Wow.
To go see them, or to have her surgery there. So. But like nobody I know knows those two neurologists that are there.
Huh. Like, they must have a pretty big volume for 3. I mean, that's.
Because I think they're telecovering all of California.
Wow. Yeah. I mean, there's nobody in Southern.
They're pretty.
Famously, there's no Kaiser neurologists in California.
Because I think they've just made that their hub and they do televisits.
Yeah,
from there. They're like, why would we hire a team?
To examine your patients. Okay.
And if they find it, they do it. Good. What else have you been up to?
Trying to keep my head above water. It's been really busy. I'm in that stage where a very large portion of my patients are at the end of life. And so now it's even busier than normal, but then it's, I'm about to have no patients.
Which I'm sure should it'll balance.
It will, it's just I haven't taken new patients in like 6 months.
Wow.
Yeah.
So she must be completely full.
Not completely full. I mean, she's seeing like 6, 7 a day. So, yeah. Yeah. But, I don't know, just the last couple of months have been ultra stressful.
Where'd you go on vacation?
I'm going on vacation to Koipu.
To where?
To Kauai.
Okay, that's right. Good. What's the last time you went on vacation?
Palm Springs. 2
Okay,
months ago.
okay,
Yeah.
good. Good.
It's just like long weekends here and there, but that's enough.
Yeah.
You know.
That's enough to get you through. But yeah.
I remember when Teresa was going through this, because like she started, she got a big bolus of patients and like natural history. Yeah. Anyway. Yeah, but otherwise,
a lot of that.
I don't have time. I would.
Good in a way.
Yeah. I've taken over the lymphoma service, so I'm admitting lymphomas at First Hill, which has been a lot of work, but also really fun.
And that's the thing with
Yeah.
it, right? Like I like doing it, but then it's like,
It's worth it. It's so fun to like see people go from nearly dead to.
so you're treating them in this building?
No,
So you live in it.
I have to, yeah.
But please tell me you're not the general record.
I admit, and then the doc of the day, the hemonc doc of the day rounds. I don't go see them on the weekends, although I could. Hey, what's up? Oh, thank you. Okay.
The things I don't ever eat is what I want. Like I eat eggs every day, usually one eggs.
Let's go sit down. We were live streaming our conversation.
Oh, really?
Yeah.
Coke, yeah, child loves Coke.
I should have thought of that. Yeah, that would be.
In Vegas.
Oh, yeah.
Yeah, thank you. Please help. She's gonna give me a hard time. She has like no cerebral. Yes. You see the doctor out last Thursday, and I texted her like, "Thank you for the best Christmas present ever." And then she recovered 4 weeks and bounced back. And then I did have one like these are bothering them. She's very bad, like cheering and everything goes on. And then she just starts crying. Oh no. And I was like, no, don't cry. You cry after I cry. I don't know if that's good. I don't know, I've been sassy today with my patients. Like, my pain is not managed. Like, you are on every pain med I could possibly get you on. You're not gonna have no pain. Like, I told them, no, it's gonna make it better if you get out of bed. Because I said, I'm getting me out of bed. I'm like, well, then good luck with your pain. I don't know what to tell you. Sorry, what about my Terry? Yeah. So, she was very worried about her nausea initially. So she has no grab symptoms after the she seems like she's gonna be a little bit of a hard. I bet. She was willing to go to the chair after I pushed her. But I walked in there and she's pretty sleepy. Yeah. Yeah, I told her stop. Oh, yeah. She seems like, but is that what your practice is? Right, exactly. Feel better. Right, and so. Yes, I go on. Okay, all right. Is she floored? Or she's floored? Okay, yeah. But I usually in all of our people. It's terrible, but sure. Yeah. I love covering our patients. It's like a cleanup crew every week. Recovering. So I think even though she may take a little time, she's I love your eyes. So helpful. They're so helpful. It's like our patient who said, I didn't know I wasn't supposed to have a full breakfast before surgery. And then the next day, when we flew him back to Alaska and back, and then he couldn't get in for surgery, I told him, Dr. Levak told him, Chief told him, and then Pauline, when they and I think I asked him to get that. It's like, this is the fourth time somebody said something to me, and I was like, can't forget it now. This is cheesier. But he did the same thing to himself. He went home and I said, he's going to shower today. I saw him, I think 4 days later, and I was like, have you showered? He's like, no. Nobody told me. Oh my gosh. I will shower. I don't feel like a shower. I haven't felt we did social wash. I did. It was like 2 months, 3 weeks, no shower. I don't get it. I feel like I want to wash my hair at least. Yeah. So true.
Let me know when I'm live.
Oh, so that we can be, that's that. That's a big hemorrhage though.
Okay. Do we have our speaker?
Yes, I'm here.
Oh, great. Great. Welcome back from lunch, everybody. So I want to introduce our next speaker. It's Dr. Adrienne, is it Boire? Am I saying that right?
Repertoire, like repertoire.
So Dr. Boire got her MD at the University of Chicago and her PhD at Tufts. Did a residency in Columbia and then a neuro-oncology fellowship at Memorial Sloan Kettering, where she remains, and currently has a laboratory and is scientific director of the Alan and Sandra Gary Metastasis and Tumor Ecosystem Center. She's done some really interesting and novel work in the space of the physiology of the leptomeningeal space, and I've been sort of a fan of her work for some time and excited to hear her talk today on that topic.
Thanks so much for that really kind introduction. I hope are my slides in the correct place? Are you seeing the correct view? Yeah? All right. Fabulous. So I'm very excited, of course, to talk about the leptomeninges. My laboratory studies metastasis to the leptomeningeal space. And just to remind everyone and reorient you, remember the leptomeninges consist of the pia and the arachnoid, and they contain the circulating cerebrospinal fluid. They encase the entire CNS, and the spinal fluid that they contain is nutritionally quite sparse. And so they're kind of an anatomically isolated and nutritionally sparse environment. And it would seem pretty improbable that they would host metastatic disease, but of course they do, otherwise I wouldn't be here. When they do, we usually use the term leptomeningeal metastasis because any tumor can result in leptomeningeal metastasis, not just carcinomas. And in modern practice, the major contributors to leptomeningeal metastasis from solid tumors are breast, lung, and melanoma. Unfortunately, the survival for these patients is quite grim, with an overall survival on the order of months. And so that just tells us that we have a lot of room for improvement. So one of the central paradigms in metastasis research comes to us from the Victorian pathologist Stephen Paget. And his famous seed and soil hypothesis, which I've written out here, has proven really durable as a metaphor because it captures this interplay between the intrinsic factors of the cancer cell and the microenvironmental selective pressure. I find this fascinating. However, when you visualize this in your head, you think about this, right here we have a bean seed in like this very loamy, delightful soil. And the thing is that I just finished telling you that the leptomeninges are a rotten place to live. And I think it's important to kind of remind ourselves that extreme microenvironments and extreme environments are capable of hosting life. Life finds a way. It's sort of the power of evolution. And so, this is the picture of kind of the sea floor, with all of the bacteria that can live there. So I think it's important to consider that soil that isn't congenial, to use Paget's term, can host cancer. And so one of the questions is, how do cancer cells adapt to the scarce nutrients that are around them? Or just rather than the loamy soil, visualize these plants in the desert. So I'm going to tell a couple of stories briefly today. One of them is the kind of the first story that came out of my laboratory, where we were it was our first stab at understanding this process. All pun intended, because we started with spinal fluid, right? So we took a look at spinal fluid collected from patients with newly diagnosed leptomeningeal metastasis from solid tumors, in this case, breast and lung cancers. And for these patients, we collected the spinal fluid and carried out 10x single-cell RNA sequencing. And what we found that was really cool was that, yes, we found cancer cells and immune cells like you'd expect, but the cancer cells clustered together. And that was surprising because that hadn't been seen in other data sets of metastatic disease. And that's something that hadn't been seen since in a lot of other metastatic sites. Usually, different tumors from different patients don't cluster together. And we thought that this reflected a conserved transcriptional response to this extreme microenvironment. So the selective pressure was so intense that it was forcing the cells to adopt a similar transcriptome. So when we tried to interrogate this data set, we thought about the selective pressure that these cells were under, and we thought about that irritating table that I showed you before that is from a lot of your kind of basic neuroscience textbooks. And we thought, what is the source of extreme pressure in this environment? And we thought iron is most limiting in this environment. And so we examined iron uptake in this space. So the postdoc that took this on, Yudan Chi, one of the things that she thought was that first you need to address the null hypothesis, right? Maybe the cancer cells don't really need iron, and so therefore it is not limiting for them. So she took a look at the levels of hepcidin, which is the hormone that's released from cells that are iron deficient, and transferrin, which is the canonical iron transporter that we all remember from basic physiology. And we found that the levels of hepcidin were elevated in the spinal fluid of patients who are harboring leptomeningeal metastasis, but the levels of transferrin were equivalent. So that told us that, yes, there was some iron deficiency in this space, but no, they weren't using transferrin to solve the problem. So we queried the data set, looking for genes that encode products that are associated with iron binding and iron transport. And that's what you're seeing there in that heat map in A. And then in B, you can see that we found just two transcripts that were associated with iron binding and transport that were expressed exclusively by the cancer cells. Lipocalin-2, which is an iron binding protein, and SLC22A17, which is the lipocalin receptor. So we've got a nice pair here. Then the next question is really, what are they doing, right? So then we pivot over to our mouse models to be able to answer those questions of why and how, and kind of more mechanistic questions. And we found that, of course, first, we found that the mice have disease that's quite similar to that we see in humans. So you can see this is a C57 black 6 mouse hosting cancer in its leptomeningeal space. When we do multicolor flow cytometry, you can see the cancer cells there in orange. And when we collect spinal fluid from either the mice or patients, we find elevated levels of lipocalin-2. So that tells us that, we're on the right track, at least in terms of the mouse models. Then to determine if lipocalin-2 was important for the pathophysiology, we knocked out lipocalin-2 expression from the cancer cells and found that inhibited growth in the space. And that's what you're seeing there in A and B. And then in the row below, what we're showing here is that we took cells that didn't have any real propensity to grow in the leptomeningeal space and didn't express lipocalin-2. And when we force those cells to express lipocalin-2, this accelerates their growth in the space and accelerates the death of the mice. So this, plus many other experiments, including an experiment here where we're measuring iron levels in the cellular material that we collected from the mice, led us to a pathway whereby inflammatory signaling from the microenvironment was leading the cancer cells to be able to generate lipocalin-2 and SLC22A17, and that those gene products were allowing them to outcompete macrophage in the microenvironment for this limiting iron, this scarce resource. So because the cells were all fighting over the same limiting reagent of iron, we reasoned that what we needed to do was to eliminate the iron from the space. We needed to chelate away the iron, so then that would inhibit the growth of the cells. So to do that, we used the drug desferoxamine, which is iron chelator in practice. And we gave it in a new direction. So rather than giving it either by mouth or IV, which are the standard routes of delivery, we gave it intrathecally to the mice. And when we did, either early in the disease course or late in the disease course, we found that that inhibited cancer growth in the leptomeningeal space. And chelating copper with D-penicillamine, that's the line in gray, didn't make much of a difference. Okay, so these data, and of course many others, prompted us to be able to open up a clinical trial of a phase 1 clinical trial of desferoxamine for patients with solid tumor leptomeningeal metastasis. The trial is still open and accruing. I can tell you that the phase 1A trial, phase 1A portion is complete. So we've found a dose. It's well tolerated, and we're even seeing an effect in terms of an effect in terms of the anti-tumor properties, which is really exciting. So if you have patients that have leptomeningeal metastasis and you're looking for a clinical trial, I know there are not many, this might be an option for you. Feel free to contact me. So the meat of the talk today is about a related story, which is this same idea of how do cancer cells respond to this microenvironment? Or as one of the people that was listening to a talk that I gave asked, he said, how do the cancer cells know they're in the leptomeningeal space? And at the time I thought that was such an irritating question, and now I think it's a really cool question. So Q&A is the best part of any talk. So to answer this question, the graduate student in my laboratory, Shinran, who took this on, she reasoned that, okay, if the cancer cells, these leptomeningeal metastatic cancer cells, we call them lepto-M cells, if they can grow in the leptomeninges and they can grow elsewhere if we implant them there, we can use those as a tool. We know that they have the capacity to grow in the leptomeninges and elsewhere. Why don't we use them as a biological probe? And she reasoned that probably there would be some epigenetic change because this is a big change that these cells are encountering. So she took the cells and she implanted them in either the leptomeningeal space or in the primary site. So in the case of LLC in Lewis lung carcinoma, that would be into the lung, or in 4T1 model into the mammary fat pad, the mouse breast. And then she harvested the cells and carried out ATAC-seq. And working with Richard Koch and Pejay Hamad, we were able to find that the chromatin accessibility of these cells are really clusters based on the microenvironment that they find themselves in. It's not a cell intrinsic property. It's really based on a signal that they're receiving from the place that they are in. When we did network enrichment analysis, we were delighted to find all kinds of developmental pathways that were upregulated. It's crazy. So many. Look at this. It's really hard to find something that's not a developmental pathway here. So we decided to pursue this angle, and we started to look at the chromatin landscapes, reasoning that we wanted to really focus on areas of open chromatin that were conserved between these two mouse models in the leptomeninges, regardless of whether the cells were adherent to the leptomeningeal space or floating in the spinal fluid. And so that would, of course, be group 7 here. And when we look at group 7, we find a motif analysis revealing that this retinoid X receptor is enriched in this space. And moreover, you can see that it's enriched more strongly in the adherent population than the floating population. So keep that idea in your head for later. We took a look at that at the level of transcription, of course, because if there's open chromatin, you would then expect there to be transcription downstream of relevant start sites. And we do indeed see transcription downstream of RXR, LXR motifs in these populations. So why was this exciting to us? It's because RXR is, of course, the retinoic acid receptor, and retinoids play these really important roles in nervous system development and homeostasis. I know you remember this from all of your prior school. However, I'll remind you that the retinoid signaling is a 2-cell system, right? So we consume vitamin A, we take up vitamin A, And retinol gets hooked up to a carrier protein called RBP4 in the liver, where it can circulate. And retinol bound to RBP4 is then taken up by the first cell through STRA6, where it undergoes a series of dehydrogenase reactions in order to be able to generate retinoic acid. Retinoic acid is a freely diffusible, nice and greasy molecule. Unfortunately, it's has a very low half-life. It's a pretty evanescent molecule, and it'll diffuse into the next cell. And that next cell, our retinoic acid, is then able to bind to its nuclear receptors, RXR or RAR, plus a co-receptor, and then can initiate signaling. So this is something we've seen all over the place in the nervous system, right? So classically, you think about mesodermal cells generating retinoic acid to signal to the neural plate in really, really early embryology. You think about the hippocampal meninges generating retinoic acid to signal to the dentate gyrus neurons, Schwann cells signaling to neuronal cells in the periphery, right? So we measured retinol, of course, in the spinal fluid. This was really difficult. So we had to work with our friends up in Boston, the Namakanorx lab, and we were able to find elevated levels of retinol in the spinal fluid of both patients and our mice in the setting of leptomeningeal metastasis, which was pretty cool. And so then we realized we have to solve a problem here, right? We've got to figure out who's generating the retinoic acid, so who's my generator, and then who's my receiver in the CSF. So the generator, that's going to be the one that's going to take up the retinol and generate retinoic acid through all of those dehydrogenase reactions. And then the receiver cell, well, that's probably the cancer cell, right? So we have to figure out what the cancer cell is getting out of this relationship. So for the first part of the question, we started thinking about the PL cells. So remember that PL cells are descendants of neural crest, right, in the forebrain, and direct descendants of mesenchyme in the midbrain and hindbrain. And so both of these cell types are known retinoic acid producers in the leptomeningeal space. And so it seemed like they might provide a nice local source of retinoic acid. And indeed they do. So when we stain up our leptomeninges in our mice, you can see that in the presence of leptomeningeal metastasis, you can see that these mouse leptomeningeal fibroblasts are expressing RALDH1 and RALDH2. You can also see that that's kind of a mess in there. You can see that those leptomeninges become quite raggedy, even in a pretty well-controlled mouse model. The same thing is true in the case of human meninges in our autopsy specimens. We can see elevated levels of RALDH in the meninges of patients who have passed away from leptomeningeal metastasis. So what might be downstream of retinoic acid? Well, remember, we were really interested in RXR, LXR signaling based on our ATAC-seq. So we thought about other physiologic contexts where we've seen RXR and LXR signaling, and that of course would be within the liver, where this signaling leads to de novo fatty acid biosynthesis, cholesterol efflux, and cholesterol homeostasis. And so we investigated that possibility. So Shinran very cleverly generated a system where she was able to recapitulate the microenvironment of the leptomeninges. So you can see here, this is an in vitro system with just cancer cells. And on the left is the Lewis lung carcinoma model, so the lung cancer model, and then on the right is the B16 melanoma model. And what you can see here in this heat map, these are the genes that are associated with de novo fatty acid biosynthesis, FASN, ACACA, SCDs, and SREBPF1. And what's really cool, actually, is that retinol itself, so remember that's the precursor to retinoic acid. If we give the cells retinol, we don't see any change in their transcription of these genes. It's really just retinoic acid that's able to induce this response, either all-trans retinoic acid or 9-cis retinoic acid. So that's really speaking to the fact that these cells need a friend, right? They need the help of a generator of retinoic acid in order to be able to induce transcription of these genes. We find evidence for this same level of signaling in our human data set. So the single cell RNA-seq data set that I introduced to you earlier, we requeried it, and we found elevations in all of those RBPs and in ACACA, FASN, and SCD, really telling us that the cancer cells in the human context are also receiving these signals. We wanted to double check to see if the cancer cells were really requiring were really taking up retinol themselves or whether they really were relying more on retinoic acid. So we knocked out STRA6, which is that the gene product that's able to take up retinol, and we found that that didn't alter the growth of cancer cells in the leptomeningeal space. However, FASN, the gene product that's associated with de novo fatty acid biosynthesis, that does, when you knock out FASN, you inhibit cell growth in the leptomeningeal space, and that makes sense, especially knowing that there's very little available lipid in the leptomeningeal microenvironment. So Shinran thought, this is good. However, we found all of this information by looking originally at retinoic acid receptor, right? So she thought, what happens if I knock out the retinoic acid receptor or the co-receptor in this system, LXR? And so this is actually kind of a bear of a project because there are 3 retinoic acid receptors, alpha, beta, and gamma. And then, of course, there are 2 LXR receptors, alpha and beta. And so she did a double knockout of the LXR receptors and a triple knockout of the RXR receptors. And to our delight, found exactly what you see here, that in the absence of the retinoic acid receptors, the cells are no longer competent to be able to do de novo fatty acid biosynthesis. So when we take these cells and we put them in a mouse, we find something even better. So of course, when you knock out LXR, we see a little bit of an effect. That makes sense. But when you knock out retinoic acid receptor, you see a really profound effect on the cancer cell's ability to grow in the space. And we see something we've never seen before, which is survivors. Even in my iron chelation studies, we always saw that the mice eventually died from their disease. In this case, we have long-term survivors, which was pretty cool. So we wanted to know what the result was downstream of this. And so what Shinran did is she then carried out metabolomics of the spinal fluid of these mice and found that knocking out RXR inhibits production of these FASN products, which is really satisfying because that's what you'd expect. However, this was, in vitro. So to answer this question in vivo, we carried out spatial metabolomics on brains that we had isolated from the mice. Now, I'll kind of walk you through this briefly. So you can see here we've implanted the cells in the lung, just like we did at the very beginning of this story, or in the brain, in the leptomeninges. And then we first carried out, the second row was looking at glutathione. Glutathione is going to help us see where the tumor cells are. And you can see there's a nice hunk of it in the lung, and you can see it there in the basilar meninges in these first 2. I don't know if you can see my mouse, but in these first 2. And in the second 2 in the next row, you can also see in the basilar meninges a nice little coating of glutathione. Phosphatidylserine is going to mark the white matter for us. And you can see some nice white matter tracks being highlighted in the next row down. And then in the third row down, you can see some unbiased segmentation where we were looking to see if the cancer cells had their own metabolic response to the leptomeningeal space, and they do. Finally, we were able to see that the cancer cells in the leptomeninges are making more products of FASN. So we see more palmitic acid, stearic acid, oleic acid, and these are products of well, at least palmitic acid and stearic acid are products of FASN. And then we see, of course, other products of lipid metabolism in the space. I wish we could have done the same experiment with RXR knockouts, but of course, the RXR knockout doesn't have any tumor in its space, so that makes it quite difficult for us to carry out spatial metabolomics when there's no tumor there. So in sum, what I've shown you in this second story is this idea that retinol in the spinal fluid is then taken up by the leptomeninges, and that the leptomeninges, these leptomeningeal fibroblasts, become a local source of retinoic acid. That retinoic acid then is able to signal to the local cancer cells, and that these cancer cells then are able to metabolically reprogram themselves and become competent to be able to generate their own lipids through de novo fatty acid biosynthesis, but also, data not shown because of time, cholesterol biosynthesis, as well as lipoprotein biosynthesis and phospholipid metabolism. So I think in general, what I would hope for you to receive from this sort of talk is this idea that yes, cancer cells are receiving and are receptive to sort of a wide variety of microenvironmental signals, and that these microenvironmental signals, whether inflammatory or developmental or potentially even neurotransmitters, right? All of these signals are going to enable the cell to be able to overcome some of the constraints of the leptomeningeal microenvironment. An open question, of course, is how might the cancer cells influence brain function, right? So how, if all the arrows are going in one direction, what's happening? What is the molecular call-in response in the other direction? So with that, I wanted to acknowledge all the people who did this work, my really terrific laboratory. We all love CSF, if you can't tell. We work with a lot of spinal fluid, and we have the best time. And they are just lovely, dedicated people. I also wanted to thank, of course, my collaborators who I've given shout outs to along the way, my support, because funding for science is not easy, but most importantly, my patients and their families. They are some of the most altruistic, generous people that I've ever met. They are facing what is arguably one of the worst diagnoses in medicine. And then they still come and see us in clinic. They come in, they ask for more ways that they can help. They donate spinal fluid. It's really remarkable. Thanks so much.
Thank you very much. That's such beautiful work, and it's so exciting to see finally more understanding about what's going in this, like what the physiology is of the leptomeningeal compartment. Would you talk a little bit about, is there a challenge in sort of potential escape mechanisms in treating the leptomeningeal space for things like nodular growth that might have their own little microenvironments that might differ?
Yeah, I think that's a really terrific point. And it's actually a little bit underlies how Shinran designed her experiment. So when we collected these two sets of data separately, we were thinking about this question. We thought, there might be something very different about the cells that are adherent versus the cells that are floating. The story I told was the first pass where we were looking to see what was conserved between the two of them. But there's a really terrific student in my lab. His name is Clark, and he's working on this question, this exact question. So what is the difference between the floating and the adherent? Is there an equilibrium between them? We think there is. And when we have this equilibrium between floating and adherent, what are the differences? Like, in order to target the adherent population, do we need to target something different in terms of metabolic kind of qualities? Or maybe those are kind of more indolent cells, in which case should we try and just get all the floaters to kind of stick down and then radiate them? Who knows? But yeah, we're really interested.
Thank you very much. Thank you for joining us.
Thanks so much for the invitation. It was a lot of fun.
That was wonderful. Thank you so much for that beautiful talk. I would like to introduce our next speaker. I'm thrilled that Dr. Chang is able to join us for our talk today. I spent some time with her during my fellowship at Yale, and she has really been just a wealth of knowledge and just an absolute joy to learn from. She's been at Yale for quite some time, so she knows the ins and outs of that hospital system very, very well. And she is the director of the SRS and Gamma Knife programs, and is also a leader in the metastatic disease world. And so I'm really thrilled to hear her speak today about the uses of LIT for the management of brain tumors. So thank you.
All right. Thank you very much for having me. Thanks, Mary, for that really nice introduction. So let me just share my screen. Okay. All right. You can all hear me okay, right?
Yeah.
Okay. All right. So as Mary said, I predominantly take care of brain metastases. And so you all in the meetings and national meetings and otherwise have heard a fair amount about laser thermocoagulation. So what I wanted to address today was really just the management, mostly for brain metastases, but also a little bit of our journey to kind of how we got to where we are. All right, these are my disclosures. All right. And so you've all heard this before, but just kind of really to summarize, why we're using lasers and a little bit of the science behind it. The laser thermocoagulation basically is using the laser to heat tissue. And so the principles behind it are at the bottom of this screen here, where laser light is slowly delivered towards the tissue. That light is then either absorbed, scattered, or reflected. And what's interesting is that different tissues have different scatter to absorption to reflection ratios. And so what's great about this technology is that the tumors actually have a very high absorption rate. And as that light is absorbed, it's actually then transformed into thermal energy. What's even better about this is that edematous tissue, which we see around tumors, actually has a very high reflection rate. And so because of that, there's a very sharp border for brain metastases, particularly between where the light is absorbed and where it's reflected. And that allows us then to differentially treat one, to treat the tumor and not so much the edema. And so we've taken advantage of this for a long time now in treating many different types of tumors, predominantly gliomas, but also metastases. And the one thing that we learned early in our experience was that, unfortunately, if you didn't laser, if the laser light didn't get to the all of the tumor, then anything that you didn't get to just grows regardless of treatment. And so really what has allowed us to move this field forward in a less frustrating fashion is the development of MR thermometry, which Frank Yulez back in the 1980s described using gradient echo imaging to allow us to track changes in temperature on the MR. And so what we do with that information today is, with these companies that we work with, the information is put into the computer, and then temperature per voxel over time is calculated using this modified Arrhenius equation. What that allows us to do then is to create a kind of almost real-time prediction map of where the heat is going and which cells we think are killed. And so for those of you who've not seen a procedure, this is kind of how it works in our institution. So all the way in the bottom left is us drilling stereotactically through a kind of 3 or 5 millimeter hole. And we'll talk about this, but for my purposes, I always biopsy the lesion. And then along the same biopsy track, we put the laser in. We then prep the patient for MRI, and we have an intraoperative MR, which really facilitates us developing this technology initially. And then we get an MR that shows that we're in where we're supposed to be. And so then what we see on the screen is this kind of picture. So the blue line being the outline of the tumor, and the yellow line that's growing is the prediction map of heating over time. And so obviously the treatment is completed when the yellow line exceeds the blue line. Okay. And so I think, from one of the real reasons why laser thermocoagulation is growing so quickly as an indication is because patients really love it. So, here's a picture of, a patient that I had to do a prior craniotomy on and then ultimately had to come back and do laser on. And so the size difference between the incisions is obviously can be quite significant. From a steroid taper standpoint, it's actually slower with the laser because obviously we're not removing anything. But surprisingly, most patients are able to go home post-op day number 1, and I have a whole bunch of crazy patients who actually go back to work, or they're what they normally do within the week. So patients really appreciate that on the back end it's easier. So I said I was going to talk mostly about brain metastases, but I kind of wanted to give you an idea. We've been doing this since 2009, so we were one of the earlier centers. And you can see that despite having had this around and available for a while, that we're still not really doing a large number of cases. So we've done about 200 cases over the last 15 years, mostly for metastases. We do some gliomas, some epilepsy, meningiomas, things like that. But to give you some perspective, we run a busy gamma knife center. We do about 350 to 400 cases of gamma knife a year, about 100 craniotomies a year for brain metastases, and still only about 15 to 20 cases a year of laser. So there's still a bit of a way to go with this technology. So moving on to brain metastases then, as you all know, brain metastases occur as part of a larger systemic disease. And one of the biggest things with this is that local failure, so if we create a complication or anything like that, unfortunately, that can shorten survival. But successful therapy using laser does not improve survival. So the procedure itself needs to be as uncomplicated as possible so that it doesn't delay next steps in care. We must remember that laser ablation is an invasive surgical procedure, so it comes with all the surgical risks. And so really, what is the role of laser in the treatment of patients with brain metastases? So in my mind, and so this is a debate, there are individuals out there nationally who believe that untreated brain metastases can be treated with laser. But for me, the role is limited. It's not a decompression tool, and it's really not a direct comparison for radiosurgery, right? It is, so from a surgical standpoint, where, the laser can really only treat up to about 2.5 to 3 centimeters. So from a craniotomy standpoint, this is not, usually an indication for surgery. We can't guarantee using the technology that we own today that we can completely ablate a lesion, especially if it's on the larger size. And so all of these lesions have to be consolidated with radiosurgery anyway. And then you can see from the images that are up that failed laser actually makes salvage radiation more complicated. So to the right, you can see, a lesion that was de novo. We decided to laser it. It looked like we'd actually done a really good job with the laser, but you can see at 3 months that the edges started to regrow. And at 4.5 months, we had to give it a more complicated radiosurgery plan than we would have done if we'd done it prior to the laser. And so I think there's there's a lot of kind of encouraging data in this area. But for me, the only reason for doing the laser would be if we were going to biopsy the lesion anyway, and we don't wait for the results of the laser, we go ahead and consolidate with radiation. So what really are the indications? And so really for me, it's post-radiosurgery, all right? So the patient's already had radiosurgery. Radiosurgery is growing very rapidly. It's very easy to do across the country. And radiosurgery is great if you only live, about the average 9 or 12 months, which is the average survival of brain metastases patients. But if you live longer than that, then what we've known for quite a while now is that these lesions, a large percentage of these lesions can actually regrow. All right. And so the problem is that there's an increasing number of brain metastases being treated with radiosurgery, and therefore an increasing number of brain metastases that are regrowing after radiosurgery. The differential diagnosis could include that, the diagnosis is wrong. It could be the tumor regrowing. It could be radiation necrosis. It could be a combination. And the bigger problem is that the differential diagnosis by imaging remains imperfect, and the rate of radiation necrosis is also increasing. So I wanted to share with you kind of one of the cases, so there've been quite a few, but one of the cases that kind of really drove me to think about like what to do in this scenario. And so this is a 41-year-old lady with triple positive breast cancer, so somebody who we should have expected to do relatively well. This was back in 2013, so it's been a while now. But she had 6 of these tiny lesions all the way to the left, in the yellow circle. She got whole brain radiation therapy followed by radiosurgery because back in the day, the data said that this resulted in better survival. You can see that about a half a year later, she started to develop changes in the area that were unclear. And so they repeated the scan 2 months later. And so you can see in the middle pictures that this lesion has rapidly increased in size. She was referred to a neurosurgeon at the time who said, well, she's got stage 4 breast cancer and this lesion is deep and, not easily resectable. So why don't we go ahead and radiate it again? And so the radiation oncologist happily obliged and gave 2 more fractions of 7-gray radiosurgery. And then you can see that 4 months later, she shows up in my office with this huge lesion that on PET looked like it was tumor. On MR spectroscopy, it looked like tumor. So we went in to resect it, and there was not a single tumor cell to be found. So this was radiation necrosis. And so I wondered if we had had a surgical intervention back in October of 2014, if in fact she might have done better. She unfortunately went on, she was mute hemiplegic, and I didn't make that any better, unfortunately, with my surgical approach. And so we have in our center become very aggressive with surgery following failed radiosurgery. We have had several cases now where we've proved, in fact, that these lesions have been wrong diagnosis, which can occur in 15% of cases of single lesion cases. And so obviously that changes the entire path. I think that, you know, there's a lot of repeat radiosurgery that gets done, but if the response to radiosurgery the first time was not particularly good, then the second time round, you're going to give less dose. And so I'm not sure that you're going to still end up with a durable response. And obviously 2 rounds of radiosurgery increases the risk of radiation necrosis. And if you have radiation necrosis that's causing the lesion to regrow, then obviously you don't want to give more radiation. In addition to that, in the brain metastasis world, we've started to understand that brain metastases can often be genetically distinct from the primary tumor and also from other metastases in the body. And so this is just a copy of Priscilla Bastianos' work from Boston that shows that in fact up to 53% of cases of brain metastases can have clinically actionable alterations in brain metastases that are not detected in the primary. And so being able to get tissue in a recurrent tumor case is becoming increasingly important. So I think there's 2 main scenarios: laser for tumor regrowth and laser for radiation necrosis. This is just an example of, you know, that we can do well even with tumor regrowth. The 42-year-old lady with metastatic melanoma, she had this left insular lesion. Given radiosurgery, she had a nice response at 3 months, and then at 12 months, you can see it started to regrow with a vengeance. PET was hot. And so what's key with laser is, again, back to that original theme, which is that you must get all the way around the lesion if you're going to laser it. And so you can see at the 2-week mark after laser that the lesion that you create with the laser is always going to be bigger than the original lesion. But if you can do this, then in the long run, the lesion will has the highest chance of doing well. And so to address the edema associated with laser, I know there's a lot of discussion out there about kind of, you know, making edema worse, but you can actually see at the 2-week mark that the edema is not significantly worse from the laser. And so our experience has been, you know, pretty favorable from that standpoint. And so this highlights this even more. So this is a 65-year-old lady with lung cancer who got radiosurgery. And then as you can see, about a year later, the lesion starts to regrow. There's a massive amount of temporal lobe edema. She's clearly symptomatic from this. And so we go ahead and laser it. And so you can see that the lesion that we leave behind with the laser is similar, if not maybe larger than the original lesion. But 2 weeks after the laser, the edema is actually already starting to get better. And so she then obviously got additional radiation to the area and the lesion resolved. All right, so turning to radiation necrosis. So why do we operate for radiation necrosis? Well, what we learned back in the day before we were using laser was that if we actually did craniotomy for these lesions, that in fact it resulted in improved survival. And so we, as we started up with the laser, we said, well, is that possibly true as well? So here are some examples of cases that we've done. This is, again, 48-year-old lady with melanoma. She had this lesion all the way to the left, treated with radiosurgery. She had an initial stabilization, but then you can see the edema got significantly bigger as well as the lesion. And so again, lasered, so all the way to the left, pre-laser. Next to that is the post-laser treatment images. And so you can see again that the edema actually gets significantly better after the laser response. And so we've been doing this a lot for our immunotherapy patients now. We don't actually wait for the lesion to get significantly big before we start. And so this is a 75-year-old gentleman, again, with melanoma, had radiosurgery, and a month later started immunotherapy. You can see to the left that the edema started to get worse. He was confused. And so we just went ahead and lasered him. And so he went home post-op day number 1. He was off steroids only for off steroids in a week and was able to restart his immunotherapy 2 weeks post-laser. Similarly, for this lung cancer patient on erlotinib, we gamma knifed 23 lesions. Of the 23, you can see the one that was causing trouble. And not so much in that the lesion was increasing in size, but just a lot of edema around the lesion. And so you can see 2 weeks after that the edema had, again, already gotten a lot better and continued to resolve over time. And so back in 2019, we published multi-center data showing that not only was survival reasonable for these patients, but in fact that our results with radiation necrosis were significantly better than with metastatic tumor, both for survival as well as local control. And the one lesson that I took away from that data was in fact this. So again, back to the degree of ablation. So if you totally ablate a radiation necrosis lesion, it will go away. If you completely ablate a tumor lesion, the majority of times it'll go away, and sometimes you'll get a partial response. But if you subtotally ablate either scenario, then with radiation necrosis, most of the time you'll end up with a stable lesion, but with tumor, you will fail. And so we took that message at our institution one step further, and we said, if we know that these lesions are going to grow, continue to grow, and so this is particularly our immunotherapy population, then why don't we just go ahead and take care of them when they're smaller, so that we can completely ablate them. And so this is an example of that. This is a patient with, again, with lung cancer. You can see 2 tiny lesions treated with radiosurgery in the upper left. And so 12 months later, this patient is completely asymptomatic, has a tiny lesion still, but you can start to see the edema forming around the lesion. And so rather than waiting for this to become symptomatic and larger, we just went ahead and gave her, treated her with the laser. She went home post-op day number 1. She only ever got a single dose of steroid. Her pathology was radiation necrosis. You can see the images 2 weeks post-laser, and she went on to 12 further months of no interruption immunotherapy. And so our medical oncologists have been very enthusiastic about this approach. It means that it allows them to never have to interrupt their schedule, and we just fit our surgery right in there, just like we can fit radiosurgery. And so how do we do overall? I was interested to look to see if our craniotomy data looked any different than our laser data. And so what we're able to demonstrate was that for lesions less than 3 centimeters in size, that all the way to the left, it's not so much the treatment modality that matters. Your outcome ends up being the same, but actually all the way to the right, it really is, again, lesion pathology that drives how patients do. And I think that, and so when you compare the two, we're increasingly offering laser, mainly because it seems that we can do this relatively safely now, particularly when the lesions are smaller, and it results in a shorter ICU and hospital stay. It's important to remember that laser is not a decompression tool, so this is a patient who we had to take ultimately back to the operating room because not all of them shrink. And so the other part of it is that it's not always a guarantee that you'll get the same results. And so this is that same patient that I showed where we did the right frontal lesion and had a really nice response. Unfortunately, she then popped up a right parietal lesion, and we ended up ultimately having to give this patient Avastin as well. So then lastly, just to address the comparison of laser to Avastin for radiation necrosis, this is just our single institutional data. And so at the end, ultimately, at the end of the day, we don't have an answer because what you can see here, particularly if you look at median time from radiosurgery to lid, is that we're actually using the two tools very differently. We're using BEV for earlier regrowth as opposed to laser, which is later regrowth. We're really using BEV for symptomatic regrowth and laser for imaging-based regrowth. But what was interesting about the data was this graph to the right, which, so the blue line is the laser volumetric lesion volume over time changes, and the black line is the bevacizumab line. And so even though laser causes an initial growth in lesion size, that tends to resolve over time and tends to be durable. With the BEV, there's an initial really good response to lesion size, but unfortunately, over time, that tends to be far less durable. And so where does laser sit now in kind of the tumor world? So within the NCCN guidelines, it can be considered for recurrent metastases, radiation necrosis, and recurrent glioblastoma. And as you know, the CNS and AANS have echoed this as well. But there's, as hopefully I showed you a little bit today, while it can be very, very effective as a tool, there are still some limiting issues with it. And so most limiting of all is this. I want to thank our team. The operative day for laser is a much longer day than a craniotomy day. And so much as it's really nice for the patients because they go home the next day, we still have a lot to do to make the surgical part of it much more efficient. All right, so thank you very much for listening.
Dr. Cheng, thank you. Zach Litvak, I do a little bit of lit, not quite as much as you do. And as you said, we're all kind of on the learning curve. I'm curious, given your experience, where you think we're going with this, primarily on the device side. The devices that are available are somewhat limiting in what we can treat and the shape of what we can treat, and wondering where we're going there.
Yeah, no, thanks, Zach. I totally agree with you. It's we need a lot of development. So I think as I look at so there are 3 different technologies out there right now available to do these procedures. And so the differences between them is that the Montera system actually has a driver and 2 types of lasers, a all-round firing laser and a side firing laser. And then the ClearPoint, which is the newer technology, doesn't require cooling. So I think that, and so I'm, just full disclosure, I'm a Monteris user, mainly because it has the robotic driver that allows me to kind of have better control over my depth of laser placement. But also the side firing and the pulsed heating allows me a larger diameter and a little bit of sculpting. So as you know, when you first put the laser in it heats kind of in a big round ball. But beyond kind of the 2.5 centimeter, sometimes the side firing can get me out there a little bit further in a single duration. But I really think that where we need to be going with development is we need the pre-planning capability. So we have so much information now from all the different companies that show us, right, based on kind of pre-op imaging, where the heat might go. And so if we have a better way to predict where it'll go or even plan beforehand, right, it allows us then to say, okay, maybe we should put the laser over here, or maybe we should put 2 lasers in, or, maybe we can do this with just 1. And so I think there's a lot of work to be done there. I think the other part of it is the robotics. So, in my dream world, I think that if you could create a pre-plan, what you could then do is, because, I'm terrible at drilling. I can never drill straight. And so, if we could get a robot that says, okay, here's where we're going to drill, drill here and here in this direction, put your lasers in, and then you can drive the use of those lasers. I think it would absolutely get us to the point where we would be able to more completely cover the lesion that we need. And so those are the areas I think we need development in.
Yeah, I love the idea of treating it more like radiosurgery and doing a simulation ahead of time. So yeah. Thank you.
Thank you very much.
I'm going to introduce our next speaker, who's a friend and a colleague, Dr. Akanksha Sharma, trained at University of Washington for her neurology residency. We were there together. She's a couple years ahead of me. And then she went to Mayo, Arizona for her neuro-oncology fellowship. And then she came back to UW for a second fellowship in palliative care. And then joined the Pacific Neuroscience Institute in Santa Monica, where she's led some, I think, really innovative and interesting trials in the palliative care setting with brain tumor patients. And I'm thrilled to hear her talk today on whole person care for the brain tumor patient. Thank you for joining us.
Thank you so much. Thank you for being here. It's I think I was invited a few years ago, and so I'm excited to be back. And I was really excited to hear Dr. Stern. It's rare sometimes to have two palliative care talks, so I'm really excited for that. Thank you for organizing this very interesting day. I'm going to talk a little bit about research, but also clinical care and sort of practical implementation of providing person-centered or whole person care for the patient with brain tumor. I've been a part of Pacific Neuroscience Institute in St. John's for about 4.5 years. So this is all work in the community, like many of you, and that is a place where neuro-oncology, palliative care and neuro-oncology has definitely lagged behind. These are my disclosures, not relevant to the talk today. And the objectives are to really, as I mentioned, discuss the principles in this particular field of work and how we can practically and routinely implement it. The title of this talk really comes from inspiration from a patient. I think our patients are our inspiration every day. They're our muses. And I was attending the Duke Brain Mets Symposium 2 years ago, and one of the patients who was on the panel said, you know, I want to be seen as the whole person when I'm going through treatment, not just the disease. And I think palliative care allows us to see patients with that whole person lens. It's the multidisciplinary pursuit of quality of life, regardless of diagnosis, regardless of outcome, regardless of disease state here in the US. And it improves quality of life and relieves suffering of patients who are facing any kind of serious illness, including cancer. And of course, with brain tumors, regardless of benign or otherwise nature, we're looking at something that's quite serious. It helps patients by addressing multiple different aspects of need, which I'll review. And as I already discussed, it's not limited by prognosis. We already have extensive data, which I won't go too much into today, but just sort of talk about how we're going to practically think about it in brain tumors. But in general, in serious illness, there's enough, and we've heard about it today too, that palliative care can improve both quality and quantity of life in a number of ways, including communication. However, I would say, in my experience in brain tumor care, we have still found it very hard to embrace and include quality of life and palliative care measures. And this is despite patients stating that they really want focus on quality of life. So the last few years, I was invited to be part of a National Brain Tumor Society PCORI initiative, which was trying to define quality of life for patients through a patient and caregiver-centered lens. Over 65% of these patients were, the participants were patients or caregivers. And we met over the course of almost 2 years, including a number of roundtable meetings, to kind of come up with the agenda and the care needs of these patients and caregivers. And one of the things that came out of this was a definition for quality of life for patients with brain tumors, which may be defined as an individual sense of well-being and ability to enjoy and participate in life. It's key to note, though, that quality of life varies through the patient's journey, and it varies for each person. It's not defined by the individual. It's not defined by a group, but by an individual. But I'll note here that it doesn't really mention anything about getting treatment or surviving. Quality of life is, of course, not necessarily linked to how long you think you're going to live. Of course, that has an impact on your quality of life, but patients want to do more than just live or survive. They want to live well. And living well when you have a brain tumor is quite complicated because the brain tumor impacts your physical journey, your cognitive abilities, your emotional state, your social, and the financial toxicity in America is beyond belief. And it also affects the way you view the world and the relationship you have with what will happen to you. So existential distress and death anxiety changes over time. It involves more than a patient. And I would say, despite the state of our world right now, it is very important to acknowledge that it is dramatically impacted by disparities in healthcare and inequity. I think more than most other cancers, brain tumors are really impacted because if you don't even have the access to care that a lot of patients don't have, then you can't even be counted in the numbers. So the numbers don't show the reality of patients and how they're impacted by disparities in healthcare. And so some of the work we're doing that I'm leading, this includes the COPAL CNS. So last year, my co-lead and I, Heather Leeper, who is also a neuro-oncologist at palliative care doctor in University of Chicago now, realized that we really need to do more standardization and uniform work on how we define quality of life in our research and clinical initiatives. And based on the NBTS's work and the work that I just described that was done to the PCORI, we decided to take that further and do a Delphi process now focused on research and clinicians to identify what outcomes should we really be focusing on uniformly in every single initiative. The reason this came up was that, as I've discussed, the quality of life definition is very variable into the individual, and there's a lot of things that impacts it. But what was happening as a result was that every study that was done in palliative care and neuro-oncology had different measures. The outcomes were different. We couldn't really combine the N, and the N remained small. And so as a field, even though we know logically that our interventions help patients, we're not able to prove the efficacy and which one we should use. And so the COPAL CNS project started last year. It just wrapped up its third Delphi in November, and we are going to be presenting hopefully data later this year. But it was 90 members. 76 was our number of people who continued participating through Delphi 3, which is great. And it spanned almost every continent. Actually all continents, and so had participants from Africa, Asia, Australia, Europe, and the US to try to, and we continued to have patient and caregiver advocates weigh into which outcomes we should make sure we include in palliative care interventions. But from a personal philosophy perspective, over the years, I've developed this palliative care framework in my clinical work, which I bring into discussions and meetings and how we think of patients and providing care to them at our center at Pacific Neuroscience Institute. We base it on a foundation of high quality communication and rapport building, and noting that rapport building can take time. We make sure that our team is multidisciplinary and that we're really thinking about a holistic approach to the patient's care. That multidisciplinary team definitely includes our APPs, our nurse navigator, who's been crucial, social workers, and we don't have a chaplain, but that's a dream. And then we want to focus that the holistic approach does not just focus on how you're feeling, how the treatment is going, how the tumor is doing on MRIs, but also how you're emotionally doing, how your caregiver is doing. Are you fearful? Are you scared for the future? How your soul is doing? And through their journey, we're looking at symptom management, care coordination, navigation, which has become so important in today's healthcare world, future and legacy planning, spiritual, social, psychological support. Shared decision-making is often a big part of trying to decide clinical trial versus treatment, and helping patients understand and cope with their disease. So what does that look like in a practical fashion? How are we integrating this into the journey? I think it's very important at this point for me to mention that I recognize that palliative care is not the same everywhere for everyone. And Dr. Stern mentioned that beautifully with Dr. Wu's story, which I know well, and I know her well. And it has to be culturally competent and personalized. It has to be sensitive, adaptive. It meets the moment. And so that in brain tumor, I strongly believe that one of the reasons we've struggled to provide uniform palliative care is because it shouldn't be uniform. It has to be trigger-based. It has to be targeted to what the patient needs and what that patient's culture and family needs, where they are in their mind and in how they are facing their disease. That is a challenge. I learned that myself as someone who immigrated from India, considers herself Indian and American, but really struggles with the philosophy of palliative care in India versus in America. I have to be very conscious when I'm seeing patients who are from my own cultural background that the conversation I have with them has to be different. And I think that's very important when we're thinking about implementing palliative care for patients with brain tumors. And many years ago, when I was a medical student and resident, we would go through the model of palliative care in the middle here, where we really just wanted people to acknowledge that palliative care can be given right from the beginning. We should do it right at the beginning. And that made sense, that instead of waiting till things were too late, we want to integrate it right from the start. However, now this patient-centered model, which again is led by Dr. Temel, who led the original palliative care trials, is becoming more prominent, both from a perspective of the patient's needs, but also from a resources perspectives, where palliative care is emphasized on the basis of care needs. So whatever the patient needs, and whenever their needs are high, you're meeting them with the appropriate care. And then when they don't have as high needs, they're continuing with the status quo. This sort of also brings together survivorship care, because as patients are living longer, especially with brain mets, with all these advances in immunotherapy, targeted therapy, we really also want to still think about the fact that they need psychosocial support. Patients who are 5-10 years from metastatic melanoma stop living with the active disease, but that doesn't mean that they don't live with the treatment side effects, with the long-term effect of radiation and immunotherapy, and that they don't have other issues that affect them. These patients can still be rather disabled, and having that lens of both palliative care and survivorship care together really allows us to give them patient-centered care. And so in this article that was plenary at ASCO last year, Dr. Temel highlighted that stepped palliative care or trigger-based palliative care was equivalent or non-inferior to early palliative care. And so in our practice, when I started, I was the only neuropalliative care doctor, which is not rare, but also our outpatient palliative care in Providence had really been cut significantly. And so we were mainly had excellent inpatient palliative care, but very little outpatient. But there was no way I was going to see every patient who was diagnosed with brain tumors or brain mets or advanced cancer. And so we use this stepped approach, which I'll talk about later, to figure out who gets additional palliative care interventions, who gets an integrated practice. And so it helps me to think about the patient's journey in a phased manner. So I think about the initial phase where patients are just diagnosed, and this is regardless of the type of tumor you have. You will get radiation, surgery, maybe some kind of clinical trial. You're thinking about treatments. It's a very overwhelming phase where you're angry, you're shocked, you're just adapting to things. And then you have this recurrence period. Again, regardless of your tumor type, it might be years later, it might be months later, it might be weeks later, unfortunately. But in this recurrence phase, you're thinking about another line of treatment, more surgery, more interventions, more trials. At some point, after a number of recurrences or other complications, you're eventually leading late stage and end of life. And of course, our goal for all our patients is that this comes really late in the course, but that's going to mean that you're thinking about clinical trials again, maybe more final rounds of radiation, and then preparing for end of life. And through all of this, and including the caregiver, the bereavement stage, we have to change the way we're meeting our patients, change the way we're talking to them, and making sure that at appropriate stages, we're bringing up discussions on prognosis and quality of life. So as an example, we'll walk through this case. This is a true story of a patient who was referred to me with a brainstem tumor. I run the ONC028 expanded access program at our site and action trial, and we often get patients with DIPG and DMG, either newly diagnosed or later in their course. So this patient was referred for clinical trial enrollment. So the first thing that comes up is, how is this patient doing? That's the first thing we think about, like, how they're clinically doing. How is this person and not their disease? So she had been on steroids since the start of radiation, really high dose. So she's had a lot of swelling and edema, but she still lost a lot of weight and muscle. She can barely keep her food down, constant nausea and vomiting, bloating, early satiety, probably from reflux. She's not on a PPI. She's feeling very weak and helpless. She's been referred for this trial and says, my oncologist tells me I need to do this trial, but I can't even keep food down. How can I keep this drug down? Patients with cancer have a number of symptoms as they start their cancer journey and throughout their journey. This is especially true in patients with brain tumors, where those symptoms are further exacerbated by neurological symptoms and by cognitive symptoms. And if we don't address the symptoms, then we can't help the patient be successful in their care, whether that's treatment or whether that's clinical trial. And so we really, going back to how you feel is how you'll do in the study. So the first thing, or how you'll do with treatment. So the first thing we did was wean down her DEX, started to wean down her DEX. It was a long process. Put her on a PPI, started her on Reglan for gastroparesis. get her in with a dietitian, get her in with other resources and support, making sure that she at least has protein and things like that. And then we could bring her back to discuss enrollment in the trial. Excuse me. The next thing that comes up is if you can't get to care, you can get care. So I mentioned this briefly earlier, but in my experience with running this program, which is one of the few on the West Coast, what we've really found is that, I'm so sorry, I have a laryngeal palsy. What we found is that patients' insurances are really a barrier to care, right? We all know that. But it really highlights itself when I know that there's a certain patient I can get in within a week, see within a week, start on this drug that may or may not help them. But for another patient, it might take 2 or 3 months to get to that same step. So we need to figure out that how to help these patients with reducing the barriers that stop them from getting for care. In this case, apart from an HMO insurance, English is not the primary language. The husband works full-time and is rarely available. Her sister was here from Mexico on a short-term visa, which was running out. And of course, she's not completely sure what a clinical trial is. Why am I being referred for this? So care coordination or healthcare navigation has become a part of palliative care. And also our amazing social workers are part of that. And that's because it really was orphaned. Like people didn't really know where to put this important aspect, especially with the decline of primary care in our country, declined reimbursement, and increase in complexity of specialty care. So this recent article found that US adults spend 8 hours a month coordinating healthcare. And this was English-speaking US adults. But for patients who have multiple barriers to accessing healthcare, it can be incredibly challenging and complex. They can be scared, they can be afraid and overwhelmed. They may be overburdened by financial costs that they don't even know how to navigate or talk about. And all of these challenges continue from the time of diagnosis and throughout the treatment, and they're incredibly significant in brain tumor care, especially where everything is expensive. So then for this particular patient, we first had to make sure we got auth. And for our in general in our program, we have an honest discussion with sponsors, because this actually ends up being a common issue in LA, is that the more they can cover, the more we're more likely to be able to enroll patients. We then also had to, we helped the sister get her visa extended. We made sure she was in with social work. So all these other aspects to make sure that she felt comfortable coming to us on a routine basis. Third aspect, not just the body, but also the mind. The patient got on the trial, started the study, and she started getting physically much better. She was eating, she's putting on weight, the steroids were weaned down, she was losing the weight and the edema. She was very quiet and withdrawn in visits. And the husband touched base with us privately and said, you know, she's scared of what might happen. She's crying every night, but because she's worried about how it's going to affect her participation in the trial, she's afraid to bring it up. So patients with cancer, of course, have depression, anxiety, panic, and existential distress. But this is all very complicated further by brain tumors, where there's neurological and cognitive symptoms that make things worse. In addition, almost all our medications that we use for depression and anxiety are extrapolated from the general psychiatric literature. There's, as of the most recent Cochrane review, there's absolutely no data in patients with brain tumors. However, we know that all of them do reduce our seizure threshold, so they all can have side effects, and the increased pill burden is very hard. Demoralization and death anxiety in patients with brain tumors has only been started to be studied in the last few years. It's incredibly important. It affects their care and their ability to want to do treatment. But again, in an area where there's no efficacious treatments in general, and only in the last few years have we started to learn about meaning-centered psychotherapy, which is incredibly successful actually, but underused, and patients don't really want to spend that time when they're already overburdened getting therapy regularly. And then psychedelic assisted therapy, which in my perspective is essentially adding something that'll speed up the process of meaning-centered psychotherapy. So you're still trying to reframe your situation and coping, but you're trying to make it faster by using a psychedelic. in the last few years, I've gone through many hurdles to get FDA and IRB approval for a psilocybin-assisted therapy for psychiatric distress in patients with brain tumors. This is finally approved. It's a very small pilot study because these trials are incredibly expensive, and it's funded by philanthropy. We're hoping to be able to start later this year enrolling our patients. There was a lot of complications with this as our state's approval board was also shut down for a period there. So a lot of uncertainty with that. We get a lot of questions about this in California, especially, and it's definitely something that's intriguing, and we really don't know what will happen with this trial. We're doing a single dose session and involving meaning-centered psychotherapy in it. But one thing to also consider is that one of the ways the psychedelics work is through neuroplasticity. So one of the things that we won't know through this trial, but in general we're thinking about is that it would not be good if we somehow encouraged stem cell growth. So where you really have to do a lot more work before we can say that this is good for brain tumors. So then we really need to spend time with our patients and think about what medications might help them, what therapy might help them. Especially in this case, patient needs a Spanish-speaking therapist, connecting them to the right resources. And then when we thinking about the future, you really can't plan for what you don't know. So privately, the husband says, they have no support here in the US. I can't afford caregivers here. She doesn't work anymore. I'm really limited. Should I just take her back to where we have family? This is a very important question, and patients are afraid to ask it, and caregivers are afraid to ask it. But in reality, it has so much implications, right, on what they can do. Caregiving costs in the LA area, which I imagine are similar to Seattle, is about $40 to $45 an hour. And towards the end of their life, most brain tumor patients are going to need 24/7 care. And in a recent review that Dr. Leeper did, she found that almost 60% of brain tumor patients could not work soon after diagnosis. So there's a huge burden to care. There's financial costs, and there's also just not knowing what's coming ahead. So when you understand together what the disease means and you learn how to cope with it, or even accept the uncertainty of the future, especially on patients who are in clinical trials, it can actually inform your treatment choices, address fears around uncertainty, and improve end of life and care received, right? And however, at the same time, we know that majority of patients and caregivers want to know their prognosis, or at least they know deep down they should know something about it, but few actually discuss it with clinicians. And this is especially true in both oncology and the neurology literature. And so what that means is that patients are making very important medical choices, like enrolling on trials, staying in an area, quitting a job, not moving to be closer to family, or moving to be closer to family. All of these choices may be highly influenced by their understanding of prognosis. So if you don't know what's coming ahead, you can't plan for it. And what we also know from neuro-oncology literature, and this is work that I did in fellowship, but has also been, this was the first prospective review of this, but Dr. Eli Diamond and others at Sloan Kettering have looked at prognostic understanding retrospectively and in other ways, and we know that patient prognostic understanding is really low compared to caregivers. Caregivers have probably more pessimistic prognostic understanding, but also have probably more accurate even compared to the neuro-oncologist. So that discord in patients versus caregivers ends up being very important and significant because the patient is declining cognitively in conditions with glioma or meningioma or anything that affects their understanding. The caregiver has to make more decisions. And so what that means is that the patient in the beginning may know and is wondering what to expect, what am I going to do? Should I update my will? Should I do a living trust? And the caregivers have their own questions, which they're not discussing so as not to burden the patient. And meanwhile, the clinicians are uncomfortable, unsure if they should bring up prognosis. They worry about taking away hope. And most importantly, I think nowadays there's just not enough time. So then with this particular patient, we have slowly shared with the husband the concerns we have. The patient doesn't want to be involved in these conversations, but she's given us permission to talk with her husband about it. And so we've shared, as things change, we let him know, we're worried about it, or we think she's doing well. Let's pause and keep talking about it. So keeping an open channel because we don't know what's going to happen, but making sure we're making time to discuss things with him. And then on another visit, you learned that the patient has a daughter from a previous marriage. and current husband has never legally adopted her. She mentioned she wants to take an important trip with her daughter. So this journey of the patient is not just the patient's journey, it's also the family, the social systems. And in things like this, there's some emotional things about legacy and future planning that are important, but there are also some very practical things that come into play. So in this situation, for example, the husband has never legally adopted this child. And you have to start having these conversations about living trust, estate planning, the future, what it means for the patient should things go well, what it means if the things don't go well. But if we don't have these conversations, then there could be some really serious long-term implications in a family that hasn't prepared for it. So advanced care planning should be an important part of our patient's journey. And that, of course, includes conversations on prognosis, or at least preparing for everything, preparing for all scenarios, hoping for the best and preparing for the worst. And in this state and in Washington, of course, this also might mean that there might be questions about end of life act or medical aid in dying. The experience of the care partner is an important part of what we do at our site, and also nationally, there's more interest in figuring it out. I'm just currently doing a cost study, so trying to figure out what the average cost of care for families is, because most families have to hire formal caregivers, and we don't really have that information in the literature. But care partners of patients living with brain tumor have high levels of distress. They're very dependent. They often have neuropsychiatric symptoms, and these caregivers are incredibly isolated and lonely. And so supporting the care partners is important. It's difficult in our reimbursement system because they require separate check-ins. We can bill for time or bill for other things, but it's very challenging. And I recently gave grand rounds at USC, and this was one of the biggest questions of discussion was, how can we do it better? How can we validate and provide them with support and confirm their experience, but do it in that limited time that insurance gives us? And I don't have any good answers for that, but it's a very important aspect of care. So in our program, and for interest, I'll go through this. From 2021 onwards, this was data we looked at last year and presented at SNO. We have a trigger-based approach to care. So patients either see me in clinic if I'm also going to be their neuro-oncologist and decide their care. For some patients, that works really well. For patients for whom that doesn't work, or they need additional care, or they see one of my colleagues, they're referred to a separate comprehensive or supportive care clinic, where we focus on these things: treatment, decision, symptom management, coping, advanced care planning. Most of the patients are seen for symptom management, including pain or nausea or getting through chemo. And then the second biggest group is treatment decisions. They're trying to figure out which treatment to choose or which clinical trial to get on. The patients overall have, in the time that I've been with the practice, we have had some significant change in our numbers. For example, in last year, to 95% of deaths for the entire practice was in hospice versus only 33% nationally. And before I came, I would say it would be about 50%. Almost 100% of our notes, and this is for the whole practice, have a clear proxy identified, and having a clear proxy is often enough to start advanced care planning in the hospital. There were discussions of advanced directives, and we make sure that almost everyone has at some point talked about what the future might hold. And the motivation for all this, of course, is that increasingly I realize that death is, of course, a terrible outcome. We don't want it, but it's not a failure. It's normal. It's the natural order of things. What I don't want our patients to have is a bad death. That, for me, would be the failure. And a bad death, in my experience, is a traumatic death that you haven't prepared for. So hopefully you agree with me that palliative care is living well for as long as possible. But to be able to do that for our patients with brain tumors, we really have to cover all these different areas. I think every patient with brain tumor deserves that approach. Of course, we still have a long way to go to that end. And hopefully you can hear this. Just one second. Let me share audio. I want to see if you can hear it.
Having come from a family.
Can everyone hear that?
Yes.
Thanks.
Where terminal illnesses have been part of our history, especially recently. I've also lost some friends to cancer. Caring palliative care for me was, went hand in hand with hospice care, and it meant the end. It was a little off-putting. It was scary. Just led me to assume that my end was here, and it was comfort. I was to be comforted until that happened. When I met you, it was, how can we improve your quality of life? And in what ways can we do this? And it was very supportive. I felt like I had a cheerleader on my side immediately when I met you. Just the impression you gave was bigger picture. It was all aspects of my life, a very well-rounded focus.
I think it's essential. And to be honest, I think it's essential from the beginning. We don't know when the symptoms or when it's going to get hard. You can't predict. And if you wait too long, then you risk the opportunity of not having built a relationship, building trust, knowing, and for the physician to be able to read their patient because they know them. They've seen them when they are really well before they're getting really uncomfortable. I wouldn't do it any other way. As a caregiver, how it helped, palliative care helped me is there was this partnership. Like I knew that I had a partner in caring for my friend. When I would reach out, you were able to understand what I was talking about from more of a, like a comfort lens. And you helped reduce my anxiety as well as, and that helps me as a caregiver not put my anxiety onto my family member who's already really, has a difficult burden to bear.
It's an interesting question. I wouldn't say off the bat I would recommend palliative care. I would more say off the bat, why aren't you doing palliative care? Coming from knowing what it's like and what it's not like, it's like, wouldn't you want to be taken care of? Wouldn't you want your feelings and your concerns to be taken account of, to be heard, to make sure that your whole care team is talking to each other? Getting a cancer treatment diagnosis, it comes like Dr. Sharma told me, it comes really fast, really quick, and there's a lot to navigate on top of your emotional and mental. It's not only that you're going through your treatment, but you're also going through this maze of logistics. And for a team just to come in and help you with all that, the amount of mental and emotional stress it takes off your shoulders, the energy that you save from the stress, it's just better for you when you are going through an active treatment. And to have people there in place to help you out is a great deal and a big help.
So I think, the takeaways I want to leave with is that quality of life is individual. We know that, we understand that, and each patient has to define it for themselves. But we need to hear what that quality of life for each of our patient is. And it's important and crucial to weave that quality of life into the entire journey, thinking about not just how their disease is doing, how their scans are looking, but also how they're feeling. And if we can do that, it improves their tolerance of treatment, their willingness to try treatment. And through the palliative care lens, we can fulfill that goal by alleviating suffering. Patient-centered and person-centered care or disease-centered care should be the focus. When I first started looking for jobs many years ago, people would often tell me that I couldn't possibly do neuro-oncology and palliative care together because it was a conflict. It gives me pride today to be the director of our clinical trials program and also do palliative care. So it is possible, it is important, it's just a different lens. We should be keen to make our patients' lives more wonderful, not just less terrible. Thank you so much. I especially want to thank the caregivers and patients who helped me make that last video, and thank you everyone for inviting me.
Thank you very much for a wonderful talk. I really appreciated especially the emphasis on caregiver support. We had recently some of our patients started just entirely independent from our clinic on their own, started a caregiver support group for patients with brain tumors, and that's been just phenomenal to see. So thank you very much. That was really phenomenal.
Thank you.
And I think Dr. Wong is going to introduce our next speaker.
Hello, my name is Tony Wong. I feel like a bit of an interloper here. I'm a functional surgeon here at Swedish. I have the great honor and privilege of introducing my friend and colleague, Cheyenne Musa. Cheyenne and I did a residency together at the University of Virginia. For those of you who don't know about UVA or familiar with Charlottesville, Cheyenne here is I believe, a quadruple who. He did his undergrad, med school, and residency at UVA and is now an assistant professor of neurosurgery at the University of Virginia. And he's going to talk to us about some really interesting things about focused ultrasound and brain tumors. Take it away, Cheyenne.
Tony, thanks so much for that very nice introduction. Let me just share my screen right here. Can everyone see my screen?
Yes.
All right, well,
In
Tony,
presenter mode, Dr. Musa, could
okay,
you
let
just
me
swap
switch that.
displays?
Is that better?
Not yet.
Let's see.
There you go. Perfect.
Oh. How about now?
That looks great.
Okay, all right.
Thank you.
Well, again, thank you so much for that introduction. I also am a stereotactic and functional neurosurgeon and have been using focused ultrasound for the treatment primarily of movement disorders. But more recently, we've moved into using focused ultrasound for non-invasive treatment of brain tumors as well. I'll talk a bit about a clinical trial that we're doing here for that, but what I've been asked to do today is to give basically an overview of how this technology is being used for brain tumors. Some disclosures. So I've been awarded research funding for that clinical trial, which we'll discuss from the Focused Ultrasound Foundation. And I've also been provided research travel funding from Navifus, which is a company that produces a focused ultrasound device. So I think we're all familiar with diagnostic ultrasound, and this is where we use an ultrasound probe that emits sound waves that can travel through the body, and we're able to look at the reflection of those sound waves and construct an image. And that image can be used for diagnosis. And I know we're all familiar that this is a safe technology. It can even be used to image a fetus and doesn't cause any injury to the body. Now, focused ultrasound kind of turns that idea on its head. And with that, we use a curved transducer that focuses that ultrasound energy to a point. And it's that mechanical energy that collects at that point that allows us to have an effect. And this can be used in neurosurgery with transcranial purposes to create an ablation or to open the blood-brain barrier or to do other sorts of treatments for the brain, which we'll discuss. Now, this idea of using focused ultrasound for transcranial applications actually is not new. This began in the 1950s and was really pioneered by two brothers, William and Francis Fry, who were American physicists. He used a device similar to what you see here in order to create intracranial ablations, first in animal models, and later even was used in patients with Parkinson's disease. Now, with transcranial focused ultrasound, much of that energy is actually absorbed by the skull, so it's very difficult to create an ablation intracranially. And at that time, it was impossible without making a craniotomy. So they teamed up with a neurosurgeon, Russell Myers, who performed craniotomies in order to create these intracranial ablations in patients with Parkinson's. However, as you can imagine, that's quite invasive, and this idea never really caught on at that time. Now, if you fast forward about 70 years later, here's an example of a much more advanced device that we currently use. And I'll talk about the various devices that are used, but this particular one is called the Insightec Exablate device. It's a hemispheric phased array transducer with 1,024 elements that are all focused to one spot in order to create an ablation. There's also a low intensity system that's used for blood-brain barrier opening, and we'll talk more about that. But this device is coupled with an MRI scanner that can be used for MR thermography to basically monitor the treatment in real time as it's occurring. Here's a timeline of how focused ultrasound has really been used for transcranial applications. As I mentioned before, the first uses were really in the 50s. But it's really since the 90s that we've seen an explosion in research. And this is because of technological advancements, not only with MRI imaging, but also with phased array transducers that allow for transcranial applications. And it was really in the early 2000s where we first see this being used for transient blood-brain barrier opening. A few years later, that was used for targeted drug delivery, which we'll talk about some more. It was even used for ablation of intracranial tumors, which hasn't caught on so much because that area of ablation is so small. But later was used for ablation and movement disorders. And that low intensity focused ultrasound for blood-brain barrier opening, which we'll discuss, has not only been used for drug delivery, but even for clearing plaques in Alzheimer's disease. And others have even studied using low intensity focused ultrasound for neuromodulation as well, even for things like addiction. But again, we'll focus more on the neuro-oncology aspects. So here are some examples of devices that are commonly used both for clinical and research purposes. On the left side of the screen, you see the Exablate Neuro. That's an image that I showed earlier. That's that large hemispheric transducer that goes over the skull and can focus on central targets within the brain to create an ablation or open the blood-brain barrier. There's also an implantable device called the Carthera Sonocloud, which can either have 1 or 9 transducers that emit a beam of low intensity focused ultrasound, which is used for blood-brain barrier opening purposes. We'll see some more of that later in the talk. And then also there's the Navifus device, which is a phased array transducer that can actually be moved around the head and we use neuronavigation in order to see where that ultrasound is being delivered. So it's more versatile for that purpose. What this slide shows is that there are many different applications and mechanisms for using both high intensity and low intensity focused ultrasound. As I mentioned before, thermal ablation is already being used for movement disorders and is FDA approved for treatment of essential tremor and Parkinson's disease. And it's been used for ablation of brain tumors as well, but that area of ablation is very small and it's limited to the central portion of the brain. And so it's not used commonly. We more often would use something like LIT for a less invasive ablation of a tumor. However, I think what's had the most excitement is blood-brain barrier opening, followed by targeted drug delivery, which is used for brain tumors. And so we'll jump right into that. So for this 20-minute talk, we won't be able to go into all of the different, exciting studies that have come out in the past few years, but I want to highlight a few. Now, first, what is blood-brain barrier opening with ultrasound? So essentially, I think we're all familiar with what the blood-brain barrier is. But with this, what we want to do is basically create leaking through the blood-brain barrier opening through the mechanical effect of ultrasound in order to have a higher concentration of a therapeutic agent in not only the tumor, but mainly within the peritumoral area where the blood-brain barrier is likely intact. So with this, we administer microbubbles that are delivered within the circulation, and these microbubbles interact with ultrasound to cavitate, and basically they increase in size and decrease in size, as you can see here, and it's that mechanical effect on the tight junctions in the blood-brain barrier that causes it to become leaky, and that chemotherapeutic agent can then track into the peritumoral area. So I'll highlight 2 studies in the past few years that have demonstrated the potential efficacy of this. This study was published in 2021 and is from Sunnybrook Institute in Toronto. And this was in patients who have metastatic breast cancer and are being treated with trastuzumab. So you can see here is an example of a patient with this posterior fossa metastasis. And in this panel, if you can see my mouse, we can see the area of the mass that was treated using ultrasound. Afterwards, there is opening of the blood-brain barrier, which is evidenced by increased gadolinium uptake within the tumor and in the peritumoral areas, which later clears as the blood-brain barrier opens. But in the study, after blood-brain barrier opening, patients were given radiolabeled trastuzumab. And what was also unique about the study is that the authors used SPECT imaging both early and late to see how the relative uptake of trastuzumab changes after blood-brain barrier opening as compared to before blood-brain barrier opening. So we can see in this example that there is some increased uptake of radiolabeled trastuzumab in the treated portion of the tumor. But in the late stages, at 48 hours, we can see there is a significant increase in trastuzumab uptake. We can look at SUV values as well. And in these 4 subjects. And for example, in subject 1, the relative uptake has increased by about 450% in the treated portion of the tumor for radiolabeled trastuzumab. And we can see in subject 2 as well in 3 and 4, we can see that there is increased relative uptake of that drug. Now, if we look at patients 4 months out after their treatment with blood-brain barrier opening followed by trastuzumab delivery, we can see that there is shrinkage of these tumors in all 4 patients. Now, another study that was published more recently, this was in Lancet Oncology in 2023, published by Adam Sonnabend. This was at Northwestern. They used a different device. This is actually an implantable device called the SonoCloud 9. And this device actually has 9 transducers that can be implanted in the skull and is powered by the system that you can see here, which actually attaches through the device through a needle that can be placed through the skin when it needs to be accessed. And this device emits a beam of ultrasound energy in the area that was resected prior. So here's an example of that. So this study looked at patients who had recurrent glioblastoma. So this is one patient here. We can see the coronal and axial views of this mass. This is the postoperative MRI showing the resection. At the time of surgery, the authors implanted that SonoCloud 9 device. Then 2 to 3 weeks later, the patients had another image that was taken prior to ultrasound delivery. Then patients underwent blood-brain barrier opening using that ultrasound device. They also received albumin-bound paclitaxel as an infusion, which is known to have poor brain penetrance. And they obtained a post-FUS MRI that showed the area of blood-brain barrier opening just deep to where that SonoCloud 9 device is. And that's evidenced by this increased gadolinium uptake, as you can see in these 2 images. Here's another example of that. This is another patient who underwent the same protocol. They underwent resection of the tumor, implantation of the device, and then blood-brain barrier opening, which is shown by this increased gadolinium uptake. So the authors wanted to study 2 things. One thing that they wanted to look at was how long does the blood-brain barrier remain open? That's a question that hasn't been well answered. And it's previously been shown that it's likely around 24 hours or so. So that's the window of opportunity for any therapy afterwards. In this study, they performed post-FUS MRIs at different time points. Here's an example of a post-FUS MRI 1 hour afterwards. Here's an example about 2.5 hours afterwards, and we can see that there's clearance of that gadolinium even after 1 hour. And so they suggest that any therapeutic intervention that's taken should likely be within the first hour afterwards. Now, in a subset of these patients, at the time of resection, and just prior to the resection after the craniotomy, this SonoCloud 9 device was implanted, and patients underwent blood-brain barrier opening using that device. Just deep to that device. And they also received fluorescein just prior to the blood-brain barrier opening. And so what we can see after blood-brain barrier opening, this is the tumor up here. This is the peritumoral area just below it. And so the area that was opened, blood-brain barrier opening, is actually here, which has the same shape as that transducer. Just next to it, this area was not opened, and we don't see any fluorescein uptake. Now, after that blood-brain barrier opening, the patients either received albumin-bound paclitaxel or carboplatin, which are 2 chemotherapeutic agents with poor blood-brain barrier penetrance. And then, at that time, patients underwent biopsy of the sonicated and non-sonicated peritumoral tissue just prior to resection of the tumor. So here's an example of one patient. We can see this is the patient's axial and coronal views on MRI scans. We see the enhancing tumor. We see there's sonicated peritumoral brain and then non-sonicated peritumoral brain. We can see this on our intraoperative image. So on the top, we see the enhancing tumor, the sonicated peritumoral brain is bright based on fluorescein, and then there's the non-sonicated peritumoral brain, which is not. Now, multiple biopsies were taken from the sonicated and non-sonicated areas. And if you look at carboplatin concentration between the two, there is approximately a 9 times increase in carboplatin concentration in the sonicated peritumoral tissue as opposed to non-sonicated. The authors looked at paclitaxel concentration in 7 patients and carboplatin in 3 patients. And if you look at the concentrations between sonicated in blue and non-sonicated in red, there's a multifold increase in concentration in the treated areas. This was the same with the brain to plasma ratio of paclitaxel, and the relative hemoglobin content remained the same as would be expected. So those are examples of blood-brain barrier opening for drug delivery. Another example of how focused ultrasound can be used in neuro-oncology is a concept called liquid biopsy. And this is kind of the opposite of that last mechanism. So with this, blood-brain barrier opening is still done in the same way with microbubbles and low-intensity focused ultrasound. However, instead of delivering a drug, we actually take a blood sample in order to look at tumor biomarkers. One biomarker is cell-free DNA. And so this was first shown as a proof of concept in a study published in 2021 out of Sunnybrook, where patients with glioblastoma underwent blood-brain barrier opening, followed by liquid biopsy. Looking at these 7 patients that were studied, all had an increase in cell-free DNA. Another study published more recently in 2023 using a neuronavigation guided ultrasound device for patients with glioblastoma performed the same thing. So these patients had pre-FUS blood collection. They underwent focused ultrasound, blood-brain barrier opening, following microbubble delivery to the tumor. And then the blood was sampled at multiple time points afterwards to look at various biomarkers. So again, one biomarker is cell-free DNA. This is a busy slide, but essentially it shows that 4 of the 5 patients had a statistically significant increase in cell-free DNA at multiple time points after focused ultrasound. They also looked at circulating tumor DNA, and 4 of the patients had the same finding. And they also looked at tumor mutations in circulating tumor DNA, one of which was TERT promoter mutation, and 3 of the patients, they did see a significant change in that as well. So again, these are proof of concept studies, and it still remains whether this mechanism can be used to actually diagnose the type of brain tumor without a needle biopsy or an open biopsy, but it is potentially possible, and there's a lot more work that needs to be done, but it is somewhat exciting. Now, another exciting mechanism is something called sonodynamic therapy, and this is completely different from blood-brain barrier opening, but still leverages the non-invasive therapy from focused ultrasound. So with this, we administer a sonosensitizer to a patient with cancer. These sonosensitizers preferentially accumulate with a tumor, within a tumor, and they are activated by the focused ultrasound to cause a localized cytotoxic effect and tumor destruction. So with sonodynamic therapy, you have to have 3 conditions that need to be met. You have to have a neoplastic cell, you need to have a specific sonosensitizing agent that collects within that cell, and then you need that low-intensity ultrasound to have that mechanical effect to activate that sonosensitizing agent, and that can cause that cytotoxic effect. If you don't have one of those or any of those, then you will not have that cytotoxic effect. So this is currently being studied for patients who have glioblastoma in multiple clinical trials across the country. With glioblastoma, you likely know we administer 5-ALA in order to help us with intraoperative visualization of tumor tissue. These high-grade glioma cells preferentially uptake 5-ALA and metabolize them to protoporphyrin 9, which will then fluoresce under a blue light. Now, it just so happens that this drug is a sonosensitizer for glioblastoma, and it's not 100% clear what the mechanism for that is. But one of the theoretical mechanisms is that focused ultrasound causes the pyrolysis to occur, and this occurs through the mechanical energy of air bubbles being cavitated, which then interacts with protoporphyrin 9, releases reactive oxygen species, which then can lead to cell damage and apoptosis and cancer cell death. Now, this was originally studied in preclinical studies with mice and rats. This is one example of one of those studies. In this study, they had rats with a model of glioblastoma, and these rats were administered 5-ALA as well as focused ultrasound, and there was a decrease in tumor burden and a longer survival as opposed to the rats that were either in the control group or only received 5-ALA or ultrasound. So really, you need to have the combination of the two in order to have that therapeutic effect. A safety study was also performed at University of Virginia in a large animal model. So this was done in swine. And these animals did not have tumors, but they were administered 5-ALA and had focused ultrasound delivered to specific areas of the brain. And there was no radiographic or histologic evidence of any cell injury, suggesting that this is safe for any normal portions of the brain. So this concept of sonodynamic therapy is being studied in multiple clinical trials. One example is a clinical trial being done at Children's National, where this is being used for patients who have DIPG using the Insightec system. So this is an MRI-guided procedure, and IV5-ALA is being administered. And we're still waiting on the results of this. At the University of Virginia, we're also performing a trial for sonodynamic therapy using a different device. This is using the Navifus device, which uses a phased array transducer that can be moved around the head in order to target specific parts of the brain more easily. So here's an example of what that device looks like, and here's an example of how it's used. So the neurosurgeon's able to hold the device, it's connected to an arm to stabilize it, and it can be moved anywhere along the head. And a neuronavigation system is used to track the device and the patient's head to see in real time where that focused ultrasound energy is being delivered. So this clinical trial is underway at UVA. We've treated 4 patients so far. We plan to treat 10 in total. So we hope to have results to present next year. So with this, patients undergo these are for patients who have recurrent glioblastoma, who are candidates for another resection procedure. But prior to that, they undergo preoperative imaging, undergo sonodynamic therapy, and then they undergo imaging 1, 3, and 6 days afterwards to look for radiographic changes after the procedure. And they also undergo multiple blood draws to see if there's any systemic immunological effect as well. The patients then undergo resection of the tumor 1 to 3 weeks after sonodynamic therapy. And at that time, we look at differences between the control and the non-treated and the treated portions of the tumor based on histology and immunologic analysis. And then patients undergo safety follow-up as well. Finally, I want to touch on thermal ablation. As I mentioned, this technology can be used for thermal ablation of tumors, but the area that is ablated is often only a few millimeters in diameter. So it's possible, but difficult to do. And also, our treatment envelope for the devices we use is limited to the central portion of the brain. However, thermal ablation can be used for oncologic purposes, but not for tumor ablation, but potentially for treatment of pain as a palliative procedure. So you may be aware for patients who have upper or lower extremity pain related to oncologic disease, as a palliative procedure, we can perform a cordotomy, which can be done minimally invasively through an electrode that's placed into the spinal cord, and the spinothalamic tract is lesioned. Now, for patients who have head and neck cancer, that wouldn't be effective. You would need to ablate higher up in the head, so basically in the midbrain, in order to treat that head and neck cancer pain. So you're ablating the spinothalamic tract more superiorly. And that can be dangerous to do with an invasive means. However, focused ultrasound allows us to do that in a non-invasive manner. And this area is central within the head, so we're able to do that safely and easily. So at the University of Virginia, we have a clinical trial that's led by Dr. Jeff Elias, where we're treating patients with unilateral head and neck cancer pain by performing focused ultrasound ablations in the midbrain, and that's called a mesencephalotomy procedure. So far, 5 patients have been treated. We will be wrapping up that study soon, and we'll be presenting those results soon. So, I know we couldn't cover all aspects of how focused ultrasound is being used in neuro-oncology, but I think these are some of the most exciting. And I hope this gives a good overview of that. So with that, I want to thank you for your time and happy to take any questions.
I got a quick question. Great talk, great talk. Quick question. The Navifus device, does that have any skull density concerns like we use with the ablative technology?
No, actually, with that device, we don't have those concerns. With the high intensity focused ultrasound, yeah, we need to have the skull dense enough to get enough delivery of ultrasound energy to create an ablation. But with the Navifus device, we're using low intensity ultrasound for either blood-brain barrier opening or sonodynamic therapy. And we haven't found that skull density affects that. So we're able to get enough transcranial delivery no matter the skull density.
2 follow-up questions real quick. Do you need to shave the head, and how long does that sonodynamic therapy take you guys to do?
Yeah, so we do have to shave the head where that transducer is touching the scalp. And so usually that's about a few centimeters in diameter. As far as how long that treatment occurs, if you were to do the same thing with, let's say, the Insightec device, where you have to put someone in a stereotactic frame, use an MRI scanner, that would take several hours. This can be done in theoretically in a few minutes. However, we do want to be able to treat large portions of a tumor. If in total, if you're treating the entire tumor, yeah, it could take upwards of an hour or so. But I do think it's quicker than other alternatives right now.
All right. Thank you again, Sean.
Thank you. Thanks for having me.
Okay, I think we might skip our break and keep going to get back on track here. So I'll introduce myself. I'm Olippi Bonham. I'm a neuro-oncologist. I did all my training at the University of Washington. So MD, PhD in Nefi Stella's lab in cannabinoid pharmacology, residency, fellowship. And then I'm happy to be here. I have a partner, Trusha Shah, who's not able to be with us today. And my goal today is to give you what I thought were some interesting updates from our recent meeting, the Society for Neuro-Oncology, which was in just this past November. And I decided to focus on grade 2, grade 3 gliomas, just to keep it short. Let's see here. Okay, great. So I have no relevant disclosures with any of the companies I'm going to talk about. So thinking about low-grade gliomas, how do we stratify them? Which means which ones am I more worried about? Which ones am I less worried about? This is, I think, a question that we have been refining our answers to over time. So I want to cover that. And that leads directly to the next question, which is, when is it appropriate to wait and see? When is it appropriate to take a more minimalist observational approach? And then what are some new or newish options that have been around for the last couple of years and patients and us are excited about? What about the old options, and when should we use what? How do we put it together into a treatment algorithm? And then what do we think is coming up in the future? So what identifies an unfavorable prognosis in IDH mutant glioma? We've had kind of several iterations of this over the years. I'm showing you the Pignati criteria, the RTOG 9802 criteria, and sort of the current thinking, which is that it matters how big the tumor starts out. It matters how big the tumor is after surgery, how much postoperative volume there is. More is worse, but it turns out that might matter a lot more for astrocytoma than for oligodendroglioma. So having, greater residual with an oligo is really less associated with prognosis than it is with astrocytic tumors. In general, astrocytic tumors have a poorer prognosis. And then on a more detailed level, there's a couple of molecular findings, and probably there's more that we don't know about, but there's a couple that we're figuring out which do predict more unfavorable behavior of a tumor, irrespective of what it may look like under the microscope or what the patient, factors may be. This includes homozygous deletion of CDKN2A/B P16, any really activation in the retinoblastoma pathway and the PI3 kinase P10 pathway. The one that is really best established is CDKN2A, and actually for astrocytomas that are IDH mutant, just the presence of this factor alone makes it a grade 4 tumor. Another thing, if you have access to such data, is the preoperative growth rate. I saw a patient yesterday who has what I think will end up being a low-grade glioma that was missed 2 years ago, and then showed up after a big seizure and had a lot of swelling. It was hard to tell what was tumor, what was swelling, but if I was being really conservative about it, I would have had to say that there wasn't that much change, and that's informative. So if that patient, even if they can't get a total resection, I would be a lot more willing to do something like observe them, because I don't think the tumor is growing quickly. And then the presence of enhancement as a radiographic correlate of something like microvascular proliferation, which is felt to be, or neoangiogenesis, which is felt to be a higher grade feature. So if you've stratified, or you think you've stratified a tumor, when is it appropriate to wait and see? And really the most important data, I think, to justify this approach is very old at this point, it's 20 years old, the ORTC 22-845 trial, which was done in the, I think, 80s and 90s, enrolled 311 patients with good performance status, low-grade glioma. And essentially, at the time, people really weren't doing a lot of chemotherapy for these patients. So they just said, we're either going to do radiation early or we're going to do it late at progression. And And what was interesting about it was there was no difference in overall survival. And that was informative in, I think, at least 2 ways. So there was a question at the time, if you do early radiation, do you actually harm the patient? So do you introduce, do you increase the likelihood of tumor mutations that might increase the likelihood of malignant transformation at a sooner time point if you do early radiation? That was one theory at the time, and I think these data would say no. Another theory was, well, if you don't treat it up front, do you allow it more time to grow and to develop, and do you harm the patient by waiting? And again, these data would say no. So my interpretation of these data is radiation is an excellent treatment. It controls the tumor, for a period of time, and clearly has an effect, but it really doesn't matter when you do it. You get the same benefit or the same, you get the same benefit whether you do it up front or you wait. So you might say, well, what about a higher grade tumor? We don't have a trial for this, but we do have one, I think, fairly well done retrospective series that was published in Neurology a couple of years ago, which looked at conservative management for, I think, a very carefully selected group of grade 3 or even grade 4 IDH mutant tumors. It's important that they're IDH mutant. You would never do this with an IDH wild type tumor because they behave, well, there is no more grade 3 IDH wild type. The important selection factor was they did look at the margins of the tumor, and they wanted to see that there were no high-grade features at the margins. So the idea was if you have a tumor that maybe at its center has a focus of enhancement, and maybe if you look at that focus under the microscope, it looks like a grade 3. If you've taken that out and the rest of the tumor looks like a grade 2, can you treat it like a grade 2? Can you observe it? And what they found was that it took almost 3.5 years from the time of surgery for the treatment team to feel compelled to do a next treatment, which would certainly suggest that you can observe these tumors, because that's a long time. If observing them was wrong, you wouldn't go that long before people felt compelled to treat. And that's a median. So I think that's actually pretty compelling data. And then, even though it is, I will say, retrospective, single institution. And then if you look at what were the factors that predicted, good outcome, it was exactly what I just told you from the prior slide. So co-deletion status, meaning oligodendrocytic tumor, pre-op and post-op volume. So how big was the tumor and how much did you get out? Tumor growth rate, age, and I thought there was more. I think I might have missed some in my slide. So all of this plus the understanding and the remarkable discovery of the role and function of the IDH mutation, which occurred about in the 2010s, early aughts and 2010s. So the IDH mutation is, thought I had a slide on this. Oh, here. The IDH mutation, there's two of these enzymes. If either one is mutant, what you end up getting is an enantiomer of the normal 2-hydroxyglutarate molecule, which does not exist in normal tissue, and therefore we use the term oncometabolite. And this oncometabolite D2-hydroxyglutarate is actually, does a number of things. It's active specifically at enzymes that remove methyl groups from chromatin. And therefore, it promotes a hypermethylated phenotype. By this mechanism, it can actually affect the expression level of thousands of genes. And so there's actually an expression profile that's associated with an IDH mutation. So as we understood this, we developed drugs that can knock down this enzyme, this mutant enzyme. And what's great about these drugs is the only place that these mutant enzymes exist is in the tumor. So they're very well tolerated. There's a couple generations. The first generation, ivosidenib, was selective just for the IDH1 enzyme. Vorasidenib, which is the newer one, is selective for both enzymes, IDH1 and IDH2, and is also designed to be brain penetrant. And so what's interesting is when you use vorasidenib or ivosidenib and reduce D2-hydroxyglutarate, you get decreased tumor proliferation. So that sort of validates this idea that the IDH mutation is one of the drivers of tumor proliferation. You get reversal of the gene expression programs that I just mentioned. So this is a reversible phenotype. And the most interesting thing to me is there's increasing recognition that you actually get increased tumor infiltrating lymphocytes. So you get increased immune surveillance of the tumor. So this is sort of an area of increasing interest, and the question is being posed, can we combine IDH inhibitors with checkpoint inhibitors or other immunotherapies, and would that be more successful? But so the trial that I want to make sure and cover today is not new anymore. It came out 2 years ago almost. The Indigo trial has really changed the way that we approach IDH mutant tumors, especially grade 2, but even sometimes grade 3. This was a trial that enrolled patients over 12 years of age. They had to have at least one prior surgery for glioma, but several of them had more. There were patients on trial that had had 3 surgeries for glioma, and that was allowed as long as they'd never had radiation or chemotherapy. They had to be relatively stable, I think 1 year from surgery and no more than 5. And so they were enrolled in a double-blinded randomized trial of placebo versus vorasidenib. Vorasidenib, as I mentioned, is the IDH1 and 2 inhibitor. And by the way, these slides are from the company's presentation at SNO. This is the primary measure of the study. So this is progression-free survival, and this is the second interim analysis. And what you can see is, first of all, people do not progress in 3-month intervals. This is because most of these people were called by radiographic criteria. So we get MRIs every 3 months. That's why it has this pattern. But what's interesting is that At 24 months, you have almost 60% of patients on vorasidenib that have still not progressed versus about a quarter of patients on placebo. So that's very exciting data. What's more exciting to me is this slide, because as those of us who treat these tumors know, sometimes after a surgery, even late after a surgery, they can be involving T2 flare abnormality, and it can be hard to know, is this, bulky globular T2 flare abnormality that's tumor, or is it more like, scarring from the surgery? And especially when it's accumulating 1-2 years after a surgery, it can be, sometimes you just have to call it progression. What this slide indicates is, the actual thinking of the treatment team. So without being bound by criteria where you have to call things progression based on the increased signal, did they really think it was progressing? And the numbers here are even better. So at 2 years, in 80% of cases, the treatment team felt there was no need for any further treatment versus 40% of cases with placebo. The other interesting piece of data that I hadn't seen until this last iteration that was presented at SNO was, so this is tumor growth rate, and the blue is placebo. And what you can see is that there's kind of a steady growth rate, which you would expect for these low-grade tumors. But with IDH inhibitor, tumor growth basically stops when the IDH inhibitor is started, and that's expected. What to me was unexpected is that in the late term, the tumor actually decreases in size, although this is, past 1.5 years out. And then the other thing that I was very pleased to see, so when we first got the study readout, everybody was interested to know, do these drugs decrease seizure? Because D2-hydroxyglutarate, the oncometabolite, actually increases excitability at postsynaptic membranes. And so the presumption was, if you have less of this molecule, you should have you should have a lower seizure threshold. That wasn't borne out in the first analysis, but actually here, the more updated data does bear out that data. So the interpretation is you have the same overall number of patients seizing. So you can see patients with at least one seizure is no different. But of the patients that have a seizure disorder, the ones on vorasidenib had, somewhere between 4 and 5 times fewer seizures. So this is important to know, because if you look on the label, it says that one of the side effects is seizure, and that's not so. It's just because seizures happen to patients with brain tumors, and so it got associated with the drug during the trial. This is the subgroup analysis. There's really, first of all, it's always good when you see, all the subgroups aligning the same way. The other thing that's important is, as expected, codeleted tumors or oligodendrocytic tumors appeared to benefit more from this treatment. And then there's this interesting finding that somehow bigger tumors at baseline benefited more from this treatment than smaller tumors. And I still think about that sometimes. I'm not sure I fully understand it. So that's kind of our new tool. So, that's been around really just for a couple of years. What about our old tools? When is it appropriate to use Temodar? When is it appropriate to use PCV, procarbazine, lomustine, or CCNU, and vincristine? So this has been also hotly debated, and David Schiff had a nice summary of the trials at his talk, and I decided to recapitulate it, but added a little bit of information. What you're seeing here is trials that have looked at different variations in adjuvant chemotherapy using kind of the older generation of treatments, so Temodar and PCV. The RTOG 9802 trial looked at high-risk grade 2 gliomas and looked at radiation followed by PCV versus just radiation. And I'm showing you, just to simplify, I'm showing you this overall survival hazard ratios on the right. And so overall hazard ratio is 0.59. When we looked at Catnon, that was a complicated trial that I have a dedicated slide for. But if you look at just the question of adjuvant treatment, this was in grade 3 astrocytomas. They did actually include IDH mutant and IDH wild type astrocytomas. There was a benefit of adjuvant treatment with Temodar. This study did not look at PCV. Like I said, I have another slide on it. If you look at RTOG 9402, and if you look at the genetically defined subgroup of grade 3 oligodendrogliomas, there was a significant benefit of neoadjuvant PCV. So you do the chemotherapy, then you do the radiation, and there was a benefit. And then interestingly, a very similar trial right below it looked at the same population, but they flipped the order of the therapies. So they did radiation and then adjuvant PCV, and they got nearly exactly the same number, which I find very compelling. And it goes along with the first study I showed you, which showed that it really doesn't matter when you do the radiation. The study that Dr. Schiff presented was E3F05. That was a study of grade 2 gliomas receiving concurrent and adjuvant Temodar versus just radiation, a study intended to assess what is the benefit of adjuvant Temodar. And what was interesting, and his point was, he's getting a hazard ratio very similar to the PCV numbers. And so there's been a long-standing debate about when should you use Temodar versus PCV. It's a lot easier to use Temodar. It's a lot easier to take Temodar as the patient. But I think the definitive answer to this comes from the CODEL trial, which is in grade 3 codeleted tumors, so grade 3 oligodendrogliomas. And there they actually looked at, everybody got radiation, and then afterwards people got either PCV or Temodar. And the readout showed a clear benefit to PCV over Temodar, specifically in oligodendrocytic tumors. So in my mind, I think if you had to summarize all this data, there's a clear benefit to chemotherapy. I think in astrocytic tumors, most of us would use TMZ first. And I think in oligodendrocytic tumors, increasingly, people are using PCV, although I know that's not everybody. This is the slide on Catnon. Catnon is another study worth mentioning, although it's not necessarily new at this point. It is ongoing. Catnon is a 4-arm, sort of pretty complicated trial, but really the questions they wanted to answer is, what's the value of concurrent Temodar and what's the value of adjuvant Temodar? And so this is the most current analysis. And you can see one of the unplanned parts of the study is that they didn't start out looking at IDH, but then they amended the study to look at IDH. So we actually have, 2 populations in the study. And if you're a purist, you probably have 3 populations that they're not even measuring, because an IDH mutant grade 3 astrocytoma with CDKN2A homozygous deletion is actually grade 4. That's not even reflected in this data. But so looking at this, the 2 relevant insights are, one, I think contrary to many people's expectations, there's no apparent benefit, at least in the early readout, for concurrent Temodar. I will say that there is precedent in neuro-oncology for curves separating late. So we look early, we don't see a benefit, but then we look 10 years later at what happened to patients and we say, oh no, there was a benefit, we just weren't seeing it at first. So I don't think this has changed most people's practice, but what it has changed, at least for me, is my willingness to drop concurrent therapy. So if I get a call that somebody's really sick, that they have an infection and people want to delay radiation because they can't do concurrent Temodar, I'm going to say, nope, just start radiation. We won't do concurrent Temodar. Or in the elderly or very frail, I think there's a rationale for not doing it. The other more controversial interpretation of this study is that there was really no significant benefit of Temodar in the IDH wild-type population. This is in contrast to several trials. It's in contrast to the Stoop study, 2005. It's in contrast to the Perry study, the short course Temodar. So I think a better interpretation might be that the effect size was too small to measure with this design that did not intend to separate IDH wild-type and IDH mutant tumors. So how do we put this together? This is kind of generally my go-to strategy. If I have a grade 2 oligo or astrocytoma and I have a complete resection and I know it's IDH mutant, I'm going to try to observe it unless if there's some factor that has me worried that's, I would have to, on an individual basis, consider. And then if there's progression, or when there's progression, then I would reach for vorasidenib. And I would do that before radiation, and this has not really, I think, penetrated. I still get a lot of questions from the community about, oh, we're starting radiation, and is there anything else we should do? And my answer is, don't start radiation, start vorasidenib. If you have a subtotal resection, in some cases I would observe, but I think in most cases I would reach for vorasidenib. Definitely for astrocytic tumors. I think in certain oligodendrocytic tumors, depending on the location, like if it were right frontal and they were residual, I still might observe it for a while. So that's a little case dependent. But in all those cases, when there's progression after vorasidenib, then you kind of go to your old treatments. You go to radiation and chemotherapy. Grade 3 oligodendrocytic tumors. I'm increasingly trying to observe these cases, and sometimes there's pushback because that's not the standard strategy, but I did show you some data to that effect. This is especially, I think, useful for cases where it's a big tumor, there's a part in the center that's enhancing, that part is out. I think that's a case where you could reasonably at least get a 3-month MRI and then kind of keep pushing off the decision. And if nothing changes, there's no reason, I think, to start vorasidenib. To start treatment. For grade 3s, I would favor upfront radiation over vorasidenib. And like I said earlier, for oligos, I would use PCV. For astrocytic tumors, I would use Temodar. So what about the future? Where are things going? This is the STELLAR trial, which I'm proud to say was open at this institution, although I kind of inherited it. I think one of the people that opened it is in the room. So this was a phase 3 randomized study, open label study of eflornithine with lomustine versus just lomustine for patients with first recurrence of an anaplastic astrocytoma. Again, IDH mutation and CDKN2A were not taken into account during study design because that wasn't standard of care. So at the time, they envisioned 2 arms. And the interesting thing about it is the arm that got eflornithine had a much lower dose of lomustine. So for those that remember the BLOB trial, 90 milligrams per meter squared, I think most of us think is not a very effective dose, at least for high-grade gliomas, versus 110 milligrams per meter squared maybe is more effective. And so in a way, the study was stacked against the experimental arm, which I like. So the results, initially look like they're negative, right? So there's no significant difference between arm A and B in either median overall survival or progression-free survival. But if you go back and apply modern diagnostic criteria, you can understand that there's actually 3 study populations in this trial. There's the IDH wild-type patients, who probably had an actual, earlier developing glioblastoma, is what we would call it now. There's the patients that had a true grade 3 IDH mutant astrocytoma, and that would require that CDKN2A/B was intact. And then there's the patients that actually had a grade 4 IDH mutant astrocytoma. So if you look at just the population of grade 3 IDH wild-type astrocytomas, there was actually a significant difference between the treatment arms. So 50% increase in overall survival, doubling of progression-free survival, both highly significant. This is the subgroup. Sorry, this is a cell phone picture from the meeting. But again, they all sort of align in the same way. So what is this thing? Eflornithine is an irreversible or suicide, it says agonist, it should be antagonist. It's a suicide antagonist of ornithine decarboxylase. It was developed as an anti-cancer drug. They thought it didn't work, but it worked great for prevention of hair growth. So it became a cream that you can apply on your face to prevent hair growth, although you need a prescription for it. And it apparently somehow, I don't know how this was discovered, also works for a variety of African sleeping sickness. I had never heard of it before inheriting this trial, to be honest, but it was recently FDA approved for neuroblastoma. I don't know how to access it. I've asked our pharmacy. The data that I showed you is not published. It's certainly not approved by the FDA, but I think in the future, this might be an additional option that we can add on to our algorithm. So maybe that should be the optimal strategy at recurrence. It took about 1.5 years or 2 years for the FDA to approve vorasidenib, and this data is not as strong, so this could take quite a while. I'll stop there. Any questions?
Thank you, Lipi. One question with regards to vorasidenib's efficacy and its impact on extended resection goals for surgery, right? Because historically, the goals of resection have been set by the inefficacy of the treatments that we have. So do you think that this is going to shift the curve a little bit more towards more conservative, less debilitating operations?
I think that's location dependent. If it were me and I had a right frontal tumor, I would want a wide resection irrespective of what I was going to use afterwards. Could probably say the same thing for a right temporal tube in a left hemisphere dominant patient. In terms of how much residual should we tolerate, I mean, I think we always want to come out of a surgery for a low-grade glioma without new deficits. If you're close to a tract and don't know how close you can get, I think that you could consider a 2-stage surgery is probably what I would recommend, because if you come out of surgery and you get a result that it's an oligo, I probably wouldn't do more. If you come out and it's an astrocytoma, or maybe it has a CDKN2AB mutation that makes it a grade 4, then you might want to go back in. So it's location dependent, and I would probably err on the side of getting a complete diagnosis before going for the high-risk portion, even if that meant a second surgery. I'm curious, I don't know, Jerome, is that what you would? Yeah.
I agree, though. I think like all these trials don't fit into the real issue, which is location and symptoms. If somebody has a low risk, completely resected right temporal lesion, I'm not so worried. But if somebody has even a little residual and it's near like speech, motor, or parietal, I think people undervalue how disabling those symptoms are. I feel completely different. And none of our data actually tells us that. So, that really influences my decision. Our options are really expanding.
Yeah. Okay. And now I want to introduce our last speaker, who is the longest tenured member of the Alfred Clinic, except for, of the Ivy Clinic, except for Dr. Cobbs. So Brenda is a wonderful social worker who has been here, I think, 4 or 5 years, 5 years? And leads a variety of wonderful patient groups, is very beloved by patients and the staff. And unfortunately for us, but fortunately for her, is retiring and will be in Colorado this time next year. So we're fortunate to have her maybe for the last time.
Thank you. Thank you, Dr. Bonham.
Good afternoon. Thank you, Dr. Bonham. And thank you for inviting me again to speak to this group, to Dr. Lipback, Dr. Cobbs, and again, Dr. Bonham. I enjoy coming and sharing what I can about social work, and I appreciate that you invite social work to the table. I'm going to see where there I am. Okay, we want to do our go down here. Okay, perfect. Nope, can they?
There we go.
All right. So today I'm going to share information about role of social work working with glioblastoma patients, and particularly similar to what Dr. Sharma was saying about palliative care, is that our glioblastoma patients come into our clinic, and as a team, we meet them where they are, meaning that there are so many psychosocial things going on with the patients that we really, one support system is not going to be for everyone. So we want to really meet our patients where we are. And today I'm going to focus on our patients who are making decisions about returning to work and what their options are. Dr. Bonham, just press to go forward.
Yeah, just arrow.
Arrow, okay. There we go. So again, we're going to demonstrate the key roles for social work as well as communication, our patients and their family members communicating with employers regarding their leave benefits. So one of the things I do want to share, just a broad overview of what an oncology social worker does. So in our IB center, we can help patients with obtaining their advanced care directives and their living wills, durable powers of attorney, the portable orders for life-sustaining treatment, that POLST. One of the things that I'm really proud about in our clinic that we've been doing lately is encouraging and getting permission from our patients to create a proxy for their MyChart account. What that does is that improves communication, it improves opportunities for us to communicate with the families about transportation or really nip in the bud any issues that are coming up psychosocially for that patient. But I'm really proud of our group that we have been looking at that as an option with our patients. We do, as Dr. Bonnet mentioned, we do have a support group that is offered twice per month. It's for not only the patient, but also the caregiver. So we have on average between 5 to 10, I would say, patients and their caregivers per month. It's done virtually monthly, and we have great participation. We learn a lot. It is a true support group where folks are sharing information about resources and just coming to get support from other patients who know exactly what they're going through. One of the things that I do as a social worker is really provide that emotional support for our patients and their loved ones, and that's just by holding space for them. I am part of the team. I am the one that has the capacity to provide active listening, do some solutions-focused problem solving with the patients, and then offer community resources and support. We also have offered in the past peer support resources where we connect patients to other patients who are similar in age, who have similar diagnoses, and that's been very helpful. One of the main things that we see in patients with glioblastoma that's been mentioned before is the financial toxicity. And patients have to decide if they can go to work, if they're the caregiver, do they have to quit work? Do they have to access their leave benefits to care for the patient, getting them transportation to and from radiation? So a lot of things are happening with the patients and their families regarding finances and insurance. Also, we're looking at just a variety of resources that we can provide that are community-based for the patient and their family. That might include home health, chore services, in-home care, and then, of course, we definitely interface and collaborate with palliative care, hospice services, and then we have about a handful, maybe, of patients each year that request the Medical Aid in Dying or Death with Dignity Act, and then as a team, we collaborate on paperwork and supporting that patient with that decision. One of the main tools that social workers, oncology social workers use to target resources for that patient is the distress screen. This is kind of my made-up model here of a distress screen. But the nice thing is that this distress screen comes in 71 languages. So regardless of the primary language of our patient, we're able to meet their needs by providing a distress screen in their language that they can understand, that they can let us know what their needs are. They focus on physical concerns, emotional concerns, social concerns, spiritual or religious concerns, but I will tell you, of the distress screens that come my way, it's the practical concerns that the patients most often identify. And that includes taking care of themselves, others, work, school, housing, finances, insurance, and transportation. So that really is the majority, I would say, of the patient care needs that are identified. So talking about our patients and the financial toxicity and the need to work, I recently attended a wonderful workshop by Cancer and Careers that really identified patients wanted to know, should I tell my employer that I have this diagnosis, that I have cancer? And what I was pleased to hear, what I was surprised to hear actually, was that Cancer and Careers at that webinar identified, as Dr. Sharma did, that that's a personal decision for the patient, that that patient would need to determine the their relationship maybe with their manager, the support that they think they could get from work. But the main topic is financial. And even beyond that, it's healthcare, maintaining their healthcare benefit. So again, that patient, and when I meet with them, we talk about what is the goal and the needs of the patient and the family. What I do recommend to all patients that come to see me regarding their leave benefits is that, if able, to request to take a care partner with them when they meet with their human resources representative, whether that's a spouse, a friend, a union representative, somebody who can take notes. As we know, our folks who have glioblastoma are going through treatment, can have some cognitive decline, can have some issues with memory. So we really want to make sure that any information they're getting from their human resources regarding their leave benefits, someone else is available to help them with note-taking. And one of the other things that Cancer and Career said that I found very important and that I share with all my patients is, do you know how to access your employee handbook to look at the leave benefits? Do you have a physical copy? When you first got hired, did they hand you a physical copy? Is there a PDF? Wherever that copy of that leave benefit or that handbook is, I encourage patients to take a look at that and really understand what their benefits are. And then probably most importantly of all is to get organized. If you're not able, if the patient is not able to organize themselves, have, again, a care partner who can help them stay organized with a file, a folder, something that keeps all of their records together. Because in the long run, it's going to be more beneficial for them to understand their benefits. So going over the types of leave that folks are entitled to, we'll go over this, just kind of this, I'm going to give just kind of a broad overview. And again, any patients, families, I really request that they talk to their human resources or their leave benefits representative to have an understanding what they are entitled to, what benefits they're eligible for. So for PTO, I wanted to emphasize, in Washington State, we have the Washington Paid Family Medical Leave, which is short-term disability. Sometimes folks were under the understanding that they had to spend down their PTO in order to be eligible for Washington Paid Family Medical Leave. The Washington law states that folks do not need to exhaust their PTO before using paid family medical leave. Sometimes patients have been very lucky with their having a shared leave program through their employer. And what that means is that maybe they've exhausted their leave, they haven't worked enough hours to get onto Washington Paid Family Medical Leave. FMLA is an unpaid service or is an unpaid benefit, so they need something to kind of get them through those first couple of months. So what I ask them to do is check with their company to see if they have a shared leave policy. And oftentimes, folks will get leave at the very minimum of what they need to maintain their healthcare benefit. So other employees in the company are donating, a couple of hours per month, and to combine, that helps that patient maintain their healthcare benefit, because that is one of the most important things they say that they want to maintain. TMZ costs money, radiation costs money, transportation to and from radiation costs money. So they want to go ahead and maintain their healthcare benefit as much as they can. Another option would be taking your safe sick or your extended illness bank. One of the things I learned just this year, I've been, like Dr. Bonham said, I've been with the Ivy Center for 5 years, but just this past year, I learned that sometimes caregivers can access their extended illness bank. So we had a woman who worked for a large company ask if I could write a letter on her behalf or fill out a form. And initially I was kind of like, no, that's not possible. And she said, no, it is. I can access my own extended illness bank to care for a loved one. And there were certain criteria that had to be met. And I think having a terminal diagnosis was one of them. Her spouse did have glioblastoma, so she was able to access her extra PTO, her extra leave, in order to care for her husband while also getting a paycheck. So that was helpful to that family. The most important, I think, thing that's happened in Washington State, or there's a couple of other states that have this, is the Washington Paid Family Medical Leave, or that paid medical leave option, also known as short-term disability. So what this does is that it offers you up to 12 weeks of paid leave that could be used either intermittently or continuously. The patient or the family decides how much they want to use. However, to be eligible, you have to have worked 820 hours out of the last 4 of the 5 quarters. But guess what? You don't have to have been currently working in order to access that benefit. As long as, if you're not employed currently, and we recently experienced this with a family member with their daughter who was like in her 30s, and she said, no, I haven't been working for the last couple of months. But she had worked over 820 hours in the last 4 out of the 5 months. So she was able to access those funds that she paid into in order to have paid leave. So I always want to emphasize that with families and patients, is that you don't have to be currently working in order to access that Washington paid family medical leave. And then again, it's medical leave for the patient or family leave for the caregiver. We fill out the paperwork. It takes us just a few minutes to fill it out. We send it to the patient via MyChart. They upload it into their SAW account, and they get their leave paid. So FMLA is the federal program that just is job guarantee. It's gonna protect your job. It's unpaid. So sometimes families use FMLA with their PTO. They use FMLA with their extended illness bank. So they cobble the benefits together. What I want to really point out is that Washington paid family medical leave and FMLA have 2 different criteria of what a family is. The Washington family medical leave provides a broader range of who you can take leave off if you're going to be a caretaker. There is a much broader category. That can include a sibling. It could include a parent, step-parent, somebody who would be, expect you to care for them, maybe a roommate. So Washington paid family medical leave does have that broader definition, where the FMLA, you take leave off to care for a parent, a child, or a spouse. So we always want to make sure that families understand that, those criteria. One of the things that I wanted to mention as well about leave is that sometimes folks, when they decide, I do need to work, I need to go back to work, I'm feeling much better, I could probably work a reduced schedule. So through the American with Disabilities Act, there is something called the reasonable accommodations. And we've completed paperwork on patients' behalf who say, I think if I went to work and we had a lady who worked in a grocery store, she just needed a stool to sit on. She got fatigued. She said, if I just had a little stool to sit on, I'd be okay. We wrote accommodations for her to have a stool to sit down. Another individual identified that she got fatigued in the afternoon. We wrote a reasonable accommodations request for her to have a nap in the afternoon or be able to take more frequent breaks. So things as small as that benefit the patient and support them getting back to work, we're going to write letters on their behalf. We're going to really champion folks getting back to work if and when they can. So the other opportunity that folks have for leave is a long-term disability insurance, and people have to pay into this. You have to have already purchased a policy, usually through your employer, and it pays a percentage of the employer's salary, usually between 50 and 70% of a person's salary. And the good thing about a long-term disability policy, when you first are hired or you enroll through your employer, they can't dismiss pre-existing conditions. However, if you have a diagnosis, so you get a diagnosis of glioblastoma, and then you go and try to purchase a long-term care policy, you most likely would be declined, or you wouldn't be able to purchase that. But again, something to consider with the other family members. You get a new job, really taking into account going ahead and purchasing that long-term disability insurance that's offered through your employer. And finally, the one that we talk about most for our patients with glioblastoma is Social Security disability. So one of the things about glioblastoma and folks who have oligodendrogliomas and astrocytomas are there. That criteria of a cancer diagnosis falls under a compassionate allowances criteria eligibility through Social Security disability. And what that means is the application is flagged so that it's reviewed on a much faster than, say, somebody who does not have this diagnosis. So I always share that with patients. There's nothing that they do to flag their own record. Just that diagnosis alone will have eyes on it much quicker than if they did not have that diagnosis. For Social Security disability, there's two ways they're going to determine eligibility. They're going to determine it through a work test, meaning have you worked enough hours toward it? Are you currently working? When was the last time you worked? And then they also want to look at the duration of work, showing that you've paid enough into Social Security. They have a great little booklet that with a chart that shows you your age and then how many years you would have to pay into Social Security in order to be eligible. So I have books like that in my office that I share with patients on a weekly basis. One of the things about Social Security disability, once you have been receiving benefits for 2 years, you automatically qualify for Medicare. So some of our patients have to weigh out if they get Social Security disability, if they are not still working for their company, if they cannot work, there's going to be a 2-year period where they're not going to have health insurance, or they're going to have to go out on an exchange and purchase health insurance. So again, these extra financial decisions, insurance decisions that folks didn't even anticipate they were going to have to make, weigh heavy on our patients. So we really take a look at really trying to, I talk to our patients about dovetailing their benefits, really understanding what benefits you're entitled to so that you can maximize. You're going from short-term disability to long-term disability to Social Security disability. Maybe you're using your PTO, then you're going to take your short-term disability. So whatever it is that's going to maximize your benefits, we really encourage patients to work with their HR representative to talk about what they can do to extend those benefits as long as possible. Social Security does have work incentives if folks are able to return to work. We have younger patients who come through our clinic with GBM who have been on and off Social Security disability 3 times. So they come off Social Security disability, they work with Social Security all the time, though they never do this independently. But I always let folks know that you can work while receiving Social Security. What they're going to look at, again, you're going to work with Social Security representative on this. What they look at is how much it's not the number of hours you can work, but how much you can earn so that you don't lose your Social Security benefit. So this is something that most folks who have a strong identity with their work, they enjoy their work, they want to go back to work, we encourage them to talk to Social Security about figuring out a way to do that. We have these little SSDI starter kits that help people get organized. I have it on a PDF. You can get it from Social Security. But what it does is it helps people gather their information in order to submit the strongest application possible. Additionally, folks who, again, we're working with people who might have some issues with manipulation, with memory, with communication. If they gather the information, they can call Social Security and make a telephone appointment. It's about a 60 to 90-minute appointment, and Social Security will input the data for you, and your application is done at the end of that phone call. And folks are often overwhelmed about, how am I going to get my medical record? How does that happen? And so what we let folks know is that Social Security will reach out to the clinics that you've identified as the providers, and they will seek medical records directly from those providers. The burden is not on the patient to identify to get their medical records to Social Security. And I share with patients, they're able to obtain their medical data through their MyChart. So it's something that can seem overwhelming at times, but again, with some help and a little bit of organization, the process can go much more smoothly. And then finally, here's some resources for our patients that I often share. about Washington Paid Family Medical Leave, FMLA, SSDI. ALSEP is an organization that helps folks who maybe have gotten a denial from Social Security disability or they have questions. They're a good organization. Another good organization for folks who are working or want to work or want to understand their rights and benefits, Cancer and Careers. And then finally, another organization that I absolutely love and refer folks to is called Triage Cancer, and their legal and resources for legal information and employment. Oftentimes they have free materials, webinars, whatever we can do to provide information to our patient, again, meeting them where they are so that we can target we can target resources to them to help decrease their psychosocial distress given this diagnosis. Any questions? That was a lot of information in a short period of time.
Brenda, thank you.
You're welcome.
That was a whirlwind. I'm curious if you could impart one pearl of wisdom to physicians and APCs, whether they be surgeons or oncologists, for patients who may not have access to resources like a social worker within the brain tumor program. What is the first sort of most important step from your perspective when somebody gets one of these diagnoses in terms of trying to create some financial stability and security for the family?
Sure. So one of the things I would look at would be having the families get on the same page about what their goals are for their finances, for healthcare. And then secondly, I would have the individual, the patient, if they are currently working, set up an appointment with a human resources representative to discuss their benefits and to have a good understanding and to take a care partner with them so that nothing falls between the cracks. We had a gentleman who worked for Boeing, and he came to me with the most beautiful matrix that Boeing had given him about his benefits, when paperwork was due, if he was approved or denied. And so I wish I had made a little graphic like that, but I think the most important thing, Dr. Levesque, that I would share would be talking to human resources and understanding benefits, and then when paperwork is due for that particular benefit, leave benefit, so that they're giving like if it's your office, like if it's neurosurgery and your staff is doing the paperwork, making sure that they're giving that clinic time to complete the paperwork so that their benefits don't fall by the wayside because they didn't get the paperwork to us in time. So I think that's the main thing, just understanding what benefits you have and then how to access them. Yeah.
Thank you. And related to that, what is your message, or what should our message be when patients or their families express concerns about talking to HR and disclosing a potentially terminal diagnosis? Because there's often fear around disclosing that diagnosis.
Yes. The webinar I just attended for Cancer and Careers talked about is taking a temperature of the environment at work. Are you able to have flexibility in, for an example, if somebody was getting radiation, and could they talk to their employer about working in the mornings and then taking time off in the afternoons to get their radiation, and really minimizing the amount of time they're away. But I think we leave that up to the patient to kind of determine what the work environment looks like, what their needs are, what their goals are. And even though it is difficult people said they don't want to feel pitied, they don't want to, there's fear that they might be fired. What we say is kind of, if you really need to access your benefits, you probably do need to express your diagnosis or, discuss your diagnosis so that you can maximize benefits. And sometimes you just have to kind of weigh one thing against the other. But maybe they also recommended if there was somebody else in the underemployment that maybe expressed the same thing or had the same diagnosis or a similar, chronic condition, to talk to a coworker about what their experience was and what they would recommend. But it really would be up to that individual to determine their goals and how to work with their human resources. Yeah. Thank you guys very much. Thank you.
Wow. We've been doing this for 10 years, and every year it gets better. I really want to give a deep, heartfelt thank you to all of our speakers today, those who were here in person, those who joined us from all over the country virtually. I want to thank our audience, both here and online, for tuning in and continuing to support the Seattle Science Foundation and our ability to share these educational programs with the world. And with that, I wish you all a happy and healthy weekend. Thank you.